30 years. Previously, it was a register that used to be maintained by our seniors, and presently we are maintaining the web-based registry since last 5 years. And regarding Indian Musculoskeletal Oncology Society, as you all know, is a national body of bone and soft tissue sarcomas, and is a multidisciplinary society. The members are radiologists, orthopedic oncosurgeons, orthopedicians, pathologists, and anyone who is involved in the sarcoma and bone tumor care can be a member of this. So we have joined hands, IMSOS and West Bengal Orthopedic Association Bone Tumor Registry have joined hands to do this CME. I thank both of them. I request our first speaker, Dr. Chandrakumar Krishnan from Arya Cancer Institute, Chennai. Sir, please come to deliver the first talk.
I would like to thank Dr. Kaushik for inviting me, and I would also like to congratulate him on his bone tumor registry. So my talk is on why do we need specialized training in orthopedic oncosurgery. So I'll talk about what is the current scenario in the resident training program. In India, we have MS and DNB orthopedic course and a diploma in orthopedic course, which are 3 years and 2 years. The purpose of this course is to expose residents to all aspects of orthopedic surgery and prepare them for general orthopedic practice. It includes all subspecialties like trauma, spine, hand, shoulder, elbow, sports, foot and ankle, adult reconstruction, pediatric and musculoskeletal oncology. And there are around 2,500 to 3,000 postgraduate seats in orthopedics in India. And most of these seats are in government medical colleges. And the residents are exposed to what consultants practice there. And very few practice oncology in these institutes. And even if they practice oncology, the number of cases they get there will be very few. And the residents may or may not get rotation during their program. And at the end of the training, the postgraduate is able to do some basic trauma, deal with osteoarticular infections, some basic plasty and basic scopy. And from the musculoskeletal oncology point of view, he might do a biopsy and a curettage. Hardly anyone would have seen a limb salvage surgery during their residency training. And following MS, there are FNB and MCH, which are 2-year and 3-year courses provided by the DNB and National Medical Council. And FNB and MCH is available for all these subspecialties like trauma, arthroplasty, sports medicine, spine, hand surgery, and pediatric orthopedics. And the same subspecialties, fellowships are also available from short-term 3-month fellowships, 6 months fellowships, to 1-year and 2-year fellowships. And the sheer number of trauma, arthroplasty, and all these are very high when compared to oncology. The fellowships in Ilizaro and oncology are also available, but at very few training centers. And the few training centers are TMH, Rajiv Gandhi Cancer Hospital at Delhi, Max Delhi, HCG Bangalore, Max Nanavati, and GCRI. And they also admit only 1 or 2 fellows per year. So what are the inherent problems with learning orthopedic oncology during residency? The incidence is rare and static. It doesn't increase like other cancers where the rate is increasing. And the incidence of MSK cancer is around only 15 lakh. And incidence of MSK tumors is less than 0.5%. So the patient number is less than 7,500. And heterogeneous. There are variety of cancers According to WHO classification, you can see the list includes more than 100 uh, histologies. Each of these tumors behave differently. Our surgery might be the same, wide local excision or a limb salvage surgery. But we should know how to work up these patients, what agents to give, adjuvant or neoadjuvant, and how to prognosticate them, how to stage them. Everything is different for all these histologies. And most of our patients present late and have financial constraints. And in government hospitals, it's difficult to perform a limb salvage surgery, not because of the technical expertise, but because of financial constraints. The processes cost minimum around 1 lakh and goes beyond that, which most of our patients cannot afford, and most of the governments do not support them. And all these patients also need psychological support. There's something called breaking bad news to the patient and the family, counseling them, and to tell them, once you tell it is cancer, they'll ask what chemotherapy, what radiotherapy, is there going to be any hair loss, what about infertility, and what function can the patient expect after surgery. So extensive psychological support is needed from the day of diagnosis. And as orthopedician, we should also know the basics of oncology when practicing orthopedic oncology, how to stage the disease. Each histology is different, whether we need a PET scan, bone scan, CT chest, or do we need any other imaging, MRI of the spine, brain, CT abdomen, pelvis. And neoadjuvant therapy, what drugs to use, what dose, at what interval, all this we also should be well versed, and when to stage the surgery. And adjuvant therapy, radiation, brachytherapy, intraoperative radiotherapy, or chemotherapy and immunotherapy. And as oncologists, we should also know some basic statistics like survival curves, log rank, Cox regression, to understand what papers say and to convey the same to the patient. And from the surgical aspects, it's totally different from what we do in MS orthopedic training. In MS orthopedic training, we have been taught, go directly to the bone, don't worry about bleeding, don't see the vessels and nerves, but it is exactly opposite in orthopedic oncology. We don't see the tumor, so in most instances, we are not seeing the bone, and it should be covered with soft tissue. Meticulous dissection is needed. We have to learn to dissect nerves and vessels and repair if needed. Meticulous hemostasis is needed because already the patients are malnourished. Because of chemotherapy, the hemoglobin is low. So even every RBC should be caught. Then we should learn about the nodal dissection, and we should have creative and novel reconstruction techniques, which is not seen in the general orthopedic practice. And most importantly, what we need is the multidisciplinary support, which we don't need much in general orthopedic practice. From the diagnostic point of view, we need the radiologist and pathologist to help us in arriving at a diagnosis. And from the therapeutics point, we need the medical and radiation oncology, plastic surgery to cover our defects, vascular surgery where we need resection of vessels and anastomosis, surgical oncology, general surgeon and thoracic surgeon to deal with metastasis, and radiology, they help us in preoperative embolization and minimally invasive techniques of ablation, either thermal or cold ablation. And also we have to sit with the engineers and design some creative and novel processes, because the need for this doesn't arise in general orthopedic practice, but often arises in orthopedic oncology practice. And we have to follow other cancers and see what is path-breaking there and try to bring it to our specialty, like isolated limb perfusion, which was for melanoma, has been brought to bone and soft tissue, 3D printing from head and neck cancers and thoracic cancers. We've also started 3D printing, immunotherapy, and other lines of chemotherapy and oral metronomic chemotherapy. So all this is possible only when we are at an institute which deals with all oncology cases. And so what we should gain during this orthopedic oncology training is general surgeon skills and oncology skills. So training requirements and expectations for graduates are expanding, and the body of knowledge and technical applications continue to grow. So that is why we need a specialized training in orthopedic oncology. Thank you.
Just one question. You told I just did other clarification you want. Incidence you told around 7,500. If you explain a bit more.
Yes, sir. Less than 0.5%.
That is the annual or monthly or what?
Annual, sir.
Across India?
Across India, sir.
I think grossly underreported.
Maybe, sir.
Huh?
This is the ICMR data.
In the year 2022.
2022 it is 14.6 lakh cases, sir. Projected to go to 15.7 lakh in 2025.
And that is in the musculoskeletal only?
No, sir. All cancers.
No, I know. No, musculoskeletal only 7,500.
Less than 0.5%. So,
That's my
yes.
That's grossly underreported. I hope. Kaushik, what's your opinion? Huh?
As per the value, it looks like underreporting.
Right. Dr. Gaur? That shows the status of our, because the discipline is new and upcoming, very few are interested. We do not maintain that tumor history because
True.
number of cases in our, I was in the previous lab, Musculoskeletal Medical College, now at IPGM here. There also I and Dr. Gaur used to look after so many cases. Huh? So hundreds of cases I think we have seen, and very few of them come for the active treatment and late stage. I think it's quite a huge number. Okay, that will come on. Thank you.
Thank you, Dr. Chandrakumar, for the excellent overview over orthopedic oncology training, and Dr. Bera sir for interactive session. I request my junior and friend Dr. Muskan and Dr. Wasif to take the course of events forward. They are the DNB residents, secondary DNB residents in Medica Hospitals, orthopedics. Please.
It controls access to opportunities and advancements. With this, we would now proceed with a workshop on focal bone lesions led by Dr. Bhavin Jhakaria, which would then be followed by an interactive discussion session. May I please call upon Dr. Bhavin?
Set everything up. Can everyone come in front? I mean, all right, so thanks Kaushik for calling me here, and it's always interesting to speak on bone tumors. I'm serious, can you all please come in front? Because if there's a small audience and everybody should pretty much be just sitting next to each other, so fill up the sofas and chairs, and those blue chairs are a little too comfortable, you all will all fall asleep, so it's nice to use the bucket plastic chairs. Okay, how many are orthopedic residents here, or surgeons? Oh, nice. And radiologists? Radiologists? Just one. Okay, nice. So when you talked about the incidence of musculoskeletal cancer. What we forget though is that the benign bone tumors don't get captured, the mimics don't get captured. And if you take that entire spectrum of lesions, then automatically we have a much larger group that we are working with. As orthopedics, oncosurgeons, your main focus in the end is treatment, which therefore would involve either surgery or then chemo, radio, etc. So you're dealing with aggressive lesions. The vast majority of bone tumors are still non-aggressive and most of the times to be left alone. And that, to understand it, can be a challenge as well. So I think that's where we will look at. So the plan today, I think I had about an hour and a half or 1 hour 45 minutes or something like that, was to give a short talk on approach to bone tumors, then show you 10 cases where you'll write down the answers, kind of think about them, and then we discuss those answers as well. And since all of you all are orthopedic, residents or consultants, we'll kind of stick to understanding it from an orthopedic perspective. So you need to know that obviously bone tumors can be seen on different modalities. Then we have to obviously identify them, characterize them, biopsy them, and then obviously treat them. And these are the various modalities that we have, of which plain X-rays and MRI are the most important. Plain X-rays have to be obtained in two planes at 90 degrees to each other. Now this is not your concern as an orthopedic surgeon, but when this does not happen in the radiology department, you need to create a scene and you need to say that this has to happen, right? So you have to have an AP and a lateral in all parts of the body except the hip, where you will have a frontal and an oblique. You can please take as many pictures as you want. Doctor, hi, no flash. It's very disturbing, all right? Take whatever pictures you want, but please control your camera, that's all. So this is an absolute must. Sometimes it seems like a no-brainer, but you'll be surprised at the number of times you'll come across X-rays that are only a single view, or you'll have an AP and then some kind of a weird oblique, and what that does is prevents you from understanding or interpreting the lesion well. Now let's look at different scenarios, right? If the radiograph is normal, but the patient has pain and swelling, what will you do? So here is a 14-year-old boy who has pain and swelling in the left gluteal region. The X-ray is plumb normal. So anybody, what do you do next? I mean, you've examined the patient and you found that there is a swelling. So what would you do next? Get an MRI done, right? So that's the MRI. The MRI clearly shows you a lesion. And this is quite typical of a small cell, round cell tumor, and this was a Ewing sarcoma. So don't stinge on getting an MRI done. We find patients who have malignant diseases, people with osteoid osteomas who linger for 2 to 3 years. So on the one hand, we talk of over-diagnosis and over-investigations, but on the other hand, we find that it doesn't get done. So a 14-year-old comes with pain in the thigh, the patient will be told these are growing pains, these are pains related to playing football, etc., for years, like a year, 2 years, 2.5 years, until somebody gets an MRI done and you find marrow edema and a focal lesion there. So as an orthopedic surgeon, if a person has pain and swelling and the X-ray is normal, get a damn MR right away, right? That's the important thing, because it allows you to pick up disease. That's important. If the radiograph is abnormal, then you figure out whether it's benign or whether it's aggressive. And there are just 2 points that you need to look at: the zone of transition and the periosteal reaction. The zone of transition is the transition point between normal and abnormal bone. So if you see that this zone is sharp, well defined, that means that the lesion is likely benign or has a slow biologic growth potential, right? That's the important thing. If you have a sclerotic rim along with the narrow zone of transition, then it is even more definite that this lesion is benign. And in this case, this would be a chondromyxoid fibroma. But when the zone of transition is wide, as you see here, there is no. Hey, you need to put off the light, please. Why did you put it on? That's okay. But this is more important, no? What's going on here? Yeah, that's fine. So when you have a wide zone, right, you can't actually make out a normal from an abnormal area, or even if you do, it's a wider zone, then you basically assume that it's an aggressive lesion. Now it could be osteomyelitis, but in this case it's Ewing sarcoma. So your first step is zone of transition. Is it narrow? Is it wide? The second is periosteal reaction, where you want to see the type of periosteal reaction. So if the periosteal reaction is solid, there is cortical thickening, then it's a benign lesion, as in this osteofibrous dysplasia. But if it's irregular and you find this very shaggy periosteal reaction, then you know it's aggressive. And in this case, it's an osteosarcoma, or sometimes you get this sunray appearance. We don't see this commonly nowadays because patients do present a little earlier when they have osteosarcomas, etc. But nevertheless, when you do see a sunray appearance, a Codman triangle, etc., then you know that you're dealing with an aggressive lesion. So in that first patient that I showed, the apilateral, you can make out here that there is a narrow zone of transition and it has a sclerotic rim. So this particular patient has a benign lesion in the talus. We still need to figure out what that might be, right? So we first said if the radiograph is normal, as a surgeon, if the patient has pain and swelling, get an MRI done, don't waste time. If the radiograph is abnormal, then you make an assessment of benign aggressive and look for signs of classic leave alone lesions. So these are 5 lesions that generally you can leave alone. That is nothing further, generally needs to be done. So that, anybody, do you know what this is? It's a non-ossifying fibroma. This, osteochondroma. This, or a simple bone cyst, either way. But this is asymptomatic, picked up in the gym, went to the gym, had a little pain, got an x-ray done. What is this? It's a benign enchondroma or a cartilage tumor, and you can leave it at that. So when you see these classic leave alone lesions, you don't need to do anything further. And these patients are typically asymptomatic for the lesion. They have been investigated for something else and these have been picked up. The commonest time you pick up a non-ossifying fibroma is that the kid was playing football, had an injury, fell down, got an x-ray done, that non-ossifying fibroma was found. But today you have helicopter parents who do not accept the diagnosis of a 200 rupee investigation and will then say that how can you be 120% sure in my precious little 11-year-old who's got a, how can you say it's not a cancer? So then you'll get an MRI done. Sometimes after the MRI they'll say, but how can you be so sure? You do a biopsy of a non-ossifying fibroma because of this over-parenting and helicoptering and stuff like that. But there's sometimes not much you can do about it, right? So then you need a person like Dr. Ajay Puri to sit down and tell them that either leave my room or listen to what I'm saying, which most of us don't have the ability to do. Then for everything else, you'll do an MR. There's only one radiologist here, so that's the protocol. For all the orthopedic surgeons, there is what we call a Tumour protocol. Ideally, you should make sure this is done in the departments where you work and wherever you get your scans done from. This happens about 10% of the times. 90% of the times we have crap scans, incomplete scans, etc. And then you still have to do the best you can, because you can't make the patient keep paying again and again just because they got a bad scan done the first time. But it matters, because everything that happens in bone tumors, the first instance is the most important. The first surgeon they see, the first scans that are done, the first biopsy that is done, and the first surgery that is done determines eventually whether the patient lives or has a poor outcome when it comes to malignant tumors. It's entirely a lottery for the patient. If the patient lands up with the right person, it's great. If the patient lands up with the wrong surgeon or a wrong diagnostic center, the patient's finished, right? That's pretty much what happens. Anyway, so with the X-ray and the MRI, we now try to come to a diagnosis. So you've got the X-ray, you've made an assessment of benign aggressive based on zone of transition and periosteal reaction. You've got the MRI done, and now you say, let's figure out what this is. So there are certain rules, and as orthopedicians, you also need to remember these rules, and obviously radiologists need to know them as well. And the first rule is that age matters. So this is a 64-year-old with thigh pain, and you can clearly see a sclerotic lesion here with irregular periosteal reaction. You can see the focal lesion on the MRI. Anybody, what do you think this is? Is this an osteosarcoma? Is this metastasis? Is this osteomyelitis? Is this a chondrosarcoma? Anybody? Mets. And you can say this even without seeing the images. So if somebody called me and said, I have a 64-year-old man with a focal lesion in the diaphysis of the femur, I'll say, it's fine. It's almost always going to be metastatic disease, right? And that is just the power of statistics. Secondary bone tumors are more common than primary bone tumors by a factor of 100 to 500 above the age of 35. So the moment somebody elderly, let's say 50 years old, comes with a focal bone lesion, the chance that that is Mets, myeloma, lymphoma is 100 to 500 times more than it is going to be a primary bone tumor. And it completely changes the management, right? Because if you assume that it's Mets, myeloma, lymphoma, then you might land up doing a PET CT, or you might send the patient off as a surgeon to a med-onc or to another physician who can examine the patient to figure out where the primary might be, or you might do it yourself. That depends on where the situation is. But this patient was a CA prostate, and we biopsied this lesion because the patient was unwilling to get any testing done. The patient says, I have a lesion. Even if it's metastatic, prove it on a biopsy, then I will figure out what's happening. So we biopsied it, that's fine. So that's the rule, and please remember the rule. And so by extension today, if you were to believe it's Mets, myeloma, lymphoma, you'd pretty much go and get a PET CT done. Then you will use the X-ray and the MRI to reassess the biologic behavior, location, matrix. Again, these are things you have to know. You have to mug these up. You have to inherently know these, or have a resource next to you that you can refer to when you have patients like this. For example, some tumors are purely epiphyseal, some are epimetaphyseal, some are metaphyseal, some are diaphyseal, and you have to know this. There is no getting out of it. So, when you have an epiphyseal tumor with a narrow zone and a sclerotic rim, so you know it's a benign tumor in the epiphysis, in the unfused skeleton, you already have the diagnosis. Anybody? It's a chondroblastoma, right? And it's T2 dark and there's marrow edema, so you have the diagnosis. You have an epimetaphyseal tumor reaching the articular surface, narrow zone but no sclerotic rim, right? This tumor doesn't have a sclerotic rim, and T2 dark, we know the diagnosis, right? It's a giant cell tumor. You have a metaphyseal tumor. Now it's not epimetaphyseal, it's purely metaphyseal, trabeculated, sclerotic rim, so we know it's benign, right? And it has fluid levels on the MR which are uninterrupted. What is this? Aneurysmal bone cyst, right? Very good. You have a diaphyseal lesion in a young patient, extensive marrow edema, some periosteal reaction, but you don't have a cortical break and you don't have extra osseous spread. This can be a little tricky, but anybody, what is this? Bingo, LCH. Right? So, these are the tumors that you have to just know about. I mean, you can't keep referring. You obviously can. If you don't remember everything, then you need to have a resource you can look at. But basically, this is how it works. So that was in the longitudinal plane. Then you have location in the transverse plane, right? So it can be central medullary, juxtamedullary, cortical, and juxtacortical. So central medullary is this. Anyone, what is this? We already saw one example. This is an enchondroma or an ACT, whatever. This we've already seen is the juxtamedullary. See the difference. Central medullary, juxtamedullary, and that's a giant cell tumor. This is cortical. Anyone, what's the diagnosis? Osteoid osteoma, right? This is also cortical. Right, it's got a sclerotic rim, narrow zone, so benign, and this is a classic appearance of cartilage, right? So on a contrast study, if you see puddling and nodular enhancement, so cartilage tumor that's cortical with and benign. Anybody? Chondromyxoid fibroma. Yeah. So periosteal will be surface. This is cortical, right? That's how it is. This is juxtacortical, and juxtacortical, and you can see the lifted periosteum, but look at the X-ray, shaggy, irregular periosteal reaction. So you know this is aggressive, you know this is malignant. If this is a malignant surface tumor, then the commonest would be surface osteosarcoma, right? Yeah. This is juxtacortical, right? Again, this is on the surface, bone forming, does not involve the underlying marrow. Anybody? Parosteal osteosarcoma. So this is how location, central, eccentric, cortical, juxtacortical makes a difference. Then there are some tumors that typically occur in specific locations, right? So you can see the list here. For example, you see an osteolytic lesion expansile in the phalanx. This is almost always enchondroma. Or you see a humeral lesion with a fracture and a fallen fragment. This is almost always a simple bone cyst, right? And you see a tibial lesion, immature skeleton, cortical with cortical thickening. This is osteofibrous dysplasia or OFD. So these are very typical things that we see. And then there are some other matrices that we look at. So what did we see up to here? We were looking at typical locations, and we looked at longitudinal, epimetadia, central, juxtamedullary, etc. Then some tumors that only occur in some areas. And now we're looking at some other specific signs. So on the X-ray, you would have an osteoid matrix, chondroid matrix, ground glass, etc. On the MR, you can have a dark lesion, fluid levels, etc., etc. So this is cartilage. Now cartilage tumor, benign, narrow zone of transition in the phalanx is obviously an enchondroma. But you have cartilage. This is the rings and arcs, irregular margins, angry looking. This becomes a chondrosarcoma. We've already seen the osteochondroma, and that's the cartilage cap. We'll talk about this later in one of the cases. And here you can see that same angry looking rings and arcs cartilage, and you can see the cartilage thickness greater than 2 centimeters, which tells us that it's a chondrosarcoma. Now there are times when you don't have a matrix, you don't have a cartilage matrix, you don't have an osteoid matrix. It just looks very clear, like you see in this humerus lesion, this distal femur lesion, and this proximal femur lesion. All of them are benign. All of them have narrow zones of transition and sclerotic rims. But what are they? That's where the MRI helps. This is bright, fluid, simple bone cyst. This is fat, right? Just like the fat in the rest of the bone. So this is a lipoma. And this is fibrous dysplasia, dark with a secondary ABC component. This is a non-ossifying fibroma where, as I said, the helicopter parents got an MRI done. We found these T2 dark areas and we actually biopsied one of them because there was just no way out. They were so completely out of control. The child had no problems, but it's never the child who has a problem, isn't it? So this is the list of T2 dark lesions. And you have to know these things because on an MRI, if you have a T2 dark lesion, then it will be one of these. And then you can look at the other characteristics, the X-ray, the location, the age, and then figure out where it stands. So again, here we have fluid levels. Anyone? Diagnosis? Right. So ideally, I mean, people would say this is an aneurysmal bone cyst, but that's the X-ray of this patient. It's an aggressive tumor, a wide zone of transition, irregular periosteal reaction, and osteoid. So this is an osteosarcoma. So this is a telangiectatic osteosarcoma, and there is a rule here: never interpret an MRI without the X-ray, ever. Because this was actually reported as an ABC by one of my colleagues in Mumbai because they hadn't seen the radiograph or the X-ray, and then eventually when they did, it was quite demoralizing because it's also a reputation risk when such a report goes out to the orthopedic oncosurgeon who pretty much knows this is not an ABC. But this is an ABC. This is a very well demarcated lesion, and when you see the X-ray, you see this sharp narrow zone of transition with a sclerotic rim, benign tumor with fluid levels. You put the two together, you have an answer. And so that's the rule you need to follow. ABCs can be of different types, and this patient that we looked at who had this benign lesion has an osteoid matrix. So benign lesion osteoid matrix would typically be an osteoblastoma, and you can see these secondary ABC levels within as well. Then we have different other findings like trabeculated expansile. There are very few tumors that are trabeculated expansile, and this is the list here. So you have an ABC here, you have another giant cell tumor, but that's metaphyseal giant cell, you could call it an ABC, and this is a desmoplastic fibroma. But basically you have about 5 or 6 tumors that are trabeculated expansiles. If you see an entity like this, then your differential is limited. You also have another group of tumors called the benign aggressive lesions. What are benign aggressive lesions? They look benign on the X-ray, but they look aggressive on the MRI. So here you have a lesion that has a sclerotic rim, right, and a narrow zone of transition, so you're going to say this is benign. But on the MRI, there's extensive marrow edema, right, but no cortical break, no extraosseous spread. So benign aggressive tumor is just that. Benign looking on X-ray, on the MRI you have marrow edema, periosteal reaction, effusion if it's intracapsular, but no cortical break or extraosseous extension, because once that happens then it becomes either osteomyelitis or a malignant tumor. So anybody, what is this? LCH, right? That's what it is. So that's the list of benign aggressive lesions. Very useful, because if you see a benign looking lesion on the X-ray and you see an angry looking lesion on the MR but without a cortical break or extraosseous extension, that's a limited list that you have here, and it's quite easy then to come to a diagnosis like this one. In fact, you have the diagnosis directly on the X-ray, right? Epiphyseal sclerotic rim. So what is this? Chondroblastoma, and you can see the marrow edema and effusion because it's benign on X-ray, aggressive looking on the MR. Obviously, infection can mimic all of this. So you have a lesion here that has a sclerotic rim, but there's some ill-defined sclerosis as well. So you know you're dealing with a benign lesion, but look at the MR. You can see a clear abscess here, but this still needs to be biopsied. And I think what I haven't really been focusing on is that unless you have a leave-alone lesion, each of these lesions needs to be biopsied to prove what they are. And so you would biopsy this as well, and that also tells you that every time you biopsy a lesion, send material for culture sensitivity and gene expert, because in our country you can never rule out tuberculosis as a cause of a lesion in the bone. All right, and then of course do the biopsy, and that we have a talk on biopsies, right, Kaushik, coming up? Yeah, so we don't talk about this. This is actually for radiologists, but I think orthopedic surgeons also need to be a little careful about what they do based on the reports you read. Now, a lot of radiologists, right, they do everything. They do brain MRs, they do ultrasound of the fetus the next half an hour, then they're coming back and doing a CT brain report, and then they're looking at an MRI of the knee. So when you're doing all of that, you're a general radiologist knowing a little bit of everything, you don't have expertise. And you can pretty much do a good job 80% of the times. But as an orthopedic surgeon, when you read a report, you need to kind of know what the expertise of the radiologist perhaps might be. Otherwise, this is what happens. So here is a 52-year-old man, left hip and thigh pain. And I'll ask all of you, aggressive or benign? Wide zone of transition, right? Osteolytic and sclerotic areas, going all the way long segment. I think we would assume this to be aggressive. That's the MR. Anyone? Diagnosis? So you have T2 bright, lobulated, some cortical thickening, no marrow edema, and anyway, I've said here also, it's typical of cartilage. So this is a chondrosarcoma. This was reported as osteomyelitis. Fine, the radiologist reported it as osteomyelitis. The radiologist ideally should have said, I don't know what this is. Just describe the lesion and leave it. Say, I don't know what it is. You figure it out, or you do a biopsy. But the radiologist actually said, this is osteomyelitis. Now, when the radiologist is osteomyelitis and you as an orthopedic surgeon say, bingo, go in and start curating this, they curated it. Then they put a nail and a screw here. No organism was found on the biopsy, and we still don't know what happened to the histopath, whether it was done, not done, or after it came, the surgeon got scared and tore it up and told the patient everything's fine. We don't know. This patient comes back with this, right? This is a recurrence, bad, goes all the way, and eventually, Chetan had to do I think a hind quarter, forequarter, whatever it is that you would do for this patient. Perhaps a limb salvage would have worked the first time. Perhaps this patient would have had a better quality of life, but the radiologist screwed up, the surgeon screwed up, both then blaming each other. But at the end of the day, it's equal blame. You cannot, as an orthopedic surgeon, rely entirely on the radiologist's report unless you know what is the level and depth of knowledge of that radiologist. And if you don't know, assume that that person is a general radiologist who doesn't have the depth. Good radiologist, everything's fine, but you don't have the depth of knowledge, so you don't know. You see these kind of lesions once a year. How do you know? So I keep telling the radiologists when I'm talking to them, just leave it, describe it and leave it. Don't give a diagnosis if you don't know what it is. But it's equally on the surgeon that you also need to apply your brain and make sure that you biopsy everything first before you go ahead and start curating something like this. And then this patient has had a recurrence recently as well, and is probably just going to die in the next year or two, when he could have led a reasonably good life. So it's just, when you see these kind of things, it's just terrible. Anyway, some of you, I run this website if you all are interested. It's a very niche thing. It's called bstneoplasms.com. Everything's free, but once in 3 weeks or so, whenever I have the time, I put up a new case and then a video discussing it and stuff like that. So that was the plan. Uh, to just kind of bring in an approach to bone tumors, you start with radiographs, obviously. If the radiograph shows a leave alone lesion, then actually leave it alone if you can. Else, do an MR, use the correct protocol. Interpret the X-ray and MR together and keep age in mind. Very, very important. This is for the radiologist. You don't know what it is, say you don't know what it is. But as a surgeon, if you don't know what it is, biopsy it. Or ask somebody else who you think might know better. But don't go in and start curating something just because it seems to be so easy to curate it. And that's what you said, right? If the training isn't there, then the only thing that a general surgeon knows is to go in and curate stuff. Don't do it. It's not right. And then obviously plan, do the appropriate biopsy. There are rules for doing the biopsy, which will be discussed. Suman, you're taking the lecture on biopsy, or Kaushik? You're doing it. Right. Perfect. All right. Thanks. Any questions, comments, etc.? Thank you. Yeah.
Excellent presentation, sir. Okay, I have heard so much, but the presentation make understanding very easy. Just one comment I'd like to make, that it's the orthopedic surgeon's responsibility is much more, I think, because we can see the patient. So compared to radiologists, I have not doing, our responsibility is much more because they have not the access to the patient. So it's the clinical course which decides. Even there are best radiologists may not be able to. Then most of the time, it's little, very rightly, clinical correlation is needed. So we as clinicians who have the access to the patient, they have much more responsibility in fixing up the things.
Exactly, and that is why that lesion shouldn't have been curated by the surgeon if the surgeon had seen the patient properly. So that didn't happen.
So, nice presentation.
Thank you.
But for myself actually, how to differentiate the chondroid and the osteoid matrix?
Are you
The
here for some
extent-
time? Are you going to be here for some time?
Yes, yes.
Yeah, I'm doing all of that. We still have cases to show, and there's a whole thing happening. I will address that. I will show you cases and examples. Yeah.
You advise contrast in all the cases?
I do. I mean, I know that there are enough times we don't need it, but I think it's just safer in our country to have contrast in every patient.
So I have a second question. Sorry, sorry. You told the protocol that after MRI, the CT or PET CT, if you see. Now, if you mean the PET CT is not always available in this part of most of the part.
Good.
So, what CT will you like to HRC thorax as well as CCT whole abdomen or technetium 19
I have
bones
just listed the various modalities that you can potentially use in bone tumors. X-ray, MR, CT, PET CT. That's not the order in which we do things.
No, I'm not thinking about order. Say I have not the access to the, I think it has been, it's a malignant. So obviously there is a need to see the other sides there.
Oh,
as
for
well.
staging.
You know,
Yeah.
it's just, so what do you suggest that this is the which minimum, say, technical 99 bones can be better, or
No.
compared to
So-
that CCT whole abdomen at least with plus HRC thorax, what you suggest if PET is not available there?
So,
I cannot put him embarrassed. The answer is, it is better, particularly for the malignant tumor, it is better to send the patient in a well-equipped center, not by orthopedic surgeon doing something and
what's an OLEQ?
well-equipped oncology center.
Sorry. Yeah, I'm sorry. I didn't get that.
That's not available. Because
No.
most of the
So,
time they could,
to answer the question, right? If you have a malignant bone tumor today, the standard of care is to do a PET CT for staging, whether it's osteosarcoma, Ewing sarcoma, not for chondrosarcoma, but for many of the others. If you don't have access to a PET CT, or if the patient cannot afford, then you would do at least a CT chest, abdomen, pelvis, and a technetium bone scan, because that would at least give you some sense of what is the extent of disease in the body. But that's based on what is available and not available. So ideally PET, but if not, then that's that. Yeah.
So this treatment that after age of 30, any bone lesion, and I mean most of bone lesion will be mets myeloma and lymphoma. Is it true for sacrum as well?
It's true for the sacrum as well. Yeah. So I assume you're talking about the fact that slightly in the older age group at 40, 45, you can still get chordomas and chondrosarcomas and stuff like that. But as a rule, yes. And sometimes if you really think about it, it doesn't really matter, right? If I have a sacral osteolytic lesion, the first thing I'm going to do is biopsy it. It doesn't matter what the hell I think it is. It is only relevant what I think it is when the pathologist comes back and says, I don't know whether this is cartilage or chordoma. Then you go back and start looking at it and trying to figure out whether you can help the pathologist, more in terms of what it might be. But that's pretty much it. Okay, if you have a pen and paper, can you start writing down answers for yourself?
Sir, one question.
Yeah.
Sir, while describing the aneurysmal bone cyst fluid levels, you just uttered the term uninterrupted fluid
Uninterrupted.
levels. So, what do you mean by interrupted fluid levels and what is the implication?
So if you have an interrupted fluid level, that means that there is some soft tissue which is there, something extra. And when there is something extra, chances are that it's not a primary ABC. And you have to go in and biopsy that area. And I'll tell you where that implication comes in. Let's say that you have a distal humerus ABC. If you were 120% sure it was an ABC, you would go in, perhaps do a frozen, or maybe in a center like mine where I don't even have the ability to do frozen, I would take that call and then inject at the same time, right? You biopsy and inject so that in one procedure you can do that. If you don't have that uninterrupted fluid level, you wouldn't inject. You would first biopsy it, wait for the result, not even on frozen, because on frozen you can have an ABC component and the pathologist might pick that up. And then based on the histology, you would then decide what treatment to be given. This is especially a problem with clear cell chondrosarcomas, which can sometimes have fluid levels. Or you could have a chondroblastoma with an ABC component presenting purely as an ABC, that one little tiny 5 millimeter chondroblastoma sitting, interrupting something. You have to be, so unless it's like 120% ABC, you have to assume that it's not and then take it from there.
Regarding biopsy, sir, what is the, how will it decide from which part of the tumor which should be biopsied on the image basis, on MRI basis?
So solid component always over cystic. If I have a PET, then the brightest or the component that lights up the most. If I have a dynamic contrast MR, then the area that enhances the most. These are the areas that you would biopsy over necrotic cystic area.
So as a orthopedic surgeon, oncologist, it's difficult to us to mark which place. If it better in pre-op when the radiologist do the MR, they will point out this part you should take the biopsy, in my opinion.
Okay, but for that you need the radiologist to know all of these things. So if it's done here, the MR in this hospital, and you're working here and the radiologist is here, then it's very easy to do. But if the MRI is done in some diagnostic center, then how can you expect them to mark it for you and tell you where to biopsy and things like that? That's not going to happen. Yeah, they don't even know that a biopsy is to be required and stuff like that. And then, there is all that stuff of how to approach, where to approach, the rules you have to follow. There's so many things to it. And then, it also comes down to, if you know from the beginning this is inoperable, then no rule matters. You can just biopsy from whichever is the easiest path to biopsy, because it makes no difference if you're seeding it or not seeding it, right? If you're almost sure that it's Mets myeloma, lymphoma, then again it doesn't really matter, because if you're not going to ever operate on the patient, then what difference does it make how you biopsy it? If it's 120% benign lesion, then the route again doesn't matter. Then you use the easiest route possible. There are so many things to it. And you can't expect a general radiologist to mark all these things. You have to read your own MRs as an orthopedic oncosurgeon. There is no way out of that.
So sir, this workshop should help us from where to do the biopsy
But he's got a whole lecture today on that. So you have an orthopedic oncosurgeon telling you as an orthopedic oncosurgeon how to biopsy. So. All right. So pen and paper. We have 10 cases. Can you? Yeah. Go ahead.
Sir, is it as a rule every infection should be biopsied and every
Yes.
tumor should be cultured
Yes.
in earlier stages?
All right, let me put it this way. If I'm speaking to a general radiology crowd and a general orthopedic crowd, yes. Obviously, there are exceptions to the rule. I mean, if I know for sure that's a cartilage tumor, because I know I've been doing this for 25 years, and I have absolutely no doubt, I may not waste my money and time and the sample on that. But then that's a reasoned call that you're taking after you understood the entire situation. But the blanket rule remains blanket. So for all practical purposes, you always culture what you biopsy or whatever histopath you get, and always do histopath in even all infections and stuff like that, because you're never sure. I mean, how many times in TMH we've seen necrotic lymphomas that looked like infection, 3 biopsies done, all negative, and then somebody did a 4th one, extensive, etc., and then you picked up the NHL in the bone. So the rule exists. Obviously, in medicine, there are exceptions to everything, but that exception decision should either be taken in an MDT or by somebody who's been doing this for such a long time that, you know, it's intuitive and you know exactly what you're doing. So that's how it is. It's like the same conundrum. You biopsy what looks like an LCH. Do you inject it with steroids at the same time or not? Or do you wait for the result to come and then inject it? And these are difficult questions to answer. I mean, we don't, yeah. Okay, just 10 questions. 16-year-old had a football injury to the ankle. This is the lesion on the X-ray. That's the MR. If you want me to show it to you again after I show you the choices, let me know. That's the CT. These are all very simple. If we need these lights out, please. Yeah. Perfect, thank you. That's the CT. And these are your choices. Is it non-ossifying fibroma, osteofibrous dysplasia, not dysplasma, sorry, chondromyxoid fibroma, or osteoblastoma? What do you think this is? I'll show it to you again. That's the X-ray, that's the MR, that's the CT, all right? Okay. Second question, 23-year-old with pain in the right arm, just the X-ray. That's the AP, that's the lateral. These are your choices. Osteomyelitis, osteoblastoma, chondroblastoma, and Langerhans cell histiocytosis. That's the X-ray. These are your choices. Third question. 30-year-old felt a non-painful swelling along the dorsum of his hand. So that's the X-ray, that's an AP, and that's an oblique, because you can't do a lateral for these. That's the MR. T2 axial, T2 sag, T1 coronal. That's the histopath. So as an orthopedic oncosurgeon, you have to know a little histopath, right? Picking up osteoid, cartilage, round cell, giant cells. Alright, what is the likely diagnosis? Is it enchondroma? Is it spina ventosa? Is it fibrous dysplasia? Or is it simple bone cyst? Okay, fourth question. 14-year-old felt a bony hard mass in the upper arm at school, otherwise asymptomatic. That's the AP, that's the oblique. Simple, just on the X-ray. Is this BPOP? That is bizarre parosteal osteochondromatous proliferation? Is it osteochondroma? Is it parosteal OGS? Or is it myositis? So I'll just show that to you again. All right. Fifth question. 30-year-old comes with minimal right hip and proximal thigh pain. That's the frontal. That's the oblique. Then we have the MR as well. T2 Sag, T1, they are all labeled. And then the CT, which is obviously the absolute diagnostic image here. So what is this? Simple bone cyst, chondrosarcoma, osteosarcoma, or fibrous dysplasia, right? So I didn't tell you this, but those who actually answer correctly, I think Kaushik is going to take them out for dinner to the Hyatt tonight, right? So if you haven't been answering, too bad. Sorry. Sixth question, 31-year-old with pain in the knee. That's the X-ray. That's the MR. That's the CT. MR, CT, and the histopath as well. Actually, the histopath is classic. So if you get that, you've pretty much got the answer. All right. So here it is. Is it GCT, chondroblastoma, osteosarcoma, or ABC? All right. Seventh question. 18-year-old with pain and swelling around the knee. That's the AP. That's the lateral. That's the MR. You can see how much the X-ray underestimates the pathology, isn't it? That's the histopath. Is this chondrosarcoma, Ewing sarcoma, lymphoma, or osteosarcoma? Not even giving a choice of a benign lesion. This is clearly malignant. The only question is which one of these four is it? Eighth, 34-year-old with pain in the right shoulder following an exuberant overhead, shoulder press in the gym. So that was the X-ray that was done first. Then you have the MR. Then you have the PET. Which I detest in these cases, but anyway, his gym injury related pain subsided after 2 weeks and he has no symptoms, no tenderness, no pain. That's important for you to make a decision here. So what is this? Is this an enchondroma? Is this an atypical cartilaginous tumor or ACT? Is this a grade 1 chondrosarcoma? Or is this a high grade chondrosarcoma? Right? I'll show it to you again because I think it's important. X-ray, MR, PET, subsided, and then this. And I'm going to discuss this because actually nowadays this problem is perhaps commoner than many of the tumors that we actually see, both here in the distal femur, proximal tibia, and the fibula. But the fibula is a different ball game anyway. So, ninth question. 50-year-old's pain and swelling, dorsal aspect of the forefoot. She has no history of current or past disease of any significance, right? So that's the X-ray, and she's 50 years old, so you know what the rule is now. But then you could also have an exception to the rule, so how do you know what that is? So is this METS, CMF, enchondroma, osteomyelitis? And I'll show you the X-ray again, because there are clues on the X-ray as to what this might be. 10th question, this is a tricky one. This is an 8-year-old girl who presented with pain in the wrist, and radiograph showed a narrow zone of transition and a distal radius osteolytic lesion, right? So I'm only showing the MR. That's a metaphyseal lesion you can see here, and then of course the rest of the findings. What do you think this is? Is this LCH, osteomyelitis, chondroblastoma, metaphyseal, rare but can happen, and chronic non-bacterial osteitis, CNO? So you have to figure out which one this is. That was it, 10 questions, and we can keep the quest papers to yourself. We're not correcting them or anything. We could have run a quiz online with an ARS, I guess, but it's okay, it's fine. It just gives you stuff to think about. So let me pull out the answers. So, will people take up the cases? Are you all ready to discuss? How does that work? Or are you too scared or whatever? No, I'll ask you. How many people will take up cases? We have 10, if all 10. Kaushik, okay, I'll give you the hard one then. Yeah, 1, 2, 3. Are you an orthopedic? No, okay. So just raise your hand, right? I mean, it's fine. We'll just take up as they go. Alright, so let's start with you. Question 1, 16-year-old had a football injury to the ankle. This was the X-ray, MR and CT, and this was the answer. What do you think this is? Why do you say that? You're right. So why do you say that?
Sir, it was first of all a benign lesion.
Perfect. So sclerotic rim, narrow zone of transition. Excellent.
So looking at the original, the site of origin, it was a cortical.
It is cortical.
A
See
cortical
that, right?
site of origin.
Yeah, it's cortical lesion, so that's perfect. Yeah.
In an 18-year-old benign lesion of
Perfect.
cortical origin.
So this is an X-ray diagnosis. You made it, but like happens now, an MRI was done and it's a T2 dark lesion. So when it's dark like this on T2, and as orthopedic oncosurgeons, you have to make sure that these are non-fat sat images. You need a conventional regular T2. So T2 dark is fibrous, so you know that non-ossifying fibromas are fibrous tumors. The CT is absolutely characteristic, showing you the same thing, a cortical lesion here. And so the answer is non-ossifying fibroma. Now let's look at the others, right? What does osteofibrous dysplasia look like? This is what it looks like. It looks like a giant non-ossifying fibroma, but it's in the tibia, along the anterior cortex. This is the location for 99% of OFDs in the body. 1% of OFDs may occur in the proximal femur, sometimes in the humerus, radius or ulna, but 99%, for all practical purposes, OFD occurs in the anterior cortex of the tibia. Why, what, we don't know, but it is just what it is. And the differential there is just one, and that's adamantinoma. And then there are points to differentiate one from the other. But here, you can clearly see narrow zone of transition, sclerotic rim, anterior cortex, and it really just looks like a giant NOF. So whenever you see what looks like a non-ossifying fibroma, but in the anterior cortex of the tibia, call it an osteofibrous dysplasia. Often the only symptom that the patient has is an increased swelling along the anterior aspect of the leg. If there is no pain or anything, don't touch the patient. Leave the patient alone. There's nothing to be done. We saw this case earlier. It's a cortical lesion, sclerotic rim. Little tough to diagnose, but you see marrow edema and periosseous edema. Let it be. And that tells you it's a benign aggressive lesion, but this is cartilage on the contrast study. So that's why it's a chondromyxoid fibroma. And this is again a cortical lesion. You can see it beautifully here with an osteoid matrix, right? So this can be tricky, and we'll come back to that question the doctor had asked us to, can you clearly always differentiate an osteoid from a chondroid matrix? In larger lesions, yes. In smaller lesions like this, sometimes it can get tricky. But when you see a cortical lesion like this, marrow edema, you're really just stuck in terms of an osteoblastoma. So you've seen a matrix here and you know what's going on. So that's your diagnosis. So the answer is a non-ossifying fibroma, and I just showed you some examples of the other tumors as well. In some other non-ossifying fibromas, here's the MR, again T2 dark. You can see how many MRs we do for non-ossifying fibromas. This patient was symptomatic, possibly had a microfracture, so you see some marrow edema here, and the patient was biopsied as well, because then they said if the patient is symptomatic, what if it's not a non-ossifying fibroma? And this is apparently characteristic histopath of non-ossifying fibroma. Some stuff here, but it's pretty much it. Again, a large one. And I'm just showing images, because these go into your head and they remain there, and the next time you see something becomes easier. Again, T2 dark and just a little larger. And sometimes, very interestingly, you get two leave-alone lesions in the same patient, right? So you've got an osteochondroma and you've got a non-ossifying fibroma in the same patient, and both are to be left alone and nothing further needs to be done. And again, see the T2 dark appearance of this. Okay, so second question, who will take it? You'll take it? Yeah, perfect. 23-year-old with pain in the right arm. This was the AP and the lateral that we had shown you. These were your choices. So what's your diagnosis? Okay, can you describe the lesion? Got it. Use the mic if you are comfortable. So benign or aggressive? Benign. Okay. So cortical thickening, looks solid, buttressing, etc. So benign lesion. Anything else that you see here? So I think the challenge is that you're seeing the cortical thickening, but have you appreciated this little small hole? Yeah, see, so once you pick that up, then there's no doubt, right? So you've got an osteoma here, and it's actually that simple, right? See, osteomyelitis will be ill-defined. Chondroblastoma is anyway epiphyseal, and LCH is cortical juxtamedullary, but you would not get this amount of cortical thickening. So just to show you some examples, I think this we'll skip. So that's a chondroblastoma, epiphyseal, humerus, a little bit of ABC component, a lot of marrow edema here. Sit. And I'd already shown you this LCH in the diaphysis, but it's intramedullary, right, with a lot of marrow edema. So that one is a typical osteoid osteoma. So this was the CT. This is called the vessel sign, where you see one prominent vessel. You also see this little bit of a osteoid matrix within. That was the MRI which identified that. We did an RFA. It was quite simple. And this is a common 10 to 20% of all primary bone tumors, typically 5 to 25. Mostly proximal femur, etc. And in India, they all get pain around 4 a.m. in the morning. Obviously, that may differ in other parts of the world, or maybe not. And they all respond to salicylates and things like that. So, but the average time it takes for a diagnosis to be made after the onset of symptoms in our country is 18 months to 24 months. It takes that much time in most instances. Yeah? These are the various findings. this is an acetabular lesion that we had seen. Cortical here, that's along the anterior aspect, extensive cortical thickening, and this is the dynamic contrast where you see rapid uptake and then washout, which confirms that this is an osteoid osteoma. See the extensive marrow edema. So we just went ahead and ablated it and the patient is absolutely fine. These are the different methods of treatment. Drilling is done by pediatric orthopedic surgeons. If they get the patient in their hands, they don't leave them. I don't know why they want to drill, but they do it. Then there's RFA, there's cryoablation, and there's MR guided focused ultrasound. But I think the most elegant way of treating osteoid osteomas, the fastest, quickest, simplest, takes 5 minutes to kind of burn these, and that's pretty much it. Cryo should be used when access is a problem, and MR guided focused ultrasound just takes too much time and is too expensive, and that's pretty much it. All right. Cool. Then it's usually an osteoblastoma. Yeah. So usually anything more than a centimeter we would call osteoblastoma, and often the treatment remains the same. You would still ablate it, but the problem is the larger the lesion, then the ablation has to be multi-level. It increases the time you have to go in at 2 different levels and things like that. So the chances of recurrence become higher. Yeah, that's the problem.
Sir, in osteoblastoma, have you encountered some situation like a double nidus in osteoblastoma? Do you have any?
Double nidus, yeah.
Many times in the reporting from the CT scan from the radiology, we see they have reported a dual nidus in the osteoblastoma.
You should ask that radiologist only what they mean by a dual nidus. I'm now thinking, I have never seen one or heard of one. I mean, theoretically it's possible, but no, never. Yeah. No. Okay, third question. This was a non-painful swelling dorsum of the hand. Who's taking this? Okay, all right. That's fine. No, that's okay. That's the X-ray. Okay, so on the X-ray itself, narrow zone of transition, sclerotic rim, you can see chondroid matrix here. It's in the phalanx. It fulfills everything. This is a classic enchondroma. It shows typical appearances on the MR, and this is absolutely classic bland cartilage. There's just nothing there. Yeah, thank you. But it's fine. It's an enchondroma. And so if you look at it, it's osteolytic, expansile, narrow zone of transition with a sclerotic rim. And you can get that in enchondroma, chondromyxoid fibroma, osteoblastoma, simple bone cyst, ABC, and rarely giant cell tumor, non-ossifying fibroma, intraosseous lipoma. These are the various conditions that can present like this. Now if you say it's a metacarpal phalangeal benign expansile lesion, your differential drops down from that list that we had to just enchondroma, CMF and ABC, and then obviously the commonest that you have is an enchondroma. Spina ventosa is not common these days. I mean, I remember as a resident 30 years ago, we used to see quite a few of these in children. Now it's extremely rare and therefore even difficult to diagnose, because while I'm seeing an expansile lesion here with periosteal reaction, to call this spina ventosa on the X-ray would be very difficult, and even on the MR. So it was on the biopsy that we picked this up to be TB. Then I know retrospectively that I'm dealing with a spina ventosa. And this typically happens when the nutrient artery is involved and there's necrosis and sudden expansion and infarction within the bone. Simple bone cysts we've seen are quite simple and straightforward. So they're usually not a problem when it comes to diagnosing them. Often you can see the fallen fragment sign here, but complicated simple bone cysts, so when you've had multiple fractures, etc., can sometimes be a little tricky. Then you have to apply your mind just a little bit. But again, the other place where you find simple bone cysts commonly is the proximal femur in the region of the hip joint. You can see a single fluid level, But again, narrow zone of transition, sclerotic rim, metaphyseal, classic location for a simple bone cyst, but also a classic location for fibrous dysplasia. So you do need the MRI to differentiate between FD and the cyst to be able to make the diagnosis. And this is FD, sclerotic rim ground glass on the X-ray, if you can appreciate that. And then T2 dark here, so that's what you have, right? So the answer is enchondroma, and I just showed you some examples of the other differentials. So a benign phalangeal or metacarpal lesion should always be assumed to be that. Why did I biopsy this? Don't ask me. Sometimes you just biopsy because you're asked to biopsy, and it wasn't required, but I think there was some reason at that time. But this patient has had a fracture and a little complicated or whatever it is. Here is another patient who's had a prior fracture that is healed, so it looks a little weird. But remember the classic appearance of cartilage, nodular, puddling, peripheral. Once you see that, you have your answer. And here's another enchondroma with a fracture that you can see. All right. We don't need to go through all this. This is fine. Yeah. So malignant transformation in the phalanges, I have not yet seen one. There are obviously case reports, nothing is impossible, but it's extremely, extremely rare. Even in patients with Olier's disease, to get phalangeal or toe chondrosarcomatous change is very, very difficult. All right, fourth question, who will take this?
So he's taking, course is taking us to higher.
Sorry?
Course is taking us to higher.
Definitely, sir, definitely.
Thank you.
So go to La Cucina, that's a very nice restaurant. So anyway, fourth question, who's taking this? Yeah, 14-year-old bony hard mass osteochondroma, right? So these were the choices, but you don't even need a choice. It's a very straightforward osteochondroma. It's a projection. The only thing is, the thing we need to remember, which we keep forgetting sometimes, and I do that as well, is that by definition, an osteochondroma has to have marrow contiguity with the parent bone. Whatever, it could be very thin, but you have to demonstrate that. So this one has, so on the X-ray that can be quite difficult sometimes, but on the MR, you can always see marrow contiguity. Once you have the marrow contiguity, you know it's an osteochondroma. The incidence of chondrosarcomatous change in non-complicated osteochondromas is 1%. We make a big deal out of cartilage gap, this, that, but it's not common to have chondrosarcomatous change. If you have hereditary multiple exostosis, which is a syndrome, genetic, then it climbs to 10%, but that's about it. So looking at all those differentials, parosteal OGS we've seen is different. There's no marrow contiguity. So while superficially this might look like an osteochondroma and sometimes gets reported as an osteochondroma as well, you know it's not because there is no marrow contiguity. A surface high-grade osteosarcoma will be an aggressive lesion on an X-ray. BPOP is a tough diagnosis, and you typically make it when you get what looks like an osteochondroma in an unusual location without marrow contiguity, and that's how the diagnosis gets made. And then this is a myositis where it superficially looks like an osteochondroma, but it's just lying in the muscle and it has nothing to do with the bone, etc. So that's the myositis.
Clinical point is there in POP, that is usually it is found in later age group, but maybe in the earlier age group, but it continues after the fusion, after the maturation.
Yes, it does.
Yeah, that is the one.
It does, that's true. So the challenge with a lot of these tumors is they are not reported, right? If you have an osteochondroma, that is an incidental finding. It doesn't go into any registry. It doesn't go into any list of tumors. It's the same with enchondromas in the phalanges, and therefore benign bone tumors are significantly underreported. Non-ossifying fibromas, simple bone cysts, none of them really go into registries or get reported significantly. So here are some more examples. That's a distal femur, and like I said, you find a very thin sliver of connect sometimes as far as the marrow cavity is concerned. These rib osteochondromas can be a little tricky to pick up sometimes, but that's pretty much it. The important thing is that they grow away from the joint. So that's one way to understand them. Sometimes osteochondromas are symptomatic without having chondrosarcomatous change. So here's a 65-year-old who's had this osteochondroma. You see the marrow contiguity and then had this swelling. It's just a large bursa that has been caused by the tip of this osteochondroma, because every time you're sitting, you're creating attrition there, and that's in the posterior part, in the subjacent to the gluteus muscle. And then some osteochondromas, obviously, if they grow like this into the spine, then they become a challenge and they'll cause cord compression and things like that. So malignant transformation, this is the way to check cartilage thickness from the tip here of the bone to the cartilage. Anything more than 2 centimeters is when you consider the possibility of chondrosarcoma. So this patient is an osteochondroma that has undergone chondrosarcomatous change, and you have greater than 2 centimeter thickness of the cartilage. Another one here, that's the osteochondroma, and then you see the chondrosarcomatous change. So you see the rings and arcs appearance, a lot of destruction of the area, thick succulent cartilage here, and that's what it is. All right. Fifth question.
So regarding medullary continuity in a pre-existing osteochondroma, so if there is a conversion to chondrosarcoma,
You may not see it.
that will be also obliterated.
Not always. So in this case, it isn't. You can actually see it on the X-ray. I haven't demonstrated it on the MR, but it may get obliterated in the sense that if the tumor grows in, then that entire boundary is gotten destroyed and obliterated. So, and how does it matter? At the end of the day, to say that this is, so if you know this is chondrosarcoma the moment you see it. Now whether it arose from a pre-existing osteochondroma or whether it's just a de novo chondrosarcoma, it makes no difference unless the patient has hereditary multiple exhaustosis. Maybe if you see something like this, you might want to just check if the patient has osteochondromas elsewhere in the body to pick this up. Alright, 30-year-old with minimal right hip and proximal pain. This is the lesion with the, who's taking this? Your? Oh, you've got your PGs there. Why are they sitting at the back like that?
They are from NH Kolkata here.
Acha, okay. So that was the X-ray. Alright. Why don't you come in front, use the mic, don't be shy. Okay, this was the MR. No worries, someone will prompt and help you as well. So you've got help. No wonder he's sitting there behind. And that's the CT. And these were your choices. What do you think this is? So, what is this appearance? Ground glass. So if you're seeing ground glass, then which one does this fit into? When do you see ground glass? Perfect. Yeah. So that's when you have all three. So you should make the diagnosis on the X-ray because you're seeing narrow zone and sclerotic rim. That tells you that this can either be simple bone cyst or FD. That's one of the two possibilities. And then this is ground glass on the AP. So ground glass with this means that this is fibrous dysplasia on the X-ray itself. Something that should be easy to do. Now you see this is T2 dark on the MR. So that again tells you it's fibrous tissue. You're not supposed to look at these images because then they almost look like there's cartilage inside. But that's wrong. It's the T2 that helps you do that. And then the CT is just classic diagnostic, and I biopsied this. Can you believe it? Because there was a surgeon who was so insistent and said, I want to 110% rule out osteosarcoma, and the patient wanted it, and it's just crazy. But anyway, we did that. So here's the differential. The only real differential is a simple bone cyst, and I've shown that to you. Sometimes tough on the X-ray, but on the MR it becomes easy. This is not really a differential because in a 47-year-old woman, you've got cortical thickening, you've got a cortical break, there's cartilage on the CT, there's lobulated tissue, so then this becomes a chondrosarcoma. And this patient, you can see new bone formation. So very superficially, you might say, oh, this could be an FD, but look at the lesion. It's got a matrix. This is not ground glass. This is osteoid matrix. Not only that, you have a lesion in the epiphysis. That just tells you this is an aggressive lesion, and that's an osteosarcoma. That's the biopsy, just confirms that it's fibrous dysplasia or whatever, and that's it. Having said that, given that our rule is that you biopsy everything, sometimes I have a very low threshold to biopsy lesions. Even if I truly believe that this didn't need a biopsy, patient has FD, patient had symptoms, a little bit of pain, and if somebody says, please go ahead and prove it, I'm happy to do that. I think it's just fair that we establish it in today's day and age if people want a diagnosis to be made for sure. So that's okay. So these are the various points. Remember, monostotic is far commoner than polyostotic. And it's femur, skull, tibia, ribs. These are the common ones. So in practice, we don't do a lot of skull imaging. So it's femur and ribs. These are the two areas that you get FD that you're looking for. I have never seen a malignant transformation of FD, but the WHO site mentions that you could have. The rest is simple. All right. Good. Thank you. Sixth question. All right. You're looking so scared. I mean, seriously, it's not an inquisition. This is a 31-year-old with pain in the knee. That's the X-ray, the MR, the CT, the histopath. And this was the question. Is it giant cell tumor, chondroblastoma, osteosarcoma, or aneurysmal bone cyst? So how would you describe it? You are seeing an osteolytic lesion. What is the zone of transition?
Osteolytic lesions are the epimetaphyseal region with a narrow zone of transition.
So you say epimetaphyseal and then one more sentence. Does it reach the articular surface or doesn't reach the articular surface?
Subchondral. Does not reach the articular surface.
No. It reaches, no? Here it is. It reaches the articular surface. So if it doesn't reach the articular surface, then you would see this appearance here. And then you would be thinking of conditions like desmoplastic fibroma, because they don't usually reach the articular surface. But this one reaches the articular surface. So you're right, osteolytic lesion, narrow zone, but not a sclerotic rim, reaches the articular surface. So what do you think this is?
GCT.
Yeah, it's a giant cell tumor. It's T2 dark as it can get here. This is the CT appearance. It tells you that the lesion is not trabeculated, which is important when you're talking about giant cell tumors. And here you see all these crazy giant cells, which gives you the answer. So that's pretty much it. And again, I'd shown you a chondroblastoma, but chondroblastomas are rarely that big. To get a giant chondroblastoma is not very common. And this is an ABC. We've seen this as well. That's usually metaphyseal, narrow zone of transition with a sclerotic rim. So one of the differentiating features between GCT and all the other benign tumors is that you don't get a sclerotic rim with GCT. So if you don't see a sclerotic rim, it could still be 2-3 things. But if you see a sclerotic rim, then it's almost always not a giant cell tumor. So that gives you the confidence that this is not a GCT, because GCT is a locally aggressive lesion. So anyway, this is how we biopsied it. This is what we got. There's one other point that is very useful in giant cell tumors. Anyway, so one is that this is epimetaphyseal, no sclerotic rim, and it's T2 dark. That is important, and you can have secondary ABC lesions. That's the list we've seen. This is the list of trabeculated expansile. But in that list of trabeculated expansile, GCT is what we call a pseudo trabeculated lesion. So this is diving deeper into this, but probably useful more for Suman, Kaushik, etc. if you've not heard me say this. You see a trabeculated lesion here. But when you look at the MR and the CT, it's not a trabeculated lesion. So the question is, why are we seeing this as a trabeculated lesion? In all the other tumors, you actually see abnormal trabeculae, right? Thickened, thin, like in ABC, etc. Here, the appearance of the trabeculated lesion is this. It's because there is this very fine crenation of the endosteal cortex that when you take an X-ray and you superimpose it, it looks trabeculated. So when you see what looks trabeculated on an X-ray but is not on the CT and MR, then that is another sign that helps you make a diagnosis of giant cell tumor. Alright, seventh question, around the knee. Who's taking that? This is very simple. I mean, yeah, so give, okay, he's taking. Thank you.
Hello sir, this will be the chondrosarcoma most likely of the knee.
Okay, just hold on. 18-year-old with pain and swelling around the knee, and that's the appearance. And these were your choices. Alright, let's just look at the X-ray. Just describe the X-ray.
Firstly, it looks like it is not a benign lesion.
Okay.
So there is.
So as a radiologist, we'd say osteolytic lesion, then we'd say metaphysis, diaphysis, then we'd say, is it...
Metaphyseal
yeah.
region, without any.
So it's epimetaphyseal.
Epimetaphyseal region.
Does not reach the articular surface. Okay, then?
So there is a narrow zone of transition.
No, there's a wide zone of transition. So it has to be narrow everywhere, right? And if you see the superior margin here, it's a wide zone. You can't really see where the lesion ends, where the normal bone begins, both here and here, right? Here, yes, to some extent, but not superiorly. Superiorly, it's a clear wide zone of transition. So you're right, aggressive lesion. So now the question is, what aggressive lesion in the distal femur would this be? Is this, you said chondrosarcoma, but then the other ones are lymphoma, osteosarcoma, Ewing sarcoma, etc. So is there anything here that gives you a sense of what it might be? Do you see any matrix? Do you see a chondroid matrix, osteoid matrix, anything of that sort?
Osteoid matrix.
So you could argue and say that there seems to be some new bone formation here, and therefore then you would think of an osteosarcoma. But think about it this way, that in an 18-year-old, in the distal femur, it is always osteosarcoma. You only think of, the only other differential is a Ewing sarcoma. To get a chondrosarcoma in an 18-year-old distal femur epimetaphyseal is very, very rare. So if you know that also, then it's easier. But more importantly, it's completely dark, which is what osteosarcoma is. And then obviously, and a chondrosarcoma would be bright, lobulated, all of that, which you don't see here. So it's a very classic osteosarcoma, and that's the diagnosis. And then of course, these are the different types of osteosarcomas. Each one of these has to be treated and managed differently, and that's pretty much it. Okay. Great, thanks. Alright, this, who's taking? Alright, perfect. 34-year-old pain in the right shoulder. I showed you this X-ray. That was the MR. That was the PET. Then I said his pain subsided, and these were your choices.
Sir, inchondroma is more probable, but ACT can be also kept.
So what will you do next? Because if you call it an ACT, then what do you do?
It is actually rare, sir.
So how many of you would biopsy this or curate it, and how many would leave it? So how many would leave it alone? Alright, perfect. So then that's that. Alright, so this is a 5 centimeter long lesion. Alright, it's got entrapped fat, no endosteal scalloping, no extraosseous extension, no marrow edema. Typically, when you look at long bone cartilage tumors, you have enchondroma You have ACT slash grade 1 chondrosarcoma and high grade chondrosarcoma. So ACT is pretty much considered the same as a grade 1 chondrosarcoma. But the reason the terminology has come is because the moment you use the term grade 1 chondrosarcoma, whatever it is, it's a sarcoma and it has to be treated. And therefore, ACT is a term that says, it's like, when you have a 6x6 Gleason prostate cancer, where a lot of people now say, don't call it a cancer, just say that it's dysplasia of prostatic tissue, so that you don't have to do anything further about it, but whatever. So location matters. In the phalanges, it's all enchondroma. You don't talk of anything else. But in the pelvis, right, this lesion here, it has a sclerotic rim. It looks benign, but you can see the chondroid matrix here. This is cartilage. And if this one is called ACT, it can't be called ACT. You kind of upgrade it a little to a grade 1 chondrosarcoma. So in the pelvis, these all become chondrosarcomas. They are not enchondromas, and they can be followed up if it's very slow growing, but in the end, these would require treatment. So the vast majority of flat bone tumors will be labeled as grade 1 chondrosarcomas, but in the long bones, you just pretty much call all of them enchondroma slash ACT. And a lot of centers don't even bother now to differentiate one from the other. It doesn't really make any difference because your focus is enchondroma ACT versus high grade chondrosarcoma, not enchondroma versus grade 1 chondrosarcoma. So this one I had shown you, where once you have a cortical break, you know this is a high grade chondrosarcoma, and that's different. But you consider chondrosarcoma when it's greater than 4 centimeters, when there's generalized endosteal scalloping, change in size in 1 year, cortical break, soft tissue extension, or the lesion becomes painful without a fracture. Enchondroma ACT is less than 5 centimeters, endosteal scalloping less than 2/3, no cortical break, etc., etc. This patient, we've been scanning the 5 scans from June 19 to Feb 23, and you can see that the lesion has remained static. One sign that is quite relevant and important, not talked about much, is entrapped fat on T1 weighted images. If you see entrapped fat like this in a cartilage tumor, it's almost always a benign lesion or an enchondroma slash ACT. The moment it becomes a chondrosarcoma, the entrapped fat goes away. So the answer is it could call it either. And a couple more examples. Look at this one here, right? Cartilage tumor, small, less than 4 centimeters. Even the PET uptake is less than 2. So this would be called enchondroma slash ACT. This one again, the same thing, right? Even though there's a little more endosteal scalloping, otherwise it's fine. But this one here is a cartilage tumor, but you can see the extent of endosteal scalloping. Also, you see these cartilage rests that are going into the marrow cavity. This is also a problem. That's why this becomes high grade. And then, of course, this is clearly a high grade chondrosarcoma. And, when we were talking, doctor, about differentiating matrices, on an X-ray, you will see this cumulus cloud or rings and arcs. And I've shown some other examples, whereas an osteoid matrix will just be new bone formation that you would see. And on MR, cartilage is like this, lobulated, bright, septate, and then on contrast shows nodular enhancement. All right, let's move a little faster.
Yes, question actually. The intraosseous low-grade chondrosarcoma, there is a term where I have read it.
So that has changed now. That's what the whole thing is, that low grade means grade 1, and we don't call it low grade chondrosarcoma because these are typically observed lesions. You don't really touch them. So the term is ACT or atypical cartilaginous tumor, which is a better way of saying that, so that people don't get excited and start getting unnecessary surgery done. All right. This is a 50-year-old with swelling pain, dorsal aspect of the forefoot. That's the metatarsal lesion. Anybody? Yeah, okay. So what is the likely diagnosis?
So meets
Mets, right. So, the rule is very simple and straightforward. Above the age of 35, all osteolytic lesions in the body are Mets, myeloma, lymphoma, unless proven otherwise. All rules have exceptions, and the exception here is that to get a metastatic lesion in the metatarsal bone is extremely rare. So if this patient had presented with a humerus lesion or a femur lesion or a tibia lesion, fine. But here that's tough. And so you want to study this better. And if you see this, you're seeing what looks like a possible sequestrum here. Alright? Just looking at this. Now if you're seeing something that looks like a sequestrum, then perhaps this is osteomyelitis and not metastatic disease. The importance being that instead of doing a PET CT or looking for a primary, you focus on the local lesion only, right? So then we went ahead and did an MR. The MR shows a lot of soft tissue here. And if you were a radiologist, you would have appreciated the T1 bright wall, which tells you that this is likely an abscess. And you can see that here as well. So then we just, and you can see the sequestrum beautifully on the CT, right? This is so classic. So then we just biopsied it, turned out to be tuberculosis, and that was that. So, right? So osteomyelitis. So while the rule is real and it exists, it's unless proven otherwise. And in this particular patient, the MRI also showed a soft tissue component that was larger, and you have signs that tell you this is likely infection. Therefore, you just focus on the local lesion. But the rest of the rules remain the same. You still have to biopsy it, you still have to do all of that, and then take it from there. Right?
It's actually
So did the patient have clinical features of osteomyelitis also?
Yes, yes.
The rest of that particular metatarsal, yes, metatarsal is thickened and irregular. All of them. That we also going to.
Yes, yes, yes. Yeah, that's a good pickup. All right, last question, anybody? So these are some examples of osteomyelitis. You can see these ill-defined. You get a wide zone of transition, but you'll get an abscess. Here you see a sequestrum. Here you see sequestrum and cloaca. So these are your typical appearances of osteomyelitis. Okay. Last. Okay, so 8-year-old girl, I said radiograph showed a narrow zone of transition, and then you have this MRI, and then these were your choices. What do you think this is?
Sir, can I look at the options, please? Sir, it can be metaphyseal chondroblastoma.
Okay. What do you think, Kaushik?
My choice will be osteomyelitis.
Osteomyelitis? Okay. So what would you do next? I mean, you don't have an answer on this. You know it's a benign aggressive lesion. There's a list of 8 or 9 things possible. I've given you 4 choices. You have to prove the diagnosis. What would you do next?
Sir, will you go for true cut biopsy?
Alright. So we did a true cut biopsy. The true cut biopsy was negative for histology and microbiology. Now what do you do? And it's a good biopsy, right? Look, it's all properly done. All stuff, enough material, etc., etc. What do you do next?
What is the microscopic description?
Inflammation.
CRP is CRP.
CRP is high.
It's a chronic bacterial osteitis.
Non-bacterial, right? So this is a tricky situation. It is possible that the biopsy didn't capture it. So we know it's not a tumor, because if chondroblastoma and all would have been seen on a biopsy, it's with osteomyelitis that we have a problem. But when you have a child with a subphyseal, metaphyseal lesion in the age group of 8 to 14, presenting like this, marrow edema but no cortical break, no extra osseous lesion, and a negative biopsy, the first thing you have to think of is an entity called chronic non-bacterial osteitis, or CNO, which in the past used to be called chronic recurrent multifocal osteomyelitis, etc., etc. Now, a week later, the patient gave a history of pain in the ankles. Now it became multifocal. Multifocal means the patient goes to the rheumatologist, did a whole body MR, and we found these multiple areas of involvement in different bones of the body. So then you have the diagnosis. Patients put on pamidonate, which is what they give, and then when she came back a year later, pretty much all the lesions have disappeared. So the reason I brought this case up and I presented it at the IMSOS meeting as well is that we don't think of it, right? It's typically the rheumatologists who make the diagnosis, but as orthopedic surgeons, orthopedic oncosurgeons, radiologists as well, we find that a difficult diagnosis at the first instance. But remember this clinical profile, 8 to 15, and you see a subphyseal metaphyseal lesion, negative biopsy if it's solitary. Think of chronic non-bacterial osteitis, but if the patient has multifocal disease, then you don't even biopsy. You do a whole body MR or multiple MRIs, and if all regions have the same appearance, then send it to the pediatric rheumatologist if you have access to one, who will then, there are different parameters, and then they make the diagnosis. So that's pretty much what it is. All right, thank you so much for participating, and thank you.
Thank you so much, sir, for this extremely enlightening session. We can't remember the last time we learned this much on a Sunday morning. I think my fellow residents would like to agree. So for our next session, I would like to invite Dr. Chandra Kumar Krishnan from Adir Cancer Institute, Chennai, and he is going to show us he's going to give a talk on bone and soft tissue biopsies and do's and don'ts. Good morning. I'll be talking on the principles of bone and soft tissue biopsy. I think my talk has been made easy by the previous speaker. So why is it very important? See, all these patients, unplanned surgery was done outside without doing a biopsy. If only a biopsy would have been done in these patients, the limb would have been salvaged. Even though we tried limb salvage in these patients, ultimately they failed and they had to undergo amputation. So it is very important to know when to biopsy. And as sir has already told clearly, any aggressive indeterminate imaging features will need biopsy. And to confirm or exclude a metastasis in a patient with known primary malignancy, and sometimes to rule out infections, and to exclude or confirm an underlying lesion causing a pathological fracture. And the indications for biopsy in a soft tissue mass, more than 3 centimeters in size, masses which are actively growing, or symptomatic lesions. And most often MRI is reported as soft tissue hematoma that is not associated with trauma, no ecchymosis, and is increasing in size or symptoms are the lesions which require biopsy. So evaluation of a patient with bone tumor, less than 40 years, MRI and then biopsy. More than 40 years, we usually go for a PET CT. So where should a biopsy be done? Preferably in a center where treatment is carried out. This was a landmark paper by Mannikin et al. In 1982, which stated that when a biopsy is not done at a center where the treatment is carried out, there is increased diagnostic error, poor technique, which altered the treatment plan and had complications. And he repeated the study in 1996 and found the same results. And I think even in today's date, if you do the study, we'll have the similar results. So it's a final diagnostic procedure and not a shortcut to diagnosis. So why are we talking so much about biopsy? Because the biopsy tract is potentially contaminated. That is what we have to assume, and it must be removed during the definitive surgery. So biopsy is done after imaging because the hematoma and inflammation may alter interpretation of the studies. There are few touch-me-not lesions like Dr. Bhavin told. There's osteoid osteoma, enchondroma, osteochondroma, enchondroma, simple bone cyst, fibrous dysplasias, where a biopsy may not be needed. Then target site. The MRI might tell us from where the biopsy has to be taken, like sir pointed out, solid lesions, enhancing lesions. We should avoid the central necrotic area. Sarcomas tend to grow centrifugally away from the center. As it grows away from the central part necrosis. And if you take biopsy from such areas, you might not get the adequate representative material. And also this lesion is a cystic lesion. If you go blindly or take biopsy from the fluid area, you will not get the biopsy. It is ideal to target the solid areas. And again, image guided biopsy for a lesion in the pubis. This is a soft tissue mass, again showing lot of fluids, cystic areas. So MRI will tell us where to take the biopsy from. This is another lesion at the back of the knee. If you see the MRI, you know it is predominantly cystic with the few areas of solid areas. And this is dedifferentiated liposarcoma. So if you do imaging, you know where to take the biopsy from. You should preferably target the dedifferentiated area here. And the biopsy can, the MRI can tell us the anatomic route and to avoid any critical neurovascular structures while doing the biopsy. So the techniques are a needle and open biopsies. The needle biopsies is the FNAC or core needle, true cut or J needle. J needle is used when we enter the bone. A true cut needle is used when we take the biopsy from soft tissue areas. Open biopsies are incisional and excisional. We do an excision biopsy if the lesion is less than 3 centimeter and superficial, and the surgery doesn't cause much morbidity. So the role of FNAC is very limited in primary bone tumors. It's only in the recurrent bone tumors, metastatic carcinomas, or to rule out nodal metastasis. The core needle biopsy is what is the standard at presently. The advantages are it has low risk of contamination, minimally invasive. It can be done as a OPD procedure. It can be image guided, either CT or ultrasound guided, and it is cost effective. The disadvantages are only a small area can be sampled. Reliable grading is not possible. So upgrading of the tumor is always possible when you do a definitive surgery, and we need an experienced pathologist to report on core needle biopsies. And when we are doing core needle biopsies, it's preferable to go along the line of future incision because the needle tract has to be removed. Preferable to put small incision. Shortest anatomic route may not always be the best route, but preferable to go by that route. And we don't violate anatomic compartments or joints and take adequate course. At least 3 to 4 course would be sufficient. So this is the anatomic route. Proximal femur, we preferable to go laterally because our incision is going to be lateral. But if the lesion is medial, you can take a medial biopsy and always buttonhole the biopsy tract while doing the definitive surgery. Same for proximal tibia. If the lesion is lateral, you go laterally. Medial, you can go medially. Proximal humerus, you go through the anterior fibers of the deltoid. You should avoid the deltopectoral groove because of risk of contamination in the intermuscular plane. So open biopsy is done when adequate core needle biopsy has failed to reveal a diagnosis, and we are still suspecting there is something going on in the bone. Then we go for an open biopsy. So while doing an open biopsy, a tourniquet may be used, but no examination should be done. We should avoid raising flaps. From the skin incision, directly go to the bone. It should be a single incision because if you raise flaps, whatever hematoma occurs, it will dissect the soft tissues and subcutaneous plane, and there will be excessive contamination. And while doing definitive surgery, we'll have to remove excessive tissue, which may be avoided, and removing excessive tissue will cause needing for flaps to close. And we go through the muscle instead of intermuscular planes, and neurovascular bundles should not be dissected or manipulated. And if it's a bony lesion, it is enough to take biopsy from the soft tissue component. We need not violate the bone, which is already weakened, it might fracture. And if it's a purely intraosseous lesion, then we have to make an oval window in the bone and send FS if needed to see for adequacy of the sample. And you plug the hole in the bone with cement to prevent blood coming out and contaminating, and also provide strength to the bone. And while making holes, it should be longitudinal oval holes with rounded borders. That will prevent stress risers and avoid fracture. And tunicate should be released. Meticulous hemostasis, like I already told, should be obtained before closure. Drain should be avoided, but if needed, it should be along the line of incision, and you should remember to remove the drain tract also while doing the definitive procedure, and it's closed in layers. So, and like sir told, TB is still rampant. Culture if suspicious. This turned out to be tuberculosis. And we should advise non-weight bearing mobilization, splint or bed rest when the biopsy is done to avoid such fractures and prevent the limb salvage surgeries in these patients. The fixator should be a 10% neutral buffered formalin solution, or you can speak to your pathologist what fixator they require. Some people prefer the lymphoma fixator for bone tumors. They say it's easier for them to process the tissue with that solution. And do not split the biopsy specimen because these tumors are very heterogeneous. We need to see all the blocks before coming to a diagnosis, and if you want a second opinion, you send the entire specimen to a pathologist. And always convey messages to the pathologist. Tell them what is the clinical features, show them the radiographs, tell them if there is any pathological fracture, because all these can hinder a reporting. Because the biopsy was done for this patient, the pathologist reported as normal bone seen. But we have to correlate with the radiological findings, and it's a low-grade parosteal osteosarcoma. This is the video of a core needle biopsy. A distal femur lesion. That's the joint line. You can either go medially or laterally, wherever the tumor is. You give local anesthesia. This patient is being done under sedation. That is the Jamshedji needle. You go perpendicular. It is very important to go perpendicular because we'll be removing only the perpendicular tract. If you go in any other directions, then we'll have to remove a wider area of tissue during the definitive surgery. And if it is a solid lesion, the J needle, you can take multiple course. But if the lesion is cystic and has soft tissue component inside, it's better to aspirate with the syringe and put the tissue in the gauze. We use 13, you can use 13 gauge, 11 gauge, 8 gauge. If you have to enter the bone, it's preferable to use a bit wider so that you can take adequate tissue. This is a true cut, which is done for a soft tissue. A true cut needle can be used even to biopsy osteosarcomas and chondrosarcomas. The extraosseous component can be biopsied with the true cut needle. Only if you need to enter the bone, we'll prefer using a J needle. Or in giant cell tumors, we use a J needle. These soft tissue needles, they have a throw of varying lengths, 0.5 centimeter, 1 centimeter. Based on size of the lesion, we can choose the throw we need.
I don't understand what are you doing with the sample on the glove?
We're collecting the samples of this.
You don't put it straight in the formalin.
We put it straight in the formalin also, this to show in the. This to show.
And here you're going blind.
Yes, sir. We advise guided biopsy for most of our patients, sir. This was to show the technique of. Very rarely we perform biopsies at our institute, sir. Radiologist performs the biopsy.
In the previous case, you have taken only one code?
No, sir. I'll show you.
Previously?
No, sir. We have taken multiple.
Okay.
So the take-home message is to obtain the diagnostic tissue by minimizing morbidity and limit potential tumor spread and avoid interference with future treatment. It is a simple procedure, yet a cognitively complex unit. Thank you.
Sir, in case of GCT or say ABC, you will not hardly get any.
Exactly, sir. That's what I told when we are dealing with cystic lesions or when there is soft tissue, it's not the hard tissue inside the bone. We put in the J needle and aspirate with the 5 ml syringe. So in the when you aspirate, you'll get a lot of blood along with the solid tissue. You put it on a gauze, all the blood gets absorbed, and you can pick up the tissue with the blade, 11 mm.
Find that if you use a 14 gauge gun, even if you're getting what looks like blood, there is enough tissue in the formalin for them to make the diagnosis. You don't have a problem with GCD. With ABC, sometimes you have to go to the wall and do a little
Cure off.
Chandrakumar, you have mentioned in your lecture regarding the resection of the biopsy tract in the final resection. So, the biopsy tract we are, for all practical purposes, we are considering as a theoretically and it's practically contaminated with the tumor tissue. So, what is your suggestion to prevent or minimize the seeding of the biopsy tract? How would you prevent that?
So choose the shortest route to the tumor and use a guided biopsy. That is the best way to prevent contamination, longer area of contamination.
So by guided biopsy, you are going to hit the correct area.
Yeah.
That image guidance is going to help that. But how do you prevent while you are removing the specimen, the biopsy needle, the needle syringe construct? What is your suggestion to prevent or minimize the seeding of the biopsy tract?
No, so we use a gun cannula technique for all patients, right? Which means, so what you've shown is, I think, for demonstration purposes, but in all our core biopsies, there is a cannula which you put in, the needle cannula goes in, you remove the stillet and the cannula remains in. Through that, you put the gun and you take as many cores as you want. So it's a single entry, multiple cores. You finish, then you put the stillet back inside, then you remove the needle. So it's just a single entry exit. So you've significantly minimized seeding. The bigger issue now, and I think somebody will have to do this study, and I think in the next 5 years we'll have a lot of debate on this, is that all these rules were made for open biopsy.
True, sir. True.
And when it comes to the last 15 years where most biopsies are now core biopsies, there is very little data, or rather there is very little evidence of seeding actually happening outside of cartilage tumors. So cartilage tumors, we've still seen that when you biopsy, you can later on have seeding if you've not, or you see tumor seedlets if you've not excised the tract. But for all other tumors, there is now very little evidence of seeding being a problem. And there is a movement, and obviously these things, dogmas take so much time to turn. But it is looking as if in the vast majority of tumors now, it probably doesn't matter. So you don't traverse planes, obviously, you know, if it's an anterior compartment, you don't go from posterior compartment, that kind of stuff, no. But, you know, if you're not perfectly anterolateral in the thigh, or you go a little anterior, it should not matter. I still don't have the courage to do that, and I will still follow the rules because that's how we've been trained. But the recent literature, there are at least 3 editorials that have come up in skeletal radiology, and where people are saying we need to re-examine this, we need to look at registry data, we need to find out actually what is now the incidence and prevalence of seeding with core biopsies. So hopefully we'll get an answer with that.
I think so. I was talking about the coaxial needle, right, sir?
Coaxial.
That's what our radiologists do.
Yeah,
They've just put a coaxial and take multiple tugs. And just make one entry into the tumor. Through that, you can make multiple holes. And as sir was pointing out the seeding of biopsy types, I would like to present our data, sir. We have analyzed 150 osteosarcoma patients who underwent core needle biopsy. And we analyzed the biopsy tract in the histology specimen. Only 3 patients had seeded. See, there are multiple arguments. Patients must have received chemotherapy before surgery that might have taken care of whatever the seeding was there. And one more thing, it is very difficult to identify the biopsy tract, you know. We do the biopsy after 3 months, after 3 cycles of chemotherapy. To identify the biopsy tract is not at all possible. So that's...
I think the challenge we have as radiologists now is teaching, so because so many people now do biopsies, and it's easy to do, but that maxim that all biopsies should be done only in the center of treatment doesn't work, because let's say an MRI is done, shows a tumor, some radiologist who knows how to do a biopsy will do it.
True.
That's fine. The challenge is that, and this is what we are trying to do, that a good number of radiologists don't know the rules. They know how to put needles, they know how to get good material, but they often will traverse compartments. So in the pelvis, for example, it may be an acetabular region that you need to go anterior, but they'll go posterior because it's simpler, and then you traverse gluteal, sciatic, all the planes to get to the lesion. So there is a move with the vascular interventional societies to try and get the message out as much as possible, but that's just pretty much all we can do.
Sir, one question, technical question. Sir is also doing, I think, biopsy from the university. So when doing the biopsy, after taking the tissue, so many times like ABC and hemorrhagic tissue, there are lots of blood clotted with the tissue. So whether you use the heparin routinely or not, clear cut on the normal side.
I'll tell you
how
what.
you send to the specimen in the formalin. What is the amount? What is the percentage of formalin?
I'll tell you what I do, and I'll also tell you what others do. What I do, like I told you, if it is a cystic and bloody lesion, we aspirate. When you put it on the gauze or mop, you can clearly differentiate between the tumor tissue and the blood. The clotted blood and tumor tissue, you can clearly differentiate. You take only the tumor tissue and put it into formalin and send. That will be adequate. But there are people who put heparin to this and send the entire fluid and make cell block out of it and also analyze.
Which one you should follow?
See, both works. Both works.
Heparin doesn't happen anything.
No, no.
Dr. Shubhalakshmi Madam is our histopathologist in our institute. I would like to have an opinion from Madam. So regarding in some specific scenario, as you have also mentioned in the morning, in a few selected cases, there is a repeated biopsies, 2 or 3 repeated, even if image-guided biopsies which are negative or non-representative. So how far frozen section can help us in this scenario? Is there any role of frozen section in intra-biopsy frozen section?
In case of bone biopsy, I think frozen section has limited value in bone biopsies because most of the lesions are heterogeneous. So on frozen section we may miss the actual tumor. So
I'm not asking about the diagnosis, whether it is representative or not.
For the adequacy of the specimen. See, we do FS for the adequacy of the specimen.
Representative or not?
For bone, most of the bone specimens we do decalcification, but in frozen it is not possible to decalcify the bone and then section, do the sectioning. But in the case of soft tissue, we can definitely go for frozen section.
Usually we don't give the hard or the bony part. See, when we take the biopsy and send for adequacy for frozen, it is the
soft tissue part.
soft
Yes,
tissue
we can
part.
go,
It is not the
yes, we
bone
can
which
do
we
that.
send.
Extra soft tissue part we have to send for the.
Yeah, extraosseous, if it is extraosseous. But if it's a purely intraosseous lesion, you're going to curate the marrow or whatever it is there and send it for FS. Yeah, not the bone.
I think the other role of frozen is, and I think Manish does that the maximum, at least that's what I've seen, is when you're trying to take a treatment decision on table.
Yes, sir.
For example,
GCTs is where we commonly take up the patient saying that we'll send it for FS.
Correct.
If it is not, we'll proceed for
or
cure.
an ABC where you
Want
want to
to
inject,
inject,
so you're doing
yes,
a
yes.
core biopsy, but you then want to inject with the same at the same
Yes.
time. So those kind of things, or 3 centimeter soft tissue tumor, you're almost sure is nodular fasciitis, but before you remove it, you want to make sure it's not a sarcoma. I think those ones are the ones that go for frozen.
And if you have done a biopsy once or twice and still inconclusive, it is, even once it's inconclusive, it is better the radiologist, pathologist and the orthopedician sit together, go through the images and the histopathology before going for a second round of biopsy. You might find a diagnosis there. You might think it is a tumor, but radiologist might think it's a tumor, but it might be something else when you sit with the pathologist. So, like I told, for diagnostics, it's a multi-modal.
So that bony tumor,
Yes.
so one bony tumor with extensive soft tissue involvement.
Yes.
So only soft tissue component is sufficient.
Yes, sir. Yes, sir.
Okay.
That is as representative as.
One more indication for frozen section, probably when the margin of resection is adequate or not.
Yes, sir. Many people have stopped giving the frozen. We give frozen when we have doubt. It is not routinely performed in every limb salvage surgery.
Thank you so much, sir, for this extremely informative session. Before we move forward, the can in cancer, I feel nowadays I would like to say is that we can attempt to cure or at least possibly give patients a functionally and psychologically stable life. And that is only possible when we have an integrated approach to it, because with that comes better understanding. So moving forward, we have an orthopedic, radiological and a pathological session together. We'll be moving forward with Dr. Garg's session. Sir, please, I request you to come forward.
Good morning, respected my seniors, my juniors. We will now talk on the ORP session. So I like to invite our pathologist, Dr. Subbalakshmi, in front. Radiologist Dr. Arif and Bhavin sir. Madam, are you also? After Dr. Bhavin sir lecture, I think these two cases become a spot diagnosis. But still, I like to present this case. Start with the case 1. Young female, 35 years old, presented with the mild pain and swelling all around the first metatarsal, and this swelling is gradually progressive. The swelling is not tender, not mobile, and is fixed hard mass. This is the X-ray of the patient at the time of presentation. So, from our radiologist panel, Dr. Arif, can you comment on this X-ray?
Here we have the radiograph of the foot, and we can clearly see there is an osseous lesion that is predominantly sclerotic, arising from the first metatarsal. It is involving the cortex as well as the medulla. And we have some periosteal reaction that looks quite a bit frightening kind of. So it looks like a high-grade kind of lesion, such as osteosarcoma.
So, as this, but clinically, sir, if you see the clinically swelling all around the first, it is not tender, not well, and mild pain. So we, sir, your opinion, sir? Is a 35-year-old female, not tender, not mobile, swelling all around, gradually progressive, and this is the X-ray.
Okay. So there's a lot of either new bone or cartilage or whatever that's pretty much on the surface. That's what it looks like. So some surface lesion, and we need to figure out what it is. The first diagnosis that comes to mind is BPOC, but that's, I think it's too early to say that.
So what I saw before starting that, this session, so these are the MR images. Yeah, Dr. Arif, yeah.
Yeah.
So actually, I said an aggressive lesion.
Yeah.
But the MR clearly show, I mean, it is hyper-intense lesion. A surface lesion without any adjacent bone destruction and all. Surface lesion and then BPOP as the sensing.
Apart from BPOP, only BPOP, any other differential, sir?
No, I think we would basically look at any surface. Do you have any other images?
Yeah.
Let's finish seeing all of them. And then, anything else?
CT is also there,
Yeah,
sir.
let's see everything. And okay, go back. Let's go back. Let's go back. So one of the issues with, do we have a pointer or something? Yeah.
Cosy. Pointer.
So one of the things with BPOP or any of these tumors is that they are surface lesions. Here if you see, that lesion seems to show a cartilage gap. So at one point you might, especially on that image, along the medial margin on the surface you see that little bit of a cartilage gap in the coronal. But what is concerning here is that there is so much marrow involvement. And that marrow involvement is not what you get with BPOP. This is more an aggressive lesion, there's a surface component, and I would be very, very worried. So then when you go to the CT, let's see the CT. Yeah, and there's another one. Yeah, you see that appearance. That's very worrisome. And the previous one, you have involvement of the marrow cavity with new bone formation. So I would think of an osteosarcoma straight off on this. And that's simply because ideally you're not supposed to get marrow involvement with BPOP or any of those tumors. So it looked like that on the X-ray, but the MR and CT show an aggressive lesion with new bone formation.
So from X-ray, it should be, it looks like a BPOP, but MR and
I mean, it
CT
was just one possibility. I would have just called it a surface lesion. I'm not even sure chondroid, osteoid, and for further evaluation.
So reostal action was there, I think.
Yeah.
in X-ray.
Yeah, and it's aggressive in the sense it's not very well defined. See, if you do have a pointer, I can show that if you see the oblique, on the medial aspect, you have that irregular margin to it, very fluffy looking stuff there. Yeah, that's not common with, I mean, that is a sign that tells you, you need to work up this lesion significantly. And I would be very worried about this.
That margin itself tells that it will be aggressive because the soft tissue mass is there.
Yes. And BPOP doesn't produce marrow involvement. That's my understanding.
BPOP, continuous gap will be very thick. It is 2 centimeters, more than 2 centimeters, something like that.
No, not necessarily. No. The cartilage cap can be very thin also. BPOP, it's just, that is not I mean, because in a tumor like this, you don't even have the size to get a 2 centimeter cartilage gap. So that's not an issue. But it just, to me, looks aggressive.
On the medial side, there are states of cap.
That looks like cartilage, but on the CT, some of it is cartilage, some of it is new bone. I would be very worried. The only thing I know is that a good biopsy is required.
So does all BPOP have a smooth outer margin?
Yes. According most, at least what I've seen, they have this. They may not be smooth. You could have an undulating margin, but it would be solid, not irregular.
So, according to age and the clinical feature, it looks like a benign swelling because patient have a little bit pain, mild pain, not tender, mobile, fixed bone swelling around the face. Go for this patient These are the differential, as Bhavin sir suggest something aggressive. And these are the differential we would think: osteochondro, myositis ossificans, chondrosarcoma, and BPOP also keep in the mind. So these patients go for the surgery. And two part was that was biopsy. So this patient goes for surgery, and these are the intra picture. This is the gross tissue specimen.
So you remove a part of the metatarsal bone or only
In the subperiosteal.
You could remove it.
Yeah.
Taking a part of the cortex, a part of the metatarsal bone.
But you didn't have to enter the marrow part.
No, sir.
But in imaging wise, there is marrow changes, so.
Yeah, that's what I thought.
Biopsy suggests it is a BPOP type of lesion. I have a five slides. Madam will comment on that.
So it was a cartilaginous lesion, and we could see just lobules of cartilage. The cartilage was quite cellular, and the chondrocytes were slightly atypical with hyperchromatic nuclei. These are all cartilage cells, and most of the entire specimen was composed of these lobules of cartilage. And if you just, can you just move on?
Go to the and show us that will be
This one?
the cells which are hyperchromatic HL and that will be directly to us. Pointer
These are all lobules of cartilage, and this section also shows this cartilage, but it is, as you see, it is quite cellular, and these nuclei better appreciated in the previous section. These nuclei are quite large and hyperchromatic.
atypical anyone atypical?
No, sir, but these are hyperchromatic with a high NC ratio, and I mean nuclear cytoplasmic ratio. And here, this cartilage matures into this haphazard bony tissue with proliferation of spindle cells in between the bony tissue. And we could not demonstrate any osteoid, any abnormal mitosis, necrosis, or significant pleomorphism in any of the sections. So a diagnosis of BPOC was made.
But we is X-ray findings or the CT and MRI findings, if you will you now revise your diagnosis?
Regarding that biopsy, before the cartilage cells are usually of irregular sizes. Mature and immature is a mixture of that.
These are chondrocytes are bizarre looking.
They are also arranged not in the palisadal manner, but haphazardly arranged. Cartilage cells.
The cartilage cells will be bizarre looking and with atypia, and the chondrocytes will not be, the normal lobules of cartilage will not look so cellular. And the cartilage cell, the nuclei will not be so much prominent and not so visible. And to call it an osteosarcoma, we need to have osteoid producing osteoblasts and osteoid. And the entire section was, as you can see, the entire thing was all embedded in 5 sections. So osteoid was not demonstrated. Yes, this is what. Blue bone disease, yes. So this is the bluish tinge that we have.
What was the marrow involvement in?
Yes. So the marrow involvement is going against the diagnosis.
Yeah.
So the part of the incision biopsy, we remove the extraosseous part with the cortex and we curated the marrow cavity. The entire specimen was sent.
So what did that cartilage?
Cartilage. The entire specimen was embedded, sir. We did not leave behind any.
Then it's a cartilage tumor. I mean, if it's not malignant, then it just becomes an ECT. Right?
So there is the only point to give the surgery because the patient was not having too much of pain and the first biopsy produced a pathological fracture. There was a cause of pain. Before that, the patient was absolutely having asymptomatic
Sorry,
pain.
1 second. So was the MRI done after the patch fracture or before the patch fracture?
This MRI mostly was done after the biopsy was done. Because the biopsy was done somewhere else after the CT scan and X-ray state for biopsy was done with the X-ray and CT scan.
The CT also shows marrow sclerosis. The top one, it's just a cartilage tumor.
This case will require a strict follow-up.
Now, what is the follow-up question?
This patient, 2 months follow-up.
Because even if it's BPOP on biopsy with that marrow involvement, and we know that the recurrence in BPOP is very high when we do the curata. Even with that diagnosis, I would have preferred excision in this case than going excision. Yeah, I would have preferred excision in this case.
So you have excised the whole phalanx?
Yeah, whole metatarsal.
Because itself a high recurrence rate, so after that even you more than 50% of recurrence.
At least you know it's benign.
No, with that biopsy report, can we excise the total metatarsal?
Why didn't they resect before?
What is that?
Why didn't they resect before?
Actually,
It was symptomatic. Because
the incision, the previous biopsy was showing BPOP. But the MRI and CT scan were showing some extraosseous soft tissue calcification, irregular RPN as I already mentioned, and there were marrow changes also. So we are not very confident with the diagnosis of the BPOP with the imaging. So we did a incisional biopsy and curettage of the intravenous content for better representative of the hysterogen.
Actually, I have done 3 cases in the metatarsal, and also though it was, I read it that it is the disease of the short bone of the hands and the feet, but I have seen also in the humerus and also in the femur, and those cases are reported also. But what is that? Because it's the high recurrence rate, they usually excision or meticulous excision is one of the urgent need, and when it is actually we can satisfy the metatarsal. So excision and reconstruction with the type cortical bone graft or the fibula, that is the treatment of choice probably.
So from biopsy point of view, from pathology point of view, there is I think there is no doubt about that so some sorts of malignant.
Now taking to, I mean, this is not osteosarcoma because there was no osteoid, but this is a cartilaginous tumor which is showing some ATPL, and taking the radiological pictures in view, this may be a atypical cartilaginous tumor. Because the cartilages are definitely atypical, but if it is not fitting with the BPOP, then I think this is a atypical cartilaginous tumor.
And also there is no marrow tissue, is it?
No marrow tissue.
So that is going in favor of the BPOP.
No, but
Yes.
there is marrow involvement on CT.
In the biopsy there is no marrow element.
But they've curated the marrow, which was abnormal.
We've done the resection of the extraosseous part with the cortex of the metatarsal and curated the medullary content.
What was there in the medullary content biopsy?
But
This is what we have. We just have this cartilages and this trabeculae of bone and the spindle cell proliferation in between.
Just keep a close follow-up. It's metatarsal cartilage tumor, it could be an ECP.
No, it's not chondrosarcoma as well.
For next year update, we can have the follow-up of the patient. What happened?
Yeah, definitely. This patient needs follow-up further. And so for juniors, this BPOP is also known as Nora lesions. It's rare, involving hand and feet, aggressive feature on imaging. Many times Nora have aggressive features we discuss here. Non-imaging and many times it is a confusing result of HPE. Surgically complete dissection and recurrence is always many times common, more than 50% is recurrence.
I have a question for you. Regarding this BPOP and low-grade chondroid lesions, and to differentiate it, frankly, high-grade chondrosarcoma, imaging-wise it is visible, there is no confusion. But to differentiate between low-grade chondroid lesions in chondroma, BPOP, what is your suggestion regarding core biopsy and incision biopsy? Is it more beneficial or more helpful for you to get a to see the entire range of endochondral ossification? So in that matter, you suggest like incisional biopsy, or how to target the biopsy site for chondroid lesions? Is there any suggestions from your side?
I think to call it convincingly a chondrosarcoma, I think we need to show bone infiltration. Otherwise, radiologically, it is just not histologically it is not just possible to call it a chondrosarcoma, especially in low-grade chondroid tumors. You get a high-grade chondrosarcoma, it's easier to diagnose. But in case of low-grade chondroid lesions, sometimes we have to sit on the fence, to say this is an atypical chondroid neoplasm to correlate radiologically and clinically.
Is there any rule like that? Any chondroid lesion with a soft tissue calcification apart from the parent lesion, it should be always be taken with some salt. That extra soft tissue calcification apart from the parent lesion, it is always a danger thing. Is it like that?
So the only time is if you also if the patient has a synovial chondromatosis and then there's burrowing of the loose bodies or that chondroid material in the bone. It happens in the hip joint because it's a tight joint. Then you have to make that differentiation because then it's not truly intraosseous. It's just the lesions going in from outside. But otherwise, if you ever see a soft tissue component or calcification in a definite cartilage tumor which is adjacent to it, then it has to be considered aggressive and a problem. There's no question.
Next case. Ten-year-old child, progressive swelling and bowing of the leg, presented with the skygram. Dr. Arif, any comment on this X-ray? Then.
So here we have a lesion in the tibia involving mainly the upper and mid diaphysis. As the sir has talked in his just talked about the trabecular lesion with very defined margin, sclerotic margin. So it looks like a benign lesion. And possibly it is a fibrous dysplasia.
Any other imaging you required for, any other differential you want to be?
We can have CT scan from ground glass for more, ground glass will be more apparent, but I don't think.
I would like to differ, it's more of a cortical. So it's, we are dealing with lesion and the size, I think I feel more of a admantinoma or next would be osteofibrous dysplasia. So these are two my diagnoses.
So I think the diagnosis starts with this being an OFD, for an osteofibrous dysplasia. We keep talking of adamantinoma as a differential, but in this age group, adamantinoma is so rare that unless the patient is symptomatic, I mean the only symptom is bowing, right? There's no pain.
No
there's
pain.
nothing. That's not typical of an adamantinoma. Adamantinomas produce pain. They are tumors. They infiltrate the marrow and all of that as well. So this would just be an OFD. You wouldn't really do anything about it. But obviously we can't not do anything. So you must be having an MRI.
Okay,
Let's
sir.
see it.
So MRI was done.
What is that rest there? You have more images? Just show all the images first. Anything more? Yeah. No, go back. So atypical findings, right? There's a cortical break there, there's some soft tissue on the axial image, there's a rest there, and just go back, is there marrow involved there? There's marrow involved, probably. So you would want to biopsy this to rule out an adamantinoma.
Yes, sir. Even in X-ray, if you go back to X-ray, there is one cut. Yes,
The
you can
break
see there the
there,
lateral
yeah,
view.
yeah.
There is a break in the cortex.
Yes,
So
very
that's,
nice.
that's the one
Yeah,
which
yeah.
made me think of it.
That deficiency of the anterior cortex.
Dr. Garg, can you just point out that area?
Adamantinoma more common in adults, right?
Yeah, I mean this age group it's uncommon.
The cortical break just below?
No,
Just
below.
below. Still down?
Still down.
Yeah,
Yeah.
yes.
Oh, so this
Oh.
is a. So they mess it up. Yeah. Nice.
So, but sir, the thing is, patient have 10 years of age, no clinical symptoms apart from little bit swelling and bowing, and these X-ray. So what, Dr. Suman, you still on the admintinoma on your clinical radiological basis, and MR?
It's looking at MRI, yes, because there's a big marrow involvement in that area. And yes, there is a biopsy has been done, but still there is a soft tissue component in the anterior aspect. So
So this seems to be an open biopsy, correct?
yes.
And I have a feeling that in the open biopsy they've gone and pushed the tumor into the man. I mean, I didn't get that history, but now that you have that, then clearly it's all very complicated. And, yeah, just check the biopsy once to be 100% sure.
So biopsy reports this. This is the biopsy slides. Madam, please come in.
This is a tumor showing haphazardly arranged misshapen woven bone, some of lying in a fibrous stroma, and there is spindle cell proliferation, but the cells do not show any ATP or mitosis. And some of the trabeculae show appositional brimming of the osteoblasts. If you just
You call me. Yes.
So this is the osteoblast remain of some of these the woven bone.
So that's why it's called osteofibrous.
Yes. So in case of fibrous dysplasia, we won't have these osteoblasts remain, just this bone. But here we did have some this osteoblastic remain. This is an artifactual gap. But here you can see these are these are all osteoblasts.
So Suman, what right now your comment?
No, my question to the pathologist is, would you be able to differentiate between adamantinoma and osteofibrous dysplasia on
Yes,
microscopically? Would be
yes,
able to,
yes,
you get a
yes,
clear
yes,
picture?
yes,
Okay.
yes.
Okay, if the patient is asymptomatic, if it's as madam told, she is quite confident it's osteofibrous dysplasia, then I would like to observe in this case.
So the posterior margin also exponential lesion. Go back to the X-ray.
So the question is the bowing, right? They've come for
Yes.
a deformity. And will the deformity go away?
So deformity won't go, but yes, if you want to do a surgery, is going to be little morbid. So we will explain them, and if the deformity is keep increasing, then we can do something. If it's mild bowing, I think we can talk to patient and keep under close observation.
If this patient were with a pediatric orthopedic surgeon, would they do something or not? Once they know it's OFD.
I think they like to, because we oncosurgeons are ready to accept some form of deformities, the shortening, because we see that in our procedures, but normal orthopedicians, they want everything to be as normal as possible. So
Because I've seen pediatrics do that. They take asymptomatic patients and they do something to them. I don't know.
So for bowing, I think there may be some role of corrective braces and observation. Some corrective braces can prevent further bowing on weight bearing.
And most of this patient after getting matured, after 18 years, everything is, most of them is correct.
So for this thing, this is the area which is the involvement of the medullary. This is the flared cortex we are seeing, or is
No,
it?
I think not that one. You see the other image. My worry was that. You see that there seemed to be some soft tissue coming out. No, you're right. It's flared cortex only. Now everything's fitting in. But I was worried about that soft tissue, which now probably is the biopsy track, but I didn't know that. So it just fits in. In fact, everything else fits. It's too dark, laminated, all that fits into OFD. And I mean, rarely you can have this OFD-like adamantinoma, but that's on radiology, not on pathology.
So from radiology point of view, what are the points that will put our clients correct that we are dealing with the adamantinoma, not
Greater than 10 centimeters, marrow involvement, cortical break, soft tissue. These are the things. But I think more importantly, it's age. I think we try, because these two have been talked about together, but adamantinoma is an older person's disease. And the differential often is epithelial metastases from salivary gland tumors and those kind of things. And adamantinoma is an epithelial tumor. This is a completely different ball game entirely. So usually not a problem.
Management adds one to this is a younger child and diagnosis is this, the low touch lesion, observation is the mandatory. Most important thing is the counseling of the patient and family members regarding the bowing. They very much worried about the bowing of that. Now Kaushik will present the question.
Present a single case. There is a 19-year-old female patient presenting continuous pain around the left knee since last 6 months. No history of trauma, no history of constitutional symptoms. Patient was managed with conventional painkillers. So this is the X-ray, plain X-ray, frontal and lateral view. Sir, your input.
Here we can see there is a lesion in the distal femur involving the epimetaphyseal region, trabeculated, not reaching up to the to the articular location, and I can see some cortical destruction posteriorly. Yeah, over there. So I would like to do an MRI for this patient.
No, but before the end, everybody had in the, what does everybody think this is? You have to put your, so benign, I'm saying benign ABC. What are, Suman kya bolte hain?
Even I feel benign, but because the few X-rays which you showed in the morning, so maybe dysplastic fibroma.
Benign. Give the histopath.
Dr. Suman told, it's not reaching up to the subarachnoid.
Histopath, one diagonal.
Fibroma, desmoplastic.
Desmoplastic. What do you? Sir, what do you think this is? Or anybody else?
Differentials?
I mean, see, we could be wrong, but the point is you have to give a diagnosis. That's the fun of an ORP, because in the end you will have a diagnosis, hopefully. Alright, go ahead.
So should I go through the images cross-sectional images?
Yeah. Obviously.
First, let me show all the sections.
Okay. So focal lesion, no marrow edema, it's T2 dark, so there is fibrous tissue inside, there are no fluid levels, it's obviously not an ABC. But you guys might be right, it could be, there's no plastic fibroma. But yeah, it's a benign tumor, nothing else. No. The biopsy. Huh?
Someone has done a curettage.
Curettage, and because the radiology reports were benign lesion, as we have discussed, desmoplastic fibroma, fibrous defect. So the upfront curettage and intraoperative sampling was sent for the biopsy. Any other options, as we already discussed, you should, for any focal bone lesion, biopsy is not an option, it's a mandatory. So biopsy should always be done. Intraoperative curettage and sampling is not recommended procedure. This is the biopsy slides. Madam, any opinion on the slides? I apologize because these are the only 2 slides I have for this case.
Okay, I don't think I've seen this case up front.
No.
So, in the 2 pictures, you can see just this trabeculae of bone with intervening very cellular fibrous stroma. And I would have loved to see the higher part view of the spindle cells to see whether those are atypical and show any mitosis. But
After she finishes, go back.
Go back to images, sir.
So this is a tumor which is showing a fibrous component and a osseous component. So if the spindle cells are atypical and there is mitosis elsewhere, so this could be a fibroblastic osteosarcoma. Otherwise, this could be a desmoplastic fibroma.
So,
Or
if you go back, the challenge is that you're seeing woven bone. And if you look at the entire X-ray MR picture, this is not fibrous dysplasia. So that woven bone in desmoplastic fibroma, if I'm mistaken, is just a fibrous tumor. There's no woven bone. So why is there bone inside? You are not seeing an osteoid matrix. Now go to the MR, which means there is a bony matrix in this which we are not able to appreciate. So if you have new bone formation on the histology in an MRI where you're not seeing it, let's assume there's an osteoid matrix, then everything changes. Then it doesn't matter if it has a sclerotic rim or not. And you are going to think of osteosarcoma at the age of 18. That's weird. I mean, how can you have something that looks like fibrous dysplasia or, woven bone in a tumor like this? It makes no sense at all. So if you put everything together, this is really worrisome. And as ma'am said, this is very worrisome.
Sometimes low-grade central osteosarcoma.
But it's not central. Central is actually central. Yeah, it's intramedullary.
So as Dr. Arif has mentioned,
Yeah.
there is a deficiency of the posterior cortex.
I thought it was a thinning out and scalloping, but now you're right. It's probably a cortical break, which he's not sure there. Probably. Nice. So what did you do next?
So this was a biopsy report, fibroblastic osteogenic sarcoma. So yes. So this was reviewed. So this was clearly mentioned in a review. The report was reviewed multiple times because there was a discrepancy or some from the initial radiology and the histopathology, and on the top of the matter, the patient was already upfront curated. So it was very difficult for the index operating team, for the clinicians, to digest this report with the curettage already done. So did the multiple times review, and they mentioned that though there was a relatively benign looking radiology, this is a spindle cell sarcoma in the metaphysics of 19-year-old female patient. So if we go back to the initial images, as Sarah also mentioned.
You did show that image to us, the one with the cortical break. You see the top right, the top row right one. The top row. Yeah, the right one. Yeah, there.
PET CT, there was no evidence of any metastasis. So the take-home message for this case, however indicative or however obvious is the radiology for a benign looking lesion, we should never take on any therapeutic intervention without a prior histopathological documented evidence in our hand. We should, as Sir has already mentioned and discussed in his morning lecture, we should always, for all practical purposes, biopsy all focal bone lesions, apart from the do not touch lesions. So histopathological diagnosis is a mandatory, it is not an option at all. So upfront curettage and intraoperative sampling is not an option at all. However, indicative is written in many times the MRI or CT scan report is showing a GCT-like lesion, giant cell rich lesion, benign lesion, but we should always have a biopsy report in our hand before embarking on a therapeutic intervention. I would request, yes.
The thing is, you see a sclerotic ring here, which is a sign of a benign lesion. The problem is all the rules of radiology that we talk about, they work 90 to 95% of the time. As they say, the diseases don't know our rules. They present whichever way they want. The rules we have made up. And so we need to remember and have the humility as well that there are times when frankly malignant lesions can look benign, and what looks frankly aggressive on the X-ray and MRI may turn out to be a benign tumor, which is why a good biopsy is so important, and exactly this is what we want to prevent. Where people go in, if this had been done after a frozen, perhaps that may be a different issue, but otherwise not acceptable. This is what happens. So now what?
Sir,
now what?
Patient was subjected to neoadjuvant chemotherapy and amputation. Patient had to amputate. Landed up amputation. Cross contamination anterolaterally and posteriorly also in the neurovascular plane. So,
but you wouldn't try to do some excision, dissection, removal of tumors?
So there was a gross contamination from ours, and actually after neoadjuvant chemotherapy, there is seeding of the biopsy tract also. So we are not very confident regarding that.
What happens is, even if the primary big tumor close to the vessel, we know that it is contained. We can go to the vessel and dissect it. But this man-made contamination is much worse than a big lesion which is close to the vessel. So because we don't know where the fluid has seeped in and where is the contamination. So most of our patients end up with amputation post-chemotherapy.
Sometimes I wish Manish would be there, because he would disagree and he does that. He's the only one. Everybody else follows this.
Sir, it's not like all the cases. Yes, based on the amount of contamination which has happened, which we see on a contrast MRI. So if it's limited to only lateral compartment where we feel can excise, do some flap, that's fine. If there's a contamination in the posterior part along the vessels, then we would go for an amputation.
And sir, as you have already mentioned in your morning lecture, for bone tumors, the first radiology, first surgeon, everything first, and we will not get a second in sarcoma. So PET CT still it's non-metastatic, so we didn't take a chance. And I think Madam will also agree, osteosarcoma is such an entity that can masquerade anything, right from fibrous dysplasia, osteochondroma, it can masquerade anything. So it's that's the thing. I would request my next speaker, Dr. Chandrakumar, to present his cases.
Male, 35-year-old male complains of pain in the knee for the past 6 months.
Do you want to go to
slide presentation?
Alright, so osteolytic lesion, epimetaphyseal, eccentric, but a wide zone of transition, especially superiorly. You see posteriorly, I'm not sure whether there is a little bit of soft tissue. Yeah, there. So if that is the soft tissue displacing it, then all the more reason would worry about an aggressive lesion. So to me, this is an aggressive lesion. Can a GCT look like this and be aggressive? Yes. But I don't know what it is. It's an aggressive lesion, needs an MR and a biopsy.
MRI.
It's T2 dark and it has a cortical break and extraosseous extension. So it could still be a giant cell tumor that's broken out, but I would want to rule out a malignancy.
Biopsy was done.
So this is a tumor which consists of several osteoclastic giant cells, which is distributed uniformly, at least in this section, and there are some mononuclear stromal cells. So this is a giant cell.
You want to see?
Yes. So, all these are multinucleated osteoclastic giant cells, and in between those single cells are those mononuclear stromal cells. So same over here.
What's the diagnosis? Giant cell.
Giant cell tumors from this.
Can we differentiate Brown's tumor from giant cell tumor histologically?
Histologically, we brown tumor, as you say, the name suggests brown. It's because of the presence of hemorrhage and hemosiderin deposition. But in these sections, I couldn't see any hemosiderin pigment. And also, you see some tunneling resorption of bone. If you have this native trabeculae of bone, the osteoclasts seem to destroy the bone, making a tunnels and getting into the central part of the trabecular bone. So that is also not visible in this section. So, I mean, if the clinical picture fits with the context, then could be definitely a problem.
Alphos is normal, sir. Any orthopedic oncologists can comment whether they do stage alkaline phosphatase, calcium and phosphorus for all giant cell tumors?
100%. So we don't as soon as we image-wise suspect a giant cell tumor, even before biopsy report comes, I will get an alkaline phosphatase.
Good. For the residents to note. So what next? What would you do for this, Kaushik?
So it's very difficult to differentiate between a giant cell tumor and the Bronze tumor, I think even under microscope. And this is the age group where even we see the Bronze tumor around in a female, between 20 to 40 years. And same with giant cell tumor, 20 to 40 years. So it's always better to have an alkaline phosphatase, and in Bronze tumor, the alkaline phosphatase will be very high. So if you have seen a very high alkaline phosphatase, then you are missing Bronze tumor. So then you have to get the parathyroid hormone level to rule out it's not Bronze tumor.
What if it turns out to be hyperparathyroidism? How will you treat this patient?
So if it's hyperparathyroidism, the treatment will be mainly focused on the primary issue. So we need to focus on the parathyroid. So once we sort this, the bone will heal. So only need to keep the patient non-weight bearing, tell them not to fracture, otherwise it will heal.
Yeah. Well.
Pardon, sir?
How is the incidence of solitary lesion? Because in the hyperparathyroidism, the system will show other stigmata will be there.
So I really don't know the numbers, but yes, in past 10 years, I might have seen 2-3 cases like that. So I really don't know the numbers.
It may not be solitary, there may be asymptomatic smaller lesions. Now I was just postulating, while you are waiting for the finding the adenoma, treating the parathyroid, etc., since this is at risk of fracture, is there a role of giving denosumab to just short term to prevent the fracture? I don't know.
To be frank, the bone quality looks pretty okay. So only thing we need to do is put a brace and keep the patient non-weight bearing. So I have not used, as I told you, I have seen only few cases. So I really don't know.
I think denosumab can be given, sir. Anywhere to prevent skeletal related events, denosumab can be used.
So would you do that in the primary treatment of a GCT in this case? No.
Yeah, denosumab, the curative becomes a bit problem. Okay, so the chance of recurrence is more. So better if not mandatory, if it's not that much thinned out, so denosumab should be avoided in such cases, because there are reports that with denosumab, with the hard bone, so curative becomes recurrence becomes much more.
True, sir. True.
Okay. So what I told radiologically just on one side only just a mild cortical break, so we can wait instead of doing denosumab. Okay.
No, sir told if it is hyperparathyroidism, whether denosumab
That's
can
right.
be. So what would you do for this patient? It's giant cell tumor.
It's a giant cell tumor. Okay.
So if it's a giant cell tumor, can you just show me the images? I think I missed it. Cross section. Cross section.
Yeah.
Okay. So it's Campanachi grade 3, where there is a soft tissue component in the posterior aspect, and there's a good cortex all around. So I like to do an upfront extended curettage, and reconstruction. It's a big debatable topic, but yes, the surgery would be upfront curettage.
What is the role of denosumab in giant cell tumor? When will you use denosumab?
See, the role of denosumab, we use it in 3 conditions. One, when we are treating with surgery, when the involvement in areas like sacrum, where we know that we won't get adequate curettage and disease clearance, and when we want to treat the patient with definitive denosumab, means no other treatment, give denosumab as a standalone treatment for giant cell tumor. The second option would be when you want to resect a big tumor with a big soft tissue component, you want to make that tumor little hard and less vascular so that it's easy to do the excision. Coming to third indication is where Campanachi grade 3, if you get little cortex by giving denosumab, so against which you can cure it, you can do it. But to be frank, I have stopped using denosumab for curettage patients, because what happens is, even if the bone forms, what we say is there can be cells in that bone which has formed. So we have to go to the pre-denosumab imaging and go that extent to do the curettage. So obviously it's not going to help me in doing a curettage. And obviously with the 2 to 3 injections, there may be the tissue become little fibrosis, make curettage little difficult. So yes, people use, but I have stopped using for before doing curettage.
So what is the dose and what is the interval at which you give denosumab?
For what indication?
For
No, I
all-
told
all
3
your-
indications.
All your indications.
Okay, so for definitive, it's ideally speaking at present, if you ask me how long it has to be given, lifelong. Okay. So, but as we know, the financial, it's going to be a big financial burden for the patient. So what I would like to do is start the patient on initial 0, 15 and 0, 7, 15 and 13, that is 4 doses. Then change it to once in 3 months for another 2 to 3 injections. Then make it once in 6 months. Then give it once in a year for 1 or 2. So it comes to almost 3 to 4 years. Then change into injection zoledronic acid slowly and stop it. Because we know that once we stop the denosumab, the chance of recurrence will be around 50%. So in this way I have treated around 3 to 4 patients. So the follow-up after stopping denosumab is maybe varying from 6 months to 1 year. Luckily we have not had any recurrence, but yes, we need to have a longer follow-up. There are a lot of institutes who add angioembolization with denosumab, so these are the options, but yes, you can combine this thing. And coming to for resection, so ideally you need to give 0, 7, 15, so 2 to 3 injections, and can operate after 3 to 4 weeks. Once you have the calcification or the rim form, the vascularity comes down and you can operate. And if you want to give before curettage, what I do, especially in the cases like pelvis and in the proximal femur where we can't use tourniquet, I give 2 doses 0 and 7 and operate the patient after 3 to 4 weeks. Even though X-ray wise you won't get the rim, but it will reduce the vascularity and there won't be much hardening of the tissue tumor, so it's easy to do a curettage.
So you have a couple of cases for whom you are giving lifelong denosumab.
Yes.
And
No, not lifelong. I have stopped after like 2 to 3.
A
3 to 4
definitive
years.
treatment with
Yes,
denosumab.
yes,
So what
yes.
are the sites?
Sacral. All patients are sacral. Yeah. I think I have 4 patients.
Can we extend it to acetabulum, periacetabulum area?
Yeah, can be done. I have 1 patient from Kolkata whom I am treating now. I think she is on treatment. So,
Okay. So most of these patients, giant cell tumor is more common in women in the reproductive age. So if they want to bear children,
see, that is the biggest problem with denosumab. If you want to give for lifelong, especially in women, you have to make sure that whether they want to, conceive and whether they have completed this family. So all those history is important. The case which we are treating in Kolkata, she has completed her family and they are okay taking denosumab.
Sorry, what is denosumab?
So, not fertility, but
teratogenic.
Teratogenic. So, yes. So that's why.
In mice, not in the human super machine. It's a teratogenic in the mice. It has been shown, right? Okay, so that's the prevention.
It's one of the contraindications in pregnancy.
So if you're treating patients with the denosumab, if they want to have a family, maybe you can change to embolization during that period. I don't know.
Yeah, something like that can be done, but I have not got any patients like that, so I have not thought. See, there is no definitive guidelines to say you have to do like this. It's you need to change according to the patient need and how it responds to it.
Ma'am, there's a question for the residents. Can you just tell what are the malignant or the neoplastic cells in the giant cell tumor? On the mic, ma'am, so the residents can hear.
It's the mononuclear stromal cells, which is the neoplastic component of the tumor, and not the osteoclastic giant cells that is found in abundance, but then it is not the tumor component. Yeah.
So, staging. So we went ahead and did curettage, ma'am. It's the post-op HP. Ma'am.
Giant cells.
These are all the giant cells and the stromal cells. Yes. The center, I'm not sure whether that's a mitosis, but there might be, and there are some eosinophilic extracellular material. Could be osteoid. And this is a mitosis, yes, and definitely an atypical one. So, yes, this is a giant cell rejustice sarcoma.
Is there a way we could have prevented this curettage?
Go back to the slide.
Biopsy slides.
Madam, if you go to the slide and show us.
The giant cells?
The
Oh, the mitosis. So, the center, and in the center of the section you can see this is a cell showing atypical mitosis. Usually we have a bipolar mitosis. The normal cell, every cell undergoes mitosis, but we have bipolar mitosis. But in this mitotic figures, we have multiple like limbs. So it is an atypical mitosis more than it's not a bipolar typical mitosis. Because in giant cell tumor we do get mitosis. There may be mitosis in giant cell tumor of bone, but then in atypical mitosis is a flag that is what we look for, atypical mitosis.
Very unfortunate, the post-op HP was a giant cell rich osteosarcoma. So what next? Kaushik.
Intraoperative curettage was done.
Yes.
So I need to assess the post-operative MR, whether there is a gross contamination, something in the neurovascular plane. Anyway, after staging, the patient will go for neoadjuvant chemotherapy. For surgical point of view, I have to assess the MR images, post-NSCT and the pre-NSCT images, whether it is salvageable or not. If it is not salvageable, then the stage positive patient goes for a fully ablative surgery.
So what is the staging you want to do? Staging investigation?
Local staging is a cross-section imaging MRI with a CT cut, and for systemic staging, fluoride paid with CT thorax or a CT thorax with bone scan.
Okay.
PET CT? PET CT? PET CT.
PET CT and usually the PET CT they cover from the vertex to mid-thigh. So whenever we are asking for from the bone side, you ask for a head-to-toe PET CT with the HRCT of the chest. Usually they don't do a HRCT of chest while doing a...
Only in Chennai, they do it in bone.
No, it's very important point because otherwise the main CT they cover up to mid.
Only mid-thigh, so yeah.
It means the mace in the proximal tibia.
No, but when you say lesion in the distal femur, usually they cover it. They do it only for metastatic disease. It's covering half of the femur.
No, even for upper limb tumors, it's only till mid-thigh.
Do the MR scanning of both the organs from hips to foot, that will come in the MR.
So all myelomas are scanned head to toe. All lower limb sarcomas are scanned head to toe, because anyway you are doing MRIs to look for skip lesions. But if it was a proximal humeral chondrosarcoma, for example, it would be to mid-thigh only, because you're not going to get, unless you specify, then you have to specify. But so this is quite standard.
So my question, do you need to change coil or do something,
No.
some different technique
No,
to cover?
you have to
Then why
cover.
it's not covered?
Takes extra time. So you have stations, and typically each station is about 20 centimeters or 30 centimeters, and you do it in steps. And so it takes just extra time, what happens if you have multiple patients waiting, that is another 15-20 minutes, and you're injecting and taking patients based on the time after injection. So if it's not required, why? That's
If you elaborate a bit, like we did previously say MRI dorsal spine, but now that has been changed. MRI dorsal spine is a scan.
Correct, whole
the
spine
whole of the
scan,
spine.
yeah.
So what's up and where not to do and where you must.
Sorry.
Elaborate a bit that from head to toe you should do the PET scan. What's that should be routine or not?
No, not routine. Because the number of lesions that occur distal to the femur is so low that it's not worth the effort. Maybe in the future, if the machines become much faster, or if there is an entity called total body PET, if that becomes standard, then of course you just have an entire head to toe happening. But at this point, it is a logistical challenge. So you do it only when indicated, which is all myelomas, all lower limb sarcomas, and when asked for. If you specify, then it will be done.
Yes. So I think we've discussed amputation versus limb salvage. The patient ended up in amputation, and he through metastasis at 1 year, and he succumbed to the disease. Why I'm telling you, this happens even at a tertiary care center.
This is one of those, you couldn't have done anything. I mean, there is nothing you can do. What can you do?
Will giant cell rich osteosarcoma pick up H3F3? No, maybe the H3F3. Okay.
But the mark.
No, what message we need to give here is, yes, it happens in tertiary center also, but with all the specialists sitting there, sometime it can happen.
Yeah, that is
You
what.
need to have an expert radiologist, pathologist in your center, so that you are not missing. Most of the times you are not going wrong.
But I will tell you this, since that marker thing came up, if you remember when Shekhar Kumta came about 3 or 4 years ago from Hong Kong, Shekhar was very clear, right? He said all tumors that are going to be treated like this, everything is now markers. So you do USP6, you do what you do for giant cell. And unless you've done molecular, they don't touch their patients anymore. So they are going that one step because you know that you can miss a giant cell rich osteosarcoma or even a malignant GCT as they call it from a biopsy. And so they're doing all of this to minimize all the stuff, and especially USP6 as well, because you have so many disparate tumors which actually turn out to be similar because they all show that morphology. And I think very, very slowly in TMH they are doing molecular in almost every patient now because they got the facilities, and both Anita and Jai Mehta have also started doing in many of their patients. I think in the next 5 years we'll see a sea change in the use of molecular in all our patients.
Even our
Madam, I'd like to know from you that what's the, in this case, say, if the molecular thing would have been done, what is the chances of error still there or say, because the biopsy was done earlier, okay, so can you show the biopsy slide, previous biopsy, not this one? Yes. So with this, if you relook and that we are not satisfied, and what's the chance of molecular things to?
From this particular section, this looks pretty like a giant cell tumor of bone because, as I said, giant cell tumor does show mitosis, but they should be like a typical mitosis, not the atypical mitosis as. And giant cell tumor, if it is previously fractured, may show osteoid as well. So from these two sections, at least I don't think there could be any other diagnosis.
But things are changing. So the other day, yesterday or the day before, but last week I biopsied a 25-year-old with a humerus chondroid lesion with a soft tissue component with lung mets and bone mets. Turned out to be an extra skeletal mesenchymal chondrosarcoma. But later, I mean, the second sentence that Anita gave was BCOR or NTRAC related spindle cell sarcoma, do the entire molecular panel. So now they've gone that one step ahead because anyway this guy is gone. I mean, unless some wonderful chemo works, there's nothing that's going to work for a lung. I mean, completely asymptomatic, little swelling here, gets the x-ray done, shows a little bit of chondroid, chest x-ray shows lung mets, and it suddenly turns out to be this. I mean, so, but the point is everybody is now slow. I mean, Ewing's is entirely now BCOR and NTRAC and all of that. Anyway, the whole classification has changed to molecular based completely.
Problem is that most of the centers we do not have access to.
But now you can't treat a Ewing without all of this, right? Because the Medonc is not going to give treatment unless you know all this anyway. No? So that has also changing very rapidly. And that's Medonc driven. Ewing is entirely Medonc driven now.
So going retrospectively, can we have something but you would have to suggest it is not a simple GCT anymore?
Not in this case. This case was one of those.
40-year-old male complains of pain in the shoulder. Is a patient from Dubai. A biopsy was
The standard. So my only question is the pain at the site of the tumor, or was it pain related to a rotator cuff or a labrum?
I'll show you the MRI, sir.
Okay, so anyway, it's a cartilage tumor, and question is going to be the same. Is it enchondroma, ACT, high-grade chondrosarcoma? No, my question was on the pain.
Yes, sir.
Can you make out whether the pain is related to the tumor or
The problem was he had a biopsy in Dubai when he had come to us.
So what ideally is you can inject steroid into
And then the
and see the pain reduces and then
these are all the features of a high-grade chondrosarcoma. So whether it turns out or doesn't turn out is a different thing, but if you see there's complete endostin scalloping, 360 degrees, this is one of those which you will treat.
So, should we do a PET CT or directly go with the biopsy, sir?
So I mean, I do PET CTs, but I don't believe in the power of PET CT in cartilage tumors. I'm sorry. I found that it's too variable, and you know, where you see high SUVs, you can anyway tell that it's going to be high grade. Where it shows low SUVs, you can anyway tell it's low grade, and the intermediate ones, you know, the SUVs of 4 and 5, anyway everything is indeterminate or intermediate, so it doesn't seem to make a difference. I would not advise. Maybe in a rare case, but in this one, biopsy first.
This section is showing atypical cartilage with foci of ossification. I think the cartilage is, I'm not very sure from this picture, if it is, it could have invading the trabeculae of native bone. And this atypical cartilage with ossification, the left hand. Same.
Would like to give a diagnosis?
Yeah. Atypical cartilaginous tumor, Faber chondrosarcoma, with the, keeping in mind the radiology.
Not high grade, it's not grade 2 grade.
No.
So then it's an ACT.
So, the biopsy was given as cartilaginous tumor. Suman, what would you like to do?
image-wise, I'm pretty sure that it's a chondrosarcoma. And biopsy has seen the cartilaginous tumor. And patient if symptomatic, then I would treat it like a chondrosarcoma. Because already biopsy has been done, and I don't know PET how much it's going to.
The problem was, since the biopsy was already done in Dubai, and PET was done after the biopsy in Dubai, and the SUV was 7.1. I don't know whether that will be of any significance in a biopsied.
No, was it an open biopsy or a CT guided biopsy?
Guided biopsy.
Guided biopsy. No, then the S7.1 is not post biopsy.
Okay.
That's of the tumor.
Okay.
So then I would treat it like a chondrosarcoma. And we know that there is no role of chemotherapy and radiation in conventional chondrosarcoma.
So I would like to do a wide local excision, and here it looks like I can save the axillary nerve and deltoid, so I would opt for a reverse shoulder reconstruction.
What we did was to differentiate enchondroma from low grade. It's not possible.
So again, I did that in my presentation. So this low-grade chondrosarcoma is your grade 1.
Yes, sir.
And in a long bone now, you're actually not using the term grade 1 chondrosarc. That has been replaced by ACT. So it's enchondroma / ACT. And your whole aim is that versus high grade. So here we already know that this is an ACT or so-called grade 1 chondrosarcoma, and we are sticking to that. And that's fine. Even ACTs can go for surgery. It's not that it won't. And that's really, so that differentiating enchondroma from low-grade chondrosarcoma is no longer the issue. It is enchondroma / low-grade chondrosarcoma versus high-grade chondrosarcoma. That's your worry.
Since it was only a cartilaginous tumor and they didn't report any high-grade features, we did a curettage. So biopsy.
This is a cartilaginous tumor, not showing any high-grade features. Cellular cartilage, no high-grade features. Yeah. See.
It was reported as chondrosarcoma grade 1, and the patient is post of 3 years, is doing well.
So my question still remains, if the pain of the patient had been due to rotator cuff and this was an incidental finding, would that, despite the MRI feature, because if it's completely incidental and you biopsied it and it turned out to be an ACT, would you observe it or not? Because that's the only factor. If this lesion is causing pain, you treat. If the lesion is not causing pain, there is a role for not doing anything and for observing these patients. And that's, I think, where it boils down.
So is there any specific clinical test or clinical sign through that the sir is mentioning? We can decipher that whether it's the pain is from the degenerative arthritis or rotator cuff here, specific clinical test is there?
In that case, the clinical signs are there, drop on sign or improvement. You can go, or you can go for what I was saying, intraarticular injection. Or if the pain is reducing, then it's okay. Otherwise, MRI also you can detect whether there are any reason about the rotator cuff.
Local infiltration with the local anesthetic, that may cause the deep-seated pain will not be relieved, but it's related to the deltoid bursar like thing, then that can okay. So the clinical findings as well as the injection that can help diagnose. Correct, yes.
Which one?
Can they be tender?
These bone lesions.
The
No,
clinical,
sir.
the clinical features are
If
more
it is a
important.
low grade, they won't be. That.
Any comment? I think clinical features will be more pertinent, that is whether related to the not related to tumor.
Actually, after this treatment, if the pain has gone, so that is significant. Otherwise, the pain may be because of many things. It may come from the cervical spine also. So the local shoulder pain. But if all has gone after this treatment, so in that way, retrospectively, we can say that it was due to the tumor.
It was due to the surgery. We don't know whether it was due to curettage.
The first place, before doing the therapeutic intervention, is there any role of clinical methods or any specific sign in MRI so that we don't operate this patient? That is the question for sir.
That is actually what Kumar said. But cervical spine also is to be clinically examined properly. And the shoulder tests, particularly involving the rotator cuff or some kind of infringement And those to be, even the shoulder that is adhesive capsulitis, that is to be executed by clinical.
So one other issue that we need to look at is that so a lot of the guidelines come out of either the NHS or the US. You know, in the NHS, patient has no choice. They may say all of that, but patient has absolutely no choice in treatment method. I mean, they can refuse, but they can't demand to get treated. And what I'm coming to is that let's say you have this lesion, patient is pain-free. You call it, you biopsied it, it's an ACT. And you tell the patient that, listen, you don't need surgery, you're asymptomatic, it's not really a high-grade chondrosarcoma, we can wait and watch, and that's the end of the matter. We've seen at least 2 patients where the patient said, nothing doing, you have to get it out, I do not want it inside me. Then what do you do? And I think in our setup, if the patient is completely convinced and wants surgery, most of us will do it, right? I mean, you're not going to. So that patient wishes also make a difference in this particular setting. And that's why I was saying in the NHS, if you called it an ACT and if the patient said, but I still want it out, they will not do it. That's it. Patient has no choice in the matter.
In these cases, I just want to mention out that clinical report is very, very important. I and Dr. Nundi was examining the patient, she's still now under observation. She had a mild pain in the knee, and on X-ray we found that touch me not listen. Okay, and we did the other investigations and explained to her, and she's doing well, and her pain also gone. So it's important from the to note that it was a clinical issue around 45. She just hardly way changes. For routine examination she came, and it was incidental finding. So that's the thing I think from which all the junior residents should take, that clinical examination is no alternative. And next please.
Thank you, Dr. Chandrakumar, for the excellent presentation. Before we break for a lunch, a small lunch break for 15-20 minutes, I'd request our senior teachers from West Bengal Orthopedic Association to please come on dais. We'll have a small felicitation ceremony for our guest speakers from outside Kolkata. Sir, please come. Professor Jain Pal, sir, Professor Kumar, and Dr. Behra, sir, please come, sir. I'd request Dr. Naveen, sir, to please come on dais. Dr. Suman and Dr. Chandrakumar. Dr. Manish, please. Dr. Manish is our intervention radiologist. Sir, please have a seat.
সরে দূরে দূরে এসো ফেলিসিটেট করবে হ্যাঁ দেবে এক এক করে ঠিক আছে ক্যামেরা
রিকোয়েস্ট প্রফেসর জেন পাল স্যার টু ফেলিসিটেট ডক্টর নবীন স্যার
নাও আগে একটু ওয়াইডে
Dr. Behra sir to felicitate Dr. Manish.
ওটা নাও
Professor Sanjay Kumar sir to felicitate Dr. Suman. Dr. Suman is my colleague and good friend from TMH. Now he is posted in Mojumdar Shaw Cancer Institute as a musculoskeletal onco surgeon and doing excellent work. Professor Pal sir to felicitate my friend Dr. Chandrakumar. He is a musculoskeletal oncosurgeon from RDR Cancer Institute, Chennai. Thank you, sir. Thank you so much. Thank you, my senior teachers and colleagues. We'll break for a small lunch break for 15 minutes.
Sir. স্টপ করি আচ্ছা ওকে বলছি স্টপ করবো না না আছে লাঞ্চের পরে আছে 15 মিনিট লাঞ্চ ব্রেক করবো
this tumor and the treatment is not that great. Okay, so still the chance of local recurrence in giant cell tumor varies from almost 10 to 40%. Okay, so means if you are operating around 10 patients, so there is chance that around 3 to 4 patients can have local recurrence. So what is the problem? Whether there is a problem with the biology of the disease or there is a problem with we doing the surgery. So let's discuss in detail about it. So Dr. Bhavin mentioned, so any suspected benign bone tumor, the first thing we ask is for X-ray. So in X-ray, the classical feature of giant cell tumor, it should be epiphyseal. So it should be epiphyseal going up to the subchondral level, and they will have that septation and non-aggressive looking. And if it's long-standing, it can have a soft tissue component as well. But if there is a periosteal reaction, or if there is a wide zone of transition, then you should think of aggressive bone tumor. So that's how the classical giant cell tumor looks. So next is the Campanacci grade. I think all of you know about Campanacci grading. So what is the use of this Campanacci grading? So Campanacci has described into 3 grades, grade 1, grade 2, grade 3. Grade 1 is where the tumor is within the bone, so there is no change in the bone shape. And in type 2, it's involved within the bone, so there is ballooning of the cortex, but the cortex is not broken. And type 3 is where the cortex is broken and there is a soft tissue component. So why it is important? Because from grade 1 to grade 3, there is increase in the local recurrence. So why it is so? If the tumor is intraosseous, you have good solid bone all around. It's easy to do the curettage and easy to get the disease clearance. If there is a soft tissue component, yes, to run the burr or to get the disease clearance is difficult. So the chance of curettage is high in grade 3. So going by standard protocol, the first is X-ray, then we go for MRI. So as Dr. Bhavin mentioned, MRI give an idea about what is the tumor is made up of, is there is any secondary ABC component in it, how much bone is involved, if there is a soft tissue component we can make out, and what is its relation to neurovascular bundle, and what is the extent of the disease, whether the cartilage is involved or not. So all this information we get on MRI. So there are a few examples. Never ever touch a giant cell tumor without biopsy. So these are the 2 cases which I have seen in my practice, which I am sharing here. So this, if you ask me anytime, or even Dr. Bhavin, based on the X-ray and MRI, 90% of the time we say, it means 100% of the time we say it's a giant cell tumor. So this was a case operated by orthopedic surgeon, beautiful curettage done, plating and cementing has been done, and the final histopathology came, it turned out to be osteosarcoma. Okay, so never ever operate a giant cell tumor without proper histological diagnosis. The one more case, 45-year-old lady, she came to me in 2016 with this imaging. You can see there's a lesion in the distal femur, and MRI was done at a reputed radiology center in Bangalore, and the radiologist had no confusion or hesitation calling it as a giant cell tumor. But so you can see there is a hyper intense lesion in the distal femur. So this indicates that there's a chondroid material. So when we did a biopsy, it turned out to be chondrosarcoma. So what I want to say is, not all pathologists, not all radiologists are exposed to musculoskeletal oncology. Like us, like surgeons, we don't have that much of exposure to musculoskeletal oncology when we are doing general orthopedics. So same with pathologists as well as the radiologist. So don't jump and operate any case without proper diagnosis, only based on MRI reporting. Okay? Nobody can sue you for doing a biopsy, even in a benign case where you are not planning to operate. But if you operate a case which is looking benign and turned out to be malignancy and there is a change in the plan, and the patient sue you, it will be a difficult problem. So at present, with so many medical legal cases against doctor, it's always better to be safe. So no put needle before knife. So that is the mantra whenever you are dealing with bone tumor or infection, when you have a doubt between whether it's a tumor or infection. So the most common treatment what we do for giant cell tumor is the extended curettage. So when we do extended curettage? That's an important question. So to answer that question, the answer would be after doing extended curettage, if you feel that you have saved adequate bone to reconstruct, then we go for extended curettage. If you feel that after doing extended curettage there won't be any bone left to do the reconstruction, we would go for excision. So let me share the few steps of extended curettage and how we do it. So here is a case, image-wise classical GCT. So you can see there's a tumor involving the proximal part of the tibia on the medial side, and you can see there's a soft tissue component in the posterior medial aspect. So ideally what we would have done is to do a biopsy through the medial cortex, okay, because that is the subcutaneous bone, easy to do it. So you can see here the whole cortex is intact except the posterior medial part. So what I have done here is we have done the biopsy from little posterior aspect through the soft tissue component without damaging or contaminating the medial cortex. So you can see here when we are doing a definitive surgery, the incision is little posterior, and we have dissected the vessel posteriorly and done a curettage from a little posterior aspect. So we could save entire anterior and lateral cortex intact. So we could do the reconstruction easily and patient will have a better functional outcome. So the treatment of giant cell tumor starts from the biopsy. So you should know from where to do biopsy, how to save the maximum bone possible that would help in the reconstruction. So now, what are the steps of curettage? How many of you seen, for residents, how many of you seen extended curettage in your hospital or in your college? Can you raise your hand? Okay. Can anyone tell what are the steps, how you do extended curettage? Or how it was done at your center?
First we will mark the lesion. So we will have to osteotomize the lesion. We will mark that. Then we will osteotomy the.
No, you got, okay. So we'll go step by step. Patient has been there is a lesion in the distal femur. Anesthesia has been given. Okay. What next?
We will we can use tourniquet.
You can or you want to use?
You want to use.
Why? What is it? Why you want to use tourniquet? Why not without tourniquet?
To have better visualization.
Okay.
And proper curative, but we should not exaggerate.
Okay. See, I'm just going step by step. So there's a tumor involving the distal femur, and you can see there's a big soft tissue component here in the lateral aspect, and those are the vessels and the nerve which is close to the tumor. So always giant cell tumor, if whenever you are able to use the tourniquet, use tourniquet because they are highly vascular. If you open without using a tourniquet, there is high chance of bleeding. And second, you won't have a clear picture of the cavity, so you won't be able to do a proper curettage. So wherever it's possible to use tourniquet, it's a must to use tourniquet. Okay. And the second step would be to make a proper exposure. Okay, there is no call minimal exposure or mini exposure when we are treating bone tumors. It has to be exposure which helps to see the lesion completely. Okay, so the lesion on CT or MRI is around 9 centimeters. So I have marked that much, and my opening would be more than that, so that I get a complete exposure. So now this is a tumor on the lateral side with the soft tissue component which I showed. So we go and cut the vastus lateralis. So what next? What do you want to do next? Now the tumor is there in front of you. What do you want to do?
We will mark the tumor lesions, extent of the lesion we will mark out. So we will try to see the normal tissue and differentiate. We will mark.
Okay, good. Next.
And we'll proceed with the resection, excision of the tumors. And osteotomy, we will mark out the margin and we will try to.
So you want to make a window?
Yes, sir.
That's what you say. If there's a soft tissue component, how you do it? There is tumor already. So as soon as you lift the vastus lateralis, there's a tumor. You can see. So what do you want to do? Okay. See, the main thing what we do is in Campanacci grade 1 and grade 2, obviously the tumor is within the bone. So we make to make an adequate window over the bone. Okay, so adequate window means it should be usually equivalent or more than the what is the tumor size. Okay, then you make a window and then you go into the tumor. In Campanacci grade 3, there is a big soft tissue component. If I just enter the soft tissue component into the tumor, okay, it will be very difficult to do the curettage against the soft tissue component, and that's why the recurrence rate is pretty high in grade 3. So what we do in grade 3 is always try to isolate the soft tissue component from the surrounding normal tissue and excise the whole soft tissue component in one piece so that we are reducing the contamination. So you can see here what we have done. You can see from lateral side, that's the arrow showing the popliteal vessel. So I have taken the popliteal vessel separated, okay, and that's the tumor there, and upper part is the cut part of the facial lateral, and so that has been retracted on the other side. So next would be to keep hydrogen peroxide soap mop on the either side, because if there is any contamination, we don't want to contaminate the whole area. We need to contaminate as less as possible. So keep hydrogen peroxide mop on the both the side, okay. Then cut or excise the whole soft tissue component in one piece, okay, so that you are reducing the contamination. You can see that now the soft tissue component has been excised and a window has been created. So that's a tumor there, that's a giant cell tumor, and the mop has been put on the either side so that you are reducing the contamination. So next we go inside, use scoop or nibbler and take out the tumor and do the curettage, okay. So is this sufficient, or you want to do something else? Now I have done a curettage. I have removed the disease which was visible to me. You want to do the reconstruction now, or you want to do something else?
We will go for a power drill, sir, to prevent the power burrow.
Okay, so you want to use power drill. Okay. So you want
also
to
adjuvant chemical like phenol to prevent the. It will using of adjuvant chemotherapy will reduce
adjuvant chemotherapy. Okay, we will go step by step. Okay, so next is you need to use a high speed burr. Okay, but the most common mistake which we make is if you connect that drill to the hand drill of your Manman or striker, that RPM is not sufficient to do an extended curettage. Okay, so never ever use your drill on your saw or the drill, because that rotation is not enough to take out the bone. So your machine should have a RPM of more than 20 to 30,000. That is available only with the Medtronic drill. The neuro people use or the ENT drill, which has more than 30,000 RPM. So the ortho drill doesn't have that much of RPM, and using that you are not going to do an extended curettage. So why this is important? Because Dr. Bhavin showed on the CT scan, the giant cell tumor will have this septase. Okay, so by using high speed burr, we are breaking all those septase, making into a single cavity, and you are removing additional 1 to 2 millimeters of bone in all the direction. Okay, so this is the one step that going to reduce the recurrence rate significantly, and this is the most important step, but this is the most common step which is missed when we are doing a curettage. So if you are don't have a burr, don't operate a case of giant cell tumor. It's a crime to do a curettage without using a burr. Okay, so that's a burr. So how you use the burr? So you have to be very careful. So it is a high speed. So it's a high speed burr. So make sure that you see each and every corner and address each and every corner. So spend adequate time. Okay. So spend adequate time. Make sure that you are seeing the whole cavity and adequate burr, make sure that you address each and every cavity. This is most important. Wherever there is soft tissue component, you excise it completely, and these are the edges where you have disease. So make sure that you address each and every part of the tumor, and you have to be little careful when there is soft tissue component, because the vessel will be just beneath the fat there. So make sure that the vessel is not damaged. Spend adequate time and address each and every corner, and that's how you do the curettage. Sorry, I'll just take 2 minutes to go back to my old slide. Okay, so this is the how the extended curettage looks. So you can make the difference, like how it was after the simple curettage and how it is after the extended curettage. So this is the step which reduces the local recurrence significantly. So you should be able to see the tumor completely. There is no lesion completely. There is no tumor left. You should be able to visualize the each and every corner. So there are many meta-analysis which mentions that using a high-speed burr reduces the local recurrence significantly. You can see this, just use of high-speed burr reduces the local recurrence from 40% to almost 20%. Now, my dear friend told adjuvants going to help in reducing the local recurrence. Yes, there is a debate, huge debate, but there are a lot of meta-analysis which has shown that adjuvant is not going to make much difference in the local recurrence. So what is going to help is how you get adequate mechanical clearance. So if you don't do a clearance, and even if you add whatever you want inside, it's not going to work. Okay, so get adequate clearance and then use the adjuvant. So adjuvant doesn't help. In case if you want to use for your satisfaction, you can use. But one important thing I want to mention is you should know the property of adjuvants, because all adjuvants are tissue toxic. You don't know how they work, and if you just pour it, you will land in disaster. So this is one of the case where the curettage has been done and liquid nitrogen has been poured into the tibia, and there is complete tissue damage and patient landed up with amputation. So what I mean to say is not to use them, but you should know their properties and how to use before, otherwise it will be a big issue. So now coming to reconstruction. So a lot of questions has been asked how to reconstruct, whether to use the cement, whether to use the bone graft, whether you used to use the combination. But I tell you, whether you use cement or you use bone graft, or you use cement and bone graft, there is not going to be much difference in the overall functional or oncological outcome. Yes, the reconstruction, certain reconstruction have their own advantages, but it's not a huge difference. So whenever I say my orthopedic colleagues that yesterday I did a giant cell tumor, the first question they ask is, what did you use for reconstruction? Because as a general orthopedicians, we are reconstructive surgeons. We have to fix, we have to plate it, and we want to reconstruct it. But as an orthopedic oncologist, for me the most worrying thing is how I got my clearance done. So next time when someone says that I have done a giant cell tumor, don't ask how they have done a reconstruction, ask them how much or how well they did get the clearance. Okay, so that is most important question. So you can use either bone graft or cement. So usually they produces decent functional outcomes. Video is not playing. So they just wanted to show both cases having similar functional outcome in this case where I use the cement and the bone graft. Sorry. So having pathological fracture intra-articular which is not displaced much, not a contraindication for extended curettage. So you can see there's a small intra-articular fracture which is undisplaced. So again we have used the same principle, done a curettage and fixed with the K-wires and reconstructed with the cement. Yes, sometimes if the lesion is very big and you know that after the curettage you won't be able to reconstruct, we excise the tumor and use a prosthesis like this. So what is the disadvantage of prosthesis? We say that yeah, prosthesis is excellent, patient get excellent function, but we can't match to the normal joint and the bone which the God has given. So these prostheses have lifetime, they have to be changed once in 15 to 20 years, patient can't squat, they can't get into their active sports or contact sports. So identifying giant cell tumor earliest and doing a proper procedure And avoiding recurrence is most key, because these patients are not going to die because of giant cell tumor. They're going to live their whole life. And if you can save their joint, that will be the fantastic thing we can do it. So don't take giant cell tumor lightly, because why we take it lightly? Because we know that patient is not going to die, and even if it recurs, we can do something. But that should not be the attitude when we are doing a giant cell tumor. The attitude should be, this patient is not going to die because of this tumor. So I have to do the best so that he doesn't get recurrence and he gets the best functional outcome. So now I'll just show you the video of how we do the procedure. So this is the Campanacci grade 2. So there is involving of the distal femur there. So I'll show the MRI that there is no cortical break. Only there is expansion of the cortex, which you can see here. So biopsy proven giant cell tumor. Okay. So we don't operate any case without biopsy. And one more thing I want to mention is there is no role of frozen intraoperatively to confirm the diagnosis. Okay, our madam is missing here. So it is very difficult for a pathologist to just on the frozen say whether it's a benign or malignant. They can say there is giant cells or not, but it's very difficult to say them for them whether it's a benign or malignant. So please do a biopsy pre-operatively, confirm it is the giant cell tumor. And what blood test you are going to do it? What blood test? Alkaline phosphatase is must. Why? Yes. So these two things are must before operating a patient of giant cell tumor. Okay. So no frozen. So all the cases we wherever we possible to use tourniquet, we try to do under tourniquet. So that is the tumor length has been marked, and biopsy scar usually I excise it. If there's any contamination, we are going to clear it. So that's some from the medial side we are operating. So once you take out, so facial lata has been cut and the vastus medialis has been lifted. So now I am reaching that ballooned part of the distal femur there. So once I do that, I use hydrogen peroxide soaked mop to pack on the either side. So that's the lesion which I am marking and showing, and that's a biopsy scar. So use a hydrogen peroxide soaked mop. And so what I want to show here is, so usually we divide the giant cell tumor curettage into two aspects. First is the disease clearance, and second is the how we do the reconstruction. So for disease clearance, whatever instrument we use, we don't take it back on the trolley. So we use a separate mop or you use a separate sheet and keep all your instrument there so that you are not contaminating the trolley which is used for the reconstruction purpose. Okay, so keep all the instruments there. So now you can see I have packed with hydrogen peroxide on the either side, and the balloon part is a weak bone, so I am just using my cautery to cut it. You can use the osteotome also to break wherever there is a thick bone. So once it's done, so excise that soft tissue part which is there and take a bowl with saline and put it in. Avoid contamination, dropping the tumor on the table or on the patient. So that part is cut, yes, and that kept in the bowl. So then we use scoops and spoon to take out the tumor. That is the simple curettage where we take out the tumor. So you can use nibbler to take out the soft tissue, jelly material like that. Don't drop it, don't contaminate the surrounding soft tissue. And I don't ask my assistant to touch near the tumor. I don't want contamination from their hand to spread to the surrounding area. So then use scoop roughly against the good bone which is there, and little gentle area where there is no bone, and try to take off as much tumor as possible. Okay, so that is the end of simple curettage. If I stop my procedure here, which most of our colleagues does, then the chance of recurrence will be more than 50%. So then we send the material for histopathology, send the whole material shift it from the table because we don't want someone to touch it and spill the whole tumor in the operating area. So that's the burr which we use. So spend adequate time. If you want to open the window, make it a big window. Make sure that you are seeing each and every corner. Break all the septae. Remove 1 to 2 millimeters of normal bone. You have to be very careful when you are using against the articular cartilage. You can damage the cartilage. You can perforate the cartilage. Or when you are using on the soft tissue component, because the vessel will be very just beneath the soft tissue, the posterior cortex. So spend adequate time, make sure that you get adequate clearance, keep washing, see the area, and then use the burr again. So once it's done, as adjuvant, I use hydrogen peroxide because this is very simple, not much tissue toxic. And also after washing, it gives a good visualization, it removes the blood and gives a good visualization. And pulse lavage is must to take away the whatever the debris is there and whatever the blood is there. So give a good wash with pulse lavage, and that's how the cavity appears after doing the extended curettage. So once it's done, change your glove, change the sheet, and remove the contaminated instruments. So in this case, I have done cementing. So we have put the plate, and then use the cement to fill the defect. So when the cement is setting, we know that it produces exothermic reaction. So we pour saline so that there is no damage to the articular cartilage. Okay, and that's how the post-op X-ray looks. So that is the extended curettage. Thank you so much. So any doubt I would love to answer.
So one thing is, the curators was the initial treatment in our days, but now it is termed as extended curators. So how, what is the difference between the curators and the extended curators? What are the components added in extended curators that will be beneficial for the
Sir, extended curettage has two parts. That's what I showed. One is the mechanical part, and second one is the use of adjuvants. So mechanical part is, as I told you, you have to use a high-speed burr. If there is no high-speed burr, don't touch giant cell tumor. That's very clear. There is no confusion. You can't use it on our Manman drill or synthesis drill. No, it's not going to work, and you won't be able to get a clearance. Second, the most important thing is make adequate opening. So we always want many things. We want to do MIPO, we want to do keyhole arthroscopic surgeries, but when it comes to tumor, the incision doesn't matter. So you have to open so that you are able to see everything clearly. So first is the mechanical burr, and second use of adjuvant. Yes, there is controversy whether the adjuvant works or doesn't work. We use hydrogen peroxide. But if you want to use phenol or if you want to liquid nitrogen, you should know their property and how to use it. So these are the most important things which constitute the part of extended curettage.
Now, as because there is, I hope that many are PGTs. So, Suman, as it is expressed very nicely and demonstrated very nicely how it is done. But on the point of examiners, they are little younger than me, and they believe in some other ways. So extended curators, he has already mentioned that it is the not making the window, rather it is the door. So it should be wide enough to get access to the all corners. And the success, as you have already received, that is how meticulously curettage is being done. So in our days, when the high-speed bar was not available, during that period I used to treat with the simple curettage of different size. There's a small to large, different size, and used to spend a good amount of time, that is about 2 hours to curate it meticulously.
Yes, sir.
And I found that in my 60 case series, there only one case required. So even without the bar. So it is the anesthetist, the assistant, the sisters of the OT, all are disgusted with the time taking. But I used to spend time for 2 hours for the curators to go to each corner, and I get the result of one recurrence in 60 cases. So that is the most
Yes,
important
yes.
thing you have to receive. And the second thing is regarding the adjuvant. Adjuvant, he has mentioned the hydrogen peroxide, which we also used to use, hydrogen peroxide. But I asked it to Ajay Puru in some meet. Then he said that I use all. So hydrogen peroxide, your alcohol, and also the phenol, all he used to use.
Maybe
That I
alcohol in the
decided.
evening, sir. But
Yes.
no, I'm sorry. But means in TMH, yes, they don't use all, so it's mainly hydrogen peroxide. But people who are trained from TMH have used various things. Like Dr. Mandip Shah is there in Gujarat. He uses phenol and alcohol, and Dr. Chandra from RDR, they uses liquid nitrogen. So I'm not against using any adjuvants, but you should know their property because they are highly tissue toxic. You can't just close your eyes and pour it.
The last point, what I like to mention, that is whether that if there is some subchondral bone erosion also, subchondral bone erosion. In that way, in that case, if you put the as the space filler, the bone cement, which has the thermo toxic effect and killing the remnant of the cells. But in that case, if we put the bone cement in the subchondral region, that will not regenerate and it will go for the early degenerative changes. So in that case, you have to do something as it is described in the literature. Na?
Sir, actually, there are a lot of studies which have shown that actually putting bone in the subchondral area has not increased the chance of early osteoarthritis. That's a new data which has come. But as you told, yes, always better to have bone in the subchondral area. So that's what the reconstruction option depends from surgeon to surgeon. So what I wanted to say is first get a adequate clearance. First get a proper disease clearance. Then, as I told you, want to put cement, bone in the subchondral bone, and then cement, do a sandwich is fine. Or if you want to use cement is fine. Or you want to use complete bone, that's also fine. But getting a disease clearance complete is important. So that is the most important aspect.
Okay, so the last point, I forgot it. Okay. Oh, yes. So last point is for the PGTs. This is what he is saying as from the renowned oncologist, okay, oncosurgeon. So what in giant cell tumor, the most important treatment is the intralesional excision. That is the extended curettage in this case. So it is not the reconstruction or excision that has people has a tendency to go for the excision where it is expendable.
Yes.
So that should be avoided.
Yes.
So when it is possible to go for the extended curettage, that should be the primary choice. Even in this stage 2, of course, even in Kapanaki stage 3, even.
Yes, 100%. So, sir was absolutely right. So, Campanachi grade 3 doesn't mean excision. So, most of, I think 70 to 80% of our cases will be Campanachi grade 3. I think Dr. Kaushik will be agree because type 1 usually, grade 1 and grade 2 usually doesn't produce much of the symptoms, and then when the patient comes to us, it will be always grade 3. So, grade 3 doesn't mean that we have to excise it. So even grade 3, around 70 to 80% of the cases, we try to do a curettage. As I told you, the criteria is after doing extended curettage, if you feel that adequate bone is left for the reconstruction, that is where we go for curettage. Excision is easy, 0% recurrence. But if you put a prosthesis, it has to be changed every 10 to 15 years. Patient cannot squat, sit cross-legged, he cannot run. You can't go to active sports. So all those problems are there. Okay. So at present, our indication has even increased in saving the joints. than excision. As we do, we have improved over time, and our recurrence rates have come down. So those cases probably which were used to be excised 10 years back, I think we are trying to salvage them with a decent outcome. So that's a message I wanted to give.
One more thing is, suppose in the lower end of the tumor, the giant cell tumor is, and you have treated the local site as it is already described. But along with that, you can find one metastasis in the lung. So what should be your attitude in that case?
Sir, having a giant cell tumor with lung mets is as low as 2 to 4%. The chance of metastasis increases with the recurrence. Patient is having recurrent disease, the chance increases. Second, if there's a long-standing disease in the body, the chance of recurrence increases. So ideally, yes, there are two schools of thought. Some people believe that the lung mets grows very slowly or sometimes become static so they can absorb. And some school believe that because they are benign lesion, better to take it out because patient is not going to die. Okay. So what I believe is if lung mets are there, if they are resectable nowadays, like how you guys are doing arthroscopic surgeries, our thoracic surgeons are doing able to do VATS resection, which is very less morbid and patient can be sent home on the second day. So if lung mets are resectable, it is better to resect. The condition where it's not resectable, we have medications like zoledronic acid and denosumab to treat with.
Just a clarification for our postgraduates. When they write answers, we often come across that up to stage 2 we do curettage and stage 3 onwards. The examiners would want a textbook answer. I agree that now the stage 3 is an extended indication. And of course there is the role of denosumab also. So in stage 3 Campanachi you can give denosumab, get the margin so that it becomes easier to curate out. But what should be the answer for the postgraduates when they write, when a question comes? The other question is, we've got DNB trainees who've got a standard short note used to come as sandwich technique. So what is the current role or status of the sandwich technique? Is it still advocated, not advocated? So if you would clarify for the postgraduates, that'll be nice.
Thank you, sir. Good question. See, actually, even in grade 3, it's not like the trend of curettage has come in past few years. So even in grade 3, the curettage has been done and as were doing from decades. So there are papers to say that the grade 3 can be curatable. So it's not like we need to excise it. So the answer should be yes, grade 3 you can do curettage, but depends upon what is the bone quality and what is the amount of bone which going to be remain after the curettage. Ideally, what you can see for theoretic purpose, what you can say is after doing extended curettage, if you can save 2/3 of the cortical bone, you can go and do the salvage. So that is the word you can use it. And you can mention that in grade 3, the chance of local recurrence is around 20 to 30%, which is more than grade 2 and grade 1. So it doesn't mean that all grade 3 require excision. Okay. So coming to next question, coming to sandwich. So sandwich technique is used in the condition where there is no subchondral bone, with the intention that putting a biological material under the chondral bone going to reduce the chance of osteoarthritis. So is there any role at present? As I told you, it's a big controversy. Nobody can say whether it's correct to do it or not correct to do it. But ideally, in your examination, most of the ideal best safest way to answer is you can do a sandwich method in the cases where there is no subchondral bone, because you are putting bone, biological thing, under the area and giving a stable reconstruction cement on it. Okay, so that's the answer I would prefer. If you ask me whether you are doing, I have not done sandwich because my concept is different, so I have not done sandwich. But for your exam purpose, you can say sandwich can be used where there is less than 5 millimeter of subchondral bone. Using the bone graft beneath the chondral area is more biological and reduces the chance of osteoarthritis.
Regarding high speed bar, is there any cutoff regarding the RPM the bar?
I think if it's less than 20,000, it's not going to be useful. And the burr which we use, Medtronic one, usually we use at the RPM of 60,000 to 70,000, which we use in our regular giant cell tumor cases. But if you feel your RPM is less than 20,000, it's not going to work.
And the second question which I face regularly from our assisting residents when they assist me, how we are using the meticulous curettage, high speed bar. So they frequently ask me the question, sir, how would you assess that this is a meticulous curettage? What is there any objective evidence or subjective, or how far I should bar?
Okay, so ideally would be, you should break all the septas. It should be a smooth margin. There should not be any bumps you can see. So you should break all the septas, and from wherever after the curettage, ideally it is better to take 2 to 3 millimeters of normal bone. So when we use the burr, better take 2 to 3 millimeters of normal bone. Obviously that's not going to be possible on the cartilage side, but when you're talking about the surrounding bone, ideally better to remove 2 to 3 millimeters of normal bone in all the direction. Because most of the cases we will be doing under tourniquet, saying that active bleeding, good bleeding, it's not going to work intraoperatively. Okay, so what we do is we try to remove around 2 to 3 millimeters of bone in all the directions.
What is your take in a protocol in the use of denosumab?
I think I told in the morning it's little tricky. The use of denosumab can be classified into 3 types. The first one is the definitive denosumab. The cases like GCT of the sacrum, GCT of the spine, where I know that I won't be able to get the complete disease clearance. We are going to treat the patient only with injection denosumab. But at present, the protocol says that the injection has to be given lifelong. If we stop the injection, then there is chance of local recurrence. Second indication is large tumor in the distal femur, no bone, any area, no bone left. The plan is to do excision and reconstruction, but we know that giant cell tumor are highly vascular and they are jelly-like. So when you are operating, when you are maneuvering, it may rupture, it may open, and there is high vascularity. You can give in that cases to reduce the vascularity and make tumor little hard so that it will help in excision. And the third indication is in Campanacci grade 3 borderline cases, where you feel that if you can get little extra cortex, you can do a curettage instead of an excision. We give denosumab and then do the curettage. So these are the 3 indications, but the last indication which I told, it's very subjective. For your exam purpose, just keep these 3 indications. And that's what the answer is expected, even if there's a question in the theory or even in the practical.
So we will talk on the grade second. What is second indication? So you're planning for the excision later on. So how many doses you will give at what interval?
See, the main idea is to reduce the vascularity and make tumor little hard. Okay, so what I would do is, there is no standard protocol. So what I would do is I give it 0 and 7, 2 injections, and operate patient after 3 to 4 weeks. Yes, in X-ray there won't be much change, but I don't want X-ray to be looking like a very hard mass to remove it. So with 2 injections with 1 week apart going to reduce the vascularity significantly and also makes the tumor hard. So I would like to give 2 injections, operate after 3 to 4 weeks.
3 to 4 weeks interval you used to put?
Yes.
So to complete this subject, what about your message to the students? The multifocal giant cell tumor, metaclonus and synchronous.
So it's a very good question, but it's a very rare condition. In I think 10 years I have seen 2 cases, and both the cases were at TMH Mumbai. So it's a very rare condition. So if the patient of a giant cell tumor diagnosed having significant symptoms in the other part of the bone, then we will screen them with either bone scan to look for the lesion. But the outcome would be same. There is no difference in the overall outcome, whether if it's a isolated GCT or if there is a multicentric GCT. The treatment principle would remain the same. If both the lesions are curatable, we are going to curate it. If one required resection, other required curate, so the treatment is not going to change. So this, but the percentage of this metachronous GCT is very rare. I think maybe 1% or less than that. But the treatment is option. Treatment principle is same. Based on whatever I told, whether you want to do a curettage or excision, it is planned accordingly.
Actually, theoretically, the synchronous, if it is multicentric, then it may be synchronous when the second lesion starts within 6 months of the first. That is synchronous. But when it appears after 6 months, then it is called metachronous. So that is theoretical.
Theoretically, yes.
Sir, has zoledronic acid any role for if you use locally after clearance?
Okay, so there are few articles which has shown there is a small, reduction in the local recurrence, but these are very small articles from one or two articles which is there. So there is not much study has been done, or people have not seen much help of putting zoledronic acid. So at present we are not using it because it has not shown significant reduction in the local recurrence. Only few centers have done, and the numbers are very small to take it.
So one more question: can we use sclerosant like palidocanol?
No, palidocanol doesn't work in giant cell tumor.
Only ABC.
Because giant cell tumor, there are tumorous spindle cells, so that's not going to be get affected by palidocanol.
How to follow up after extended curettage?
So what we do is we call the patient once in 3 months, get local X-ray, and every alternative visit we get chest X-ray. Means once in 6 months we get chest X-ray, local X-ray every 3 months. We do it for 2 years because the chance of recurrence is more in first 2 years. After the patient passes 2 years, I call them at once in 6 months for next 3 years. So that till the 5 years. Every 6 months. After 2 years, once in a year. The chance of it coming back is very less.
Thank you, sir, for such an informative session. As it is rightly said, being a surgeon is not just about cutting. I would now like to request Dr. Manish, interventional radiologist at Medica Hospital, Kolkata, to enlighten us about the non-surgical management of benign bony lesions.
A very good afternoon, everyone, and I would like to thank first to Dr. Kaushik and the whole organizing team, my senior teachers and my colleagues and juniors for inviting me on this topic. My talk will be on non-surgical management of the benign bone tumors. So far, we have learned from the eminent faculties in their field regarding the radiological aspects, that how to make a diagnosis and how the surgical management helps. Now I will be talking something else, non-surgical management. So I'll just touch on the role of intervention radiology pertaining to the MSK, mainly the tumor, because it is an onco session. Benign bone tumors is the main topic, but I'll just touch whether means we have the option of intervention radiology in case of malignant bone neoplasm. And I think I'll be answering some of the questions in the last discussion, that whether IR has some role in that, and what are the non-surgical IR treatment options, some cases, expanding indications, and what are the future. I have divided role of intervention radiology in MSK neoplasm into 3. Vascular neoplasm or the vascular malformations, benign vascular malformations. We have the intent of treatment is curative. Always in vascular malformation, depending on the location, the first intent is curative. Second treatment is preoperative embolization. Some surgeons ask us, it is highly vascular tumor, it is having a AV fistula component, not only the slow flow vascular malformation, can you just embolize it? I am going to excise it. So we have a role in that vascular malformations. But this is not a topic of today. Today's topic is mainly benign bone tumors. So again in benign bone tumors, we can make it a curative intent, pre-operative, and some adjunct as a multimodality treatment options. I'll be coming into those details. In malignant tumors, mainly as a palliative and as an adjunct to other systemic therapy or the radiotherapy like that. So the benign bone tumors, why we need treatment? This is not now, it should not be discussed in the end of the discussion, like local complications compressing the healthy bone and the surrounding tissue make the patient symptomatic. Historically, only surgical options were the treatment, like the lesion resection, mechanical stabilization in various forms like graft, cement, like that. Now there are some non-surgical treatment, IR, onco treatment, and radiotherapy. I'll be covering the IR part. So benign bone tumors, the curative intent is our first target. Second is whether we can give some symptomatic relief. It might not be curative, but the patient's symptoms got relieved. It may require 2 to 3 sessions depending on the location, depending on the size, depending on the pathology. The most important part is IR treatment is repeatable. Why I am talking about the repeatability? Because we are talking about the recurrence. So whenever there is a recurrence, be it by after surgical management, be it either by after non-surgical management, this procedure can be repeatable. So can be combined with other treatment modality. This is a very good thing we should consider, that we can combine IR treatment with surgical treatment, we can combine IR treatment with just chemotherapy, systemic therapy, radiotherapy, if the pathology is non-resectable. The common indications we all know: osteoblastoma, hemangioma, GCT and ABC. Some light on why osteoblastoma needs treatment of IR. Approximately 12% of the all skeletal neoplasm is osteoblastoma, first and second decade of life. You people know better all these clinical things. Painful, severe at night, the typical history. Nidus is less than 1.5 centimeter typically, and the bigger version of osteoblastoma is osteoblastoma. So how we make a diagnosis? I am not a person after obviously Dr. Bhavin Jankaria to speak on the diagnostic part, but still, what I want to say that what makes osteoblastoma painful is the vascular nidus, and this vascular nidus is the thing culprit, and we should target the vascular nidus. If we can make anything just inactive of the vascular part of the nidus, the symptoms gets relieved. That is our target. So how to localize that vascular nidus? We have two very good modalities nowadays. Is the contrast enhanced MRI, in which we can see the intense contrast enhancement on a dynamic MRI imaging. Other than that, in some cases we cannot even make a difference between the nidus and the surrounding edema. Then in that case we can ask for a bone scintigraphy, and the radiotracer activity in uptake is the point of interest. Most common location, long bones. So osteoblastoma 4 types: intracortical, periosteal, spongiosal and subarticular. Why I am just highlighting this point? Because the recurrence rate, and second important thing is the result of the treatment, whether be it surgical or non-surgical, depends on this. The result in case of intracortical, periosteal, spongiosal is very much acceptable. Then subarticular, the complication rates are different in these two. Surgical resection, you people know better. So the percutaneous ablation of the osteoblastoma, this is now the treatment of choice. Why it has become a treatment of choice, I will be coming into that. So what are the options we have? Thermal ablations under whatever means we do is always under image guidance. So image guidance helps us give very precise localization. Heating, thermal ablation can be with heating and cool based. That I will be coming into that when I will be detailing that. Heating can be either via RFA, that is a radio frequency ablation, laser, microwave, freezing via the just cryoablation. The success rate is approximately 90 to 100%. What is success rate? Clinical success rate. Patient is symptom free. Complication rate is less than 2%. Again, recurrence, because we are always talking about the recurrence rate in the surgical management, we have to talk about the recurrence rate in non-surgical treatment is less than 5%. Why the recurrence rate is there? Just because we are not able to localize precisely. If we are not able to localize precisely, that makes the things to occur. So we have to be very precise. Second is osteoblastoma. As I told, it is the big brother of the osteoblastoma. This clinical part you know better, that it has a male predominance, more than 2 centimeter diameter. In osteoblastoma, microwave ablation and the cryoablation has very important. Why the cryoablation? Why not RFA? I'll be again talking on that. Just because cryoablation can cover a large area of ablation area. The ablation zone in the cryoablation is larger than the RFA. And that is why in case of osteoblastoma, we have a radiofrequency ablation as the treatment of choice. In case of osteoblastoma, we try to prefer cryoablation. Again, the technical success rate we match it with the osteoblastoma. Yeah, this is something vertebral hemangioma. Usually the hemangioma is a benign disease, benign course. It is only, treatment is only indicated when it becomes symptomatic. Now when the vertebral hemangioma becomes symptomatic, when it has a extra osseous component. When there is extra osseous component, it is going to compress the cord and making the patient symptomatic. Now the incidence is approximately 10 to 12%. Female has a bit slightly predominance. Only 1% of the vertebral hemangioma are symptomatic. Again, in case of non-surgical treatment options are like vertebroplasty as a pain relief management, sclerotherapy, just for the extra osseous component. Now the other options nowadays which has come is the alcohol treatment, cryoablation, transarterial embolization, radiotherapy and radiosurgery. Now giant cell tumor. In the last talk we have heard so much about the GCT, its surgical management. So the 20% of the benign tumors, 5% of the primary benign tumors, age group is 20 to 40, location predominantly around the knee, metaphyseal side of the epiphyseal end plate, and it extends within the 1 centimeter of the articular surface. So surgical resection is again the treatment of choice whenever surgery is feasible, but recurrence rate is high as Dr. Suman has already told. So the recurrence increases the transformation into a malignancy, approximately 10%. Now one more thing we have to think is, what we are talking about the GCT is not only a GCT. It may have some ABC component. Now this ABC component makes it more aggressive nature of the GCT. So some GCTs are very aggressive, some GCTs are less aggressive. It indirectly signifies that GCT may have a more aggressive variety, that is the aneurysmal bone cyst component. So the non-surgical treatment options in case of unresectable cases, like in case of the lumbosacral location, again the cryoablation and the transarterial embolization. I'll be covering that part in detail. Whenever we are talking about the lumbosacral region GCT, it is not a small tumor. It at least in cases of wide area, more than 5 centimeter, more than 10 centimeter area. In that cases, if we are doing something called cryoablation, something called transarterial embolization, we may need multiple sittings. Why we need it? I'll be telling that. Systemic therapy and the radiation therapy can be combined when we are doing the transarterial therapy. Again, aneurysmal bone cyst, since we are treating the GCT, we can also treat the aneurysmal bone cyst in the similar manner. Because the aneurysmal bone cyst components are very much of connective tissue, reactive, it is a reactive process, so it's a reactive bone, when bone and the blood filled spaces are there. So that is why there is a very good impact of transarterial embolization in case of the aneurysmal bone cyst. It also decreases your peri-procedure bleed, peri-procedure feasibility in case of surgery. So in case of aneurysmal bone cyst, the options are transarterial embolization is the preferred approach. Apart from that, sclerotherapy can be done, but the sclerosant has to be chosen wisely. Injection of the bisphosphonate or the doxycycline injection, cementoplasty and the ablation. Other rare benign tumors where intervention can be done, like fibrous dysplasia, especially in case of vertebra, only the role of pain relief, symptomatic. Enchondroma, chondromic swide, these are more of a literature. There is very less data on all this. Now, there are some indications in case of the malignant bone neoplasm. What is the intent? Intent in case of malignant bone neoplasm is palliation. What is and mainly for the pain relief. Second thing is oligometastatic disease. Just now, before me, one question was arised by the sir that if a GCT is there and there is a lung nodule, single nodule, what to do? If you ask me, I'll always say ablate this lung nodule because GCT is very slowly progressive. Even if it is having a malignant just transformation, ablate the lung nodule, do a resection of the GCT if it is possible, because ablation is a curative treatment option. So this can help patient to just escape from the more morbid treatment after the thoracoscopy or VATS. So in case of a non-respondent to EBRT, again a malignant bone, so it is also an indication for the IR therapy. Now, so non-surgical treatments, IR treatments is a multidisciplinary approach. We have to decide based on the multidisciplinary team. The pre-procedural consultation is very important. We should have to counsel the patient about what we are trying to achieve, because each pathology has a different goal. Each pathology, the treatment purpose is different, the results are different. We have to say that whether the patient may require second sitting or not. So pre-procedural consultation is very important. Optimized image guidance, this is also a very important related to technical part. That, like, a very good image guidance is required. Not a 2-slice CT is suppose won't give a optimized image guidance if we are doing the same thing, same ablation in 16 slice, 32 slice, 128 slice. So optimized image guidance important. Whether we should have take the help of ultrasound, where we will have to take the help of PET, where we will have to take the MRI guidance. Everything has to be optimized depending on the size of the lesion, depending on the disease pathology, and appropriate anesthesia. This is also important because most of the intervention radiology treatments are done under local anesthesia, but this is the area where I personally use most commonly sedation. That is the conscious sedation is the most. So non-surgical percutaneous treatment, it started in 1987 with the cementoplasty of the first C2 spinal hemangioma. The first non-surgical treatment was done in that. In case of osteoidostoma, it changed the game from 1990s from percutaneous ablation. At that time, the ablation of the osteoidostoma was done with alcohol or laser, because at that time RFA was not that much evolved. So for low vascular malformations, we have sclerotherapy and the embolization. So this was what I was talking, that non-surgical IR treatments I have divided into ablation therapy and non-ablative therapy. Ablation therapy can be divided into thermal and non-thermal. Thermal is again of two types: heat-based treatment, cold-based treatment. Heat-based treatments like laser, RFA, microwave. Cold-based treatment is cryotherapy. Now non-thermal, there are some new modalities of treatment like HIFU, IRA. What are all these? I'll discuss. Non-ablative therapy like sclerotherapy, most common agent, most cheap is alcohol ablation. There are some other ablating agent or the sclerosing agent, sorry. And second important thing is transarterial embolization. And the last but not the least is the vertebroplasty and cementoplasty. So radiofrequency ablation, it uses an alternating current to heat, to raise the temperature within the tumor. So that is the purpose, to increase the temperature of the tumor compared to the surrounding tissue. So the mechanism of cell death is the coagulative necrosis. It started with osteoidostoma. Now the indications has expanded into multiple times cases, as I told. Now in various malignancies, it is not, RFA is not only used in the osteoidostoma. RFA has a multiple vast indications like in the liver tumor, kidney tumor, lung tumor. That is why I said that if I would be given the option, I would ask that in case of GCT with lung metastasis, if the lung metastasis is ablatable or resectable, I would give the option of ablation. Other indications like painful metastasis requiring repeated EBRT even after EBRT, because there are some metastasis like in case of renal cancer or the colon cancer, the bone metastasis are not very much sensitive to radiotherapy. In that cases, we can offer a RFA or the ablative therapy just for a pain relief. So effect is not related to histological type of metastasis, unlike the EBRT. Now something about the cryotherapy. Most of the people ask me why, means whether this patient should be given option of cryoablation or RFA ablation. So this cryoablation, as I told, is a cold based modality. cold based, but it is a thermal modality. Originally, people used to do cryotherapy in surgery, you people know better, with the help of liquid nitrogen. Now the development of argon based cryotherapy in 1990s, it made the availability of cryotherapy in higher shoot, because the probe, the applicators, the size of the applicators got reduced. So the advantage, what is the advantage of cryotherapy? Because ice ball formation, it is a temperature based again, but what is not means what was not in case of RFA or microwave, we cannot see which part of the zone we are ablating. But in case of cryotherapy, the ice ball formation, this ice ball formation phenomenon means we can see on imaging. So this is a real time assessment of what ablation zone we are getting. So this is the at least only modality where we can monitor the ablation zone in real time, because ice ball formation we can see on either CT scan, also on ultrasound and all MRI. So the mechanism in case of cryoablation is multifactorial cell death. Like we get the temperature down as less as minus 40 degrees Celsius. So in case of minus 40 degree, the immediate cell death occurs just because of toxicity of the ice. And between the 0 to 40 degree, means in the temperature range of 0 to minus 40 degree, the cell death occurs by the disruption of cell membrane. This disruption of cell membrane, why it occurs? Because of the osmosis phenomenon, the extracellular component and the intracellular component water reverses, and that causes the disruption of the cell membrane. So in cryoablation we have the multifactorial, multiple levels we can cause the cell death. So this makes this modality suitable to ablate a larger zone. This is not in case of the RFA and microwave ablation. So we can ablate even a 5 centimeter lesion, 6 centimeter, even up to 10 centimeter lesions has been ablated with a cryoablation. It is less painful than RFA, faster reduction in the painkiller, can treat sclerotic mets because ice growth is not limited by the bone density. But in case of the sclerotic mets, the choice is not good for RFA. So that is why it has to be discussed that which modality is good for means which type of patients. If the osteoblastoma is there having a very good sclerosis, it means it is very difficult to get access into the nidus, I'll personally prefer that such kind of patients should be treated with cryoablation. The only limitation in our setup is cost and the availability. So there are some cases. This is a 15 years male, typical history of osteoblastoma pain, which aggravates at night. Patient was on NSAIDs. No doubt all the cases has been referred from the orthopedic surgeons only. So this is a CT scan, which you can see here is the radiolucent area, which is the nidus. This is in the coronal section. This is small nidus measuring approximately 1 centimeter. This is the contrast enhanced MRI. Yeah, what I was talking in this, see in the case of contrast enhanced MRI, this lesion might appear big when we see, just have a look on the first time look. But this whole thing is not the disease. The actual pathology is the vascular nidus. So we have to target this vascular nidus, not the whole disease process. This is edema. So we don't have to treat this. We have to treat the vascular. That is what I was talking about earlier. So this is the nidus part. We have to treat this. We have to target this. We have to precise enough to reach there. This is the bone scintigraphy scan, which we can see that this is the vascular nidus having a radiotracer uptake. So this is the RFA. What I was talking about, we have to target this nidus. We have to get into the our RFA probe into that nidus. One thing, it's not related to it will be more of a practical thing. In RFA, we need to reach there with a separate needle. Separate needle means, suppose we can have a bone biopsy needle, we can have a drilling approach. If the lesion is surrounded by a very good sclerosis, then we can have a bone drill also. So to reach there, we have multiple options. Once we reach there, we have to insert that RFA antenna into the nidus, the whole into the center of the nidus, and this can cover maximum up to 1 centimeter, 1.5 centimeter maximum. That's the only demerit of, or the, you can say, limitation of RFA. So the patient got cured. This was done here only in this hospital only 1 year ago. Till now the patient is symptom free. So this is a second case, 27 years female, complaining of sudden onset paraparesis 1 week postpartum. The patient was a known case of hemangioma, vertebral hemangioma. Postpartum she got suddenly paraparesis. So this is the old image. I'm sorry for the bad image quality because this is the old picture the patient was having earlier. So here you can see that this is the dorsal vertebra. I could not name, here it's written I think D6. Yeah. So in the D6 vertebral body, the typical feature of hyperintensity signal in case of the T2 weighted MRI with a polka dot sign, a classical picture of hemangioma. But what is different from a normal hemangioma, that we have to look. This hemangioma is having some extraosseous component compressing over the anterior thecal sac, causing the signal changes, myelopathic changes into the cord. So that is causing the symptom. So this means this hemangioma is not a simple benign hemangioma, it is having a aggressive nature. So it needs treatment. So this patient was referred that whether we can do something for this patient. We offered transarterial embolization. So as I told, in case of hemangioma we have some options like sclerotherapy, like transarterial embolization. We preferred in this setting transarterial. Why? Because most of the part of the lesion was involving the body. We have to decrease the vascularity. By decreasing the vascularity we can reduce the size. We can expect the reduction in the size of the extraosseous compartment. Extraosseous component, if we reduce it means there is a chance of permanent, means we can prevent the patient from permanent neurological loss. So this is the transarterial embolization. This is the diagnostic run of the left side. This vertebral hemangioma is being supplied from the left side. This is the D6, the posterior intercostal artery. So what is different from the normal understanding is we are not, means we have to embolize that specific feeder. We have to go into that specific feeder branch. We have to embolize that feeder. Rest of the preserving other spinal arteries, other origin of the spinal artery or the muscular branches. That is the purpose. So we cannot embolize from here. Though we are able to see the vascular blast, though we are able to see that this hemangioma is supplying from this artery, the purpose is not to close this artery. The purpose is to preserve this artery, at the same time close this. So we have to embolize this. If we can close this artery, this hemangioma is going to take the feeder from other branch. So that is not the purpose. So this is the pre-embolization again. This is the first feeder. This is something technical which I was saying, that we have to embolize this part, vertebral hemangioma, not the feeder. Means we have to go via the feeder into the vertebral hemangioma, preserving this whole feeder, so that if we can embolize this nidus, in future there is no scope that this vascular nidus can take the vascularity from other vessels. So this is the common mistake the people can have understanding. So this is the post embolization. You can see that whatever embolizing material I have used has been concentrated into the nidus, that is the hemangioma of the vertebral body. This branch is still preserved. So this branch will help collateralize into the other branches of the posterior intercostal artery. But there won't be any further vascularization or angiogenesis of this vertebral hemangioma. That is the purpose. So this was done from the left side. Again from the right side still there was a second feeder. So again the same thing I have to do, that we have to go into this small branch, preserving this branch, the main feeder. So this is the vessel post embolization. We can see that now from both the sides there is no further vascular blast of the hemangioma. On follow-up, the patient was given to some rehab center for the physiotherapy and all, and after 6 months the patient came back. I don't have the clinical picture. So this is the case 3, 19 years male, known case of hypervascular giant cell tumor in the sacrum. Again the location is important in case of giant cell tumor. As in the previous talk, it is difficult for surgery. So this is the sacrum. You can see here the T1 inverted images, the hypointensity signal. Again, this hypointensity signal or the mass having extraosseous component, the almost right side of the sacrum with the almost complete body of the sacrum is involving the hyperintensity. So again the same thing, that in case of the arterial we offer the same, the transarterial embolization. We just went into the specific feeder branch, not the complete, at least the preserving the complete branches of the internal iliac artery. And like this, I'll just sum up fast, that what I want to say, that we have to go selectively, super selectively into that branch and just embolize that, and the rest of the branches has to be preserved. So this is the post embolization CT, which has made very helpful in case of post embolization, like whether our embolizing agent has been deposited into the right space or not. So the improvement in the image guidance has helped intervention radiology in extending or the expanding the indications of the non-surgical treatment. Especially I would like to highlight that CBCT, that is the cone beam CT integrated into the IR suite, has made us very just at least being very precise. So expanding the indications of the MSK again, just because of the use of thermocouples in case of the RFA or the microwave neurophysiologic monitoring we can do during the procedure, continuous the development of the newer modalities like the cryoablation. So the future perspectives, like we have the facility of contrast enhanced MRI guided ablation, PET guided ablation we can have. I'm not going into the details. Some light about HIFU, high intensity focus ultrasound. It is completely non-invasive because whatever is done from outside the skin. So it is always ultrasound guided or the MRI guided, but the only limitation is we should have a clear acoustic window. That is the limitation of the HIFU. Again, the microwave and the irreversible electroporation is having still now limited data on the MSK. So the conclusion is minimal invasive percutaneous image guided procedure is safe and effective. Ablation is now preferred treatment over the surgery in case of osteoblastoma, expanding indications in case of benign bone tumors, repeatability of the procedures, optimal patient selection and the modality selection, and the image guidance has advanced. So this is the key to the success of IR procedures. It can be combined with multiple modalities. Thank you. Any questions?
Questions for Dr. Manish, he would be happy to answer. In the meantime, I would request Dr. Suman to arrange his cases on panel discussion on benign bone tumors. Yes, Dr. Rahim.
Does cell death occur? Does cell death occur? Does cell death occur in case of cryotherapy, like in sub-zero temperature, 0 to minus 40 degree, due to cell disruption followed by osmosis? Or osmosis?
No, due to osmosis there is the disruption of the cell membrane and that causes the cell death.
Then in sub-zero temperature, osmosis will not occur usually because the solvent, that is water, will go into freezing. So
no, that is why we just reverse the cycles. We do the freezing and thawing, both. Okay, thank you.
Keep those lights on, otherwise it's a post-lunch session, everyone will go for deep sleep. Okay, so I have just half an hour, Kaushik has warned me, so if you guys are active and interactive, we'll try to cover as many cases as possible. Okay,
So 21-year-old, we are not going to discuss about, so this is purely surgery. So orthopedicians should be awake and participating. So we are not wasting any time. So 24-year-old, biopsy proven giant cell tumor of the proximal tibia. So that's a lesion. So you can see there is a lesion which is going into the intercondylar notch, but there is no damage in that area. There is subchondral loss here. So that's the X-ray and the MRI. So I'll show the further MRI. So there's a soft tissue component anteriorly, you can see here, and that's a lesion. So quick question: how many want to do a curettage and how many want to do the excision? Curettage, how many? Okay, excision, how many? Only one. Rest want to refer. At least you should have some answer. Excision, only one person. Okay. Curettage? Okay. So, just I am going to skip all these things which I just mentioned in my previous talk. If you want to do curettage, those people who said want to do curettage, want to do upfront curettage, or you want to give denzumab, or how you want to do? Kaushik. It's a biopsy proven giant cell tumor. So we are not talking about diagnosis, we are directly going into the management.
We'll do a extended curettage upfront in this case.
Upfront, so you don't want to give denzumab?
For this patient, we'll
Okay, sir, what do you want to do? Upfront surgery? Sir, what do you want to do?
Upfront surgery is okay.
Yeah. Just on the mic.
Yeah, we can straight away proceed. You've got quite a bit of margin there. And the wall is not as flimsy as it appears.
Okay, so I know Dr. Chandra Kumar has a little difference in the opinion here. You want to give denzumab or you want to do upfront curettage?
I'll give denosumab before.
Okay, just quick answer. Why and how you give? How many doses you give?
Why I'm giving is because I feel the subchondral bone is almost lost in the lateral part, and so I'll give maybe 3 doses, 0, 7, and after 3 weeks, 1 more dose, and after 3 weeks I'll take the patient for curettage.
Okay, so what are the intra-op changes you find after giving denzumab?
With this dose, what I'll get is I'll get some bone against which I can cure it.
So usually giant cell tumor, we know that it's a jelly-like material, but when we give denzumab, it becomes hard and like a little fibrotic tissue. Okay, so Dr. Chandra wants to give denzumab and operate, and there are so many others who want to do upfront curettage, and there's one of my friend who wants to do excision. So let's show what we did in our case. So yes, like what the majority told, we did curettage in this case. So that's the soft tissue component which isolated. So same procedure which I mentioned. Then the soft tissue component has been excised. So then we have done an extended curettage. First is the simple curettage followed by extended curettage. And I have used same patient iliac crust to support the subchondral area. And we have used the fibula as a stud graft. So why I put this picture is, you don't have to fill the whole cavity. You need to give structural support. That is more than enough. So no need to fill each and every corner of the cavity. That is not required. So I just want to show the image if it's playing. Okay. So that's how they have gone up to the subchondral notch. There is no subchondral notch. That is, there is no subchondral bone also. So that's the cartilage you can see. And anteriorly also there is no bone there. Okay. So that is the stability intraoperatively. So I have used the K-wire and the iliac crust and the fibula. That's the stability. It is completely stable and the joint is. So you can see I am wearing glass, so it was done in COVID time, so patient is at least 3 years follow-up. I am not lying, so I'll just show the follow-up. So that's the immediate post-op X-ray. So I have supported the subcondylar. So main idea is to give a stable construction under the cartilage. So I have used the iliac crest to support the cartilage there, and I have used the fibula to just support the iliac crest which I have used. So that is the X-ray. In the follow-up, you can see that the bone graft has beautifully united, and that's the function of the patient.
Focus. Bunny.
Okay, so that's the first case. So what I want to show is probably we would have done excision in these cases like maybe 10 years, 15 years back. But nowadays we are into this specialty, doing these cases regularly. So even the cases where there is no subchondral bone or there is a defect in the cartilage in the non-weight bearing part of the bone, still we are pushing and trying to do the curettage and save the joint. So that's a functional outcome. You won't get this functional outcome even if you do the prosthesis. So this case has been more than 3.5 years. She's probably disease free. Now she can live normal life, doesn't require any revision surgeries. So I just show you the role of denosumab. We were talking about the indication. I just show you the X-ray. So that's a case. There is no bone on the lateral aspect. So denosumab has been given to get some bone. This is the first kind of indication to do the curettage. And second kind of indication, big tumor, highly vascular, chance of tumor spillage intraoperatively. Denosumab is given. It becomes hard, less vascularity, easy to operate. And in the definitive type 3 indication, sacrum lesion, this nobody will be able to cure it and get a disease clearance. So there we are going to use. So these are the 3 indications of denosumab. So I'm not going to go in detail. Okay, next case. 32-year-old male, IT profession from Bangalore, had giant cell tumor, and one of our ortho colleague went ahead and did a curettage with bone grafting, and within 6 months the patient had a local recurrence. So this is the X-ray. You can see the bone graft fibula inside the lesion. I'll just go through the images. So you can see the soft tissue component, posterior aspect. So there's a disease on the lateral aspect. So that's one more MRI. So quick question: how many wants to curate and how many wants to excise? Curettage. Okay, sir wants to curettage. 1, 2, 3. Okay, 4. How many wants to excise? Only 1%. I really want to know what other people wants to do. You want to refer the cases, or you don't want to manage, or you don't have any opinion? Okay, sorry, I didn't see, sir. This is for residents. Yes, sir. What do you feel?
As it is recurrence.
Yes, sir.
So, malignant changes is taken. That is one thing is to be.
So we have done a biopsy, reconfirmed. There is no malignant changes. It is still giant cell tumor. So, okay, so most of them agree for curettage. My question to Chandra again, denosumab, no denosumab, you want to give denosumab. And I know that you use liquid nitrogen as adjuvant. So what are the precautions you take when you are giving in type 3, because it can cause thermal damage and the penetration is almost around 5 millimeters. So the vessels will be just beneath the cortex and it can damage the vessel. So what are the precautions you take when you are using liquid nitrogen?
So it's very important to position the patient appropriately. When it is proximal, when it is in the lateral aspect of the femur, I do the case in lateral position. When it is in the medial aspect, supine position, but figure of 4. So that I have a contained cavity where I can pour the liquid nitrogen. There can be small perforations in the posterior cortex. In those cases, I'll put a gel foam there and pour liquid nitrogen.
Okay, so that's why you prefer giving denosumab.
Yeah.
So that you get that cartilage, cortical bone all around, and then you can make a contained cavity and put liquid nitrogen on that. Okay. So in this case, why I want to show this case is having recurrence is not an indication for excision. Recurrent GCT doesn't mean that we need to excise it. It may be a problem of a mistake of a surgeon who might not have done a proper surgery, but all recurrence doesn't mean that patient require excision. So in this case, we went ahead, did an extended curettage. So you can see the bone, the tumor has been removed. So we have done the cementing in this case. So it's been, I think, more than 3.5 years. So patient is doing absolutely fine.
ಫುಲ್ ಸೀದನ್ ಮಾಡಿ ಫುಲ್ ಮಡಿಸ್ಕೊಳ್ಳಿ ಕೆಳಗಡೆ ಕೂರಕ್ಕೆ ಸೀದನ್ ಹಿಂದೆ ಹಿಂದೆ ಸೀದನ್ ಮಾಡಿ ಓಕೆ ಮೇಲ್ ಮಾಡಿ
Okay, so this kind of function you don't get if you do excision. Okay, so the principle of treating recurrent giant cell tumor is same as how you treat a primary giant cell tumor. If you feel that you can save adequate bone for reconstruction, you go for curettage, otherwise it will be excision. So
before you move on to the next question, next case, could you clarify for the residents, when do you decide between using bone cement and bone graft? That is one. When do you decide to put in a plate? Because in one case you put only grafts and you've got away. Follow-up question on that. When you use only grafts, what is the incidence of any collapse or path fracture through the graft and a deformity just below that? And what is your specific indications where a buttress plate or something is required?
okay, so I'll first question is whether bone, cement or sandwich. I am not a sandwich person. Either I use cement or graft. I'll tell the reason. Why means, I prefer bone in most of my patients because I feel biological is better. Because once it unites, it's like a normal bone. There is no restriction. Patient can do everything because all these patients are young patients between 20 to 40 years. And in case if they develop osteoarthritis in their 50s and 60s, we can get away with normal TKR. So the disadvantage with cement is if I do cementing and the patient develops osteoarthritis, either we need to take out the cement, put the graft, let it stabilize and then do normal TKR, or we have to do a mega prosthesis. The other advantage with cement is we can make the patient walk immediately next day. The disadvantage with bone graft is usually I don't make them to put weight for 3 months and then we'll make them walk. Now where to use what? So I personally use bone graft in most of my patients. I use cement only if the patient is elderly, who is in their 60s and 70s, if the joint is good, where I know that I don't have to do a replacement, in that case I'll use. Second, where there is high chance of recurrence. Why? Because this is theoretical, the exothermic reaction can reduce, but more than that for me is to identify the recurrence early. If I put cement, it's easy to identify the recurrence. If I put bone graft, it's very difficult to identify the recurrence in the early stage. So I prefer cement in cases where there is more chance of local recurrence. For example, in Campanacci grade 3, where there's a big soft tissue component and the chance of recurrence is very high, or if there's a pathological fracture where the chance of recurrence is high. And third is when the patient is elderly, like in 50s and 60s with a good joint. But I give both the option to all my patients. There was one young lady who was 26-year-old who had just delivered her baby. She told, I want to walk from next day because I need to take care of my child. So I did cementing in that patient. But as such, I'm a bone person, so I would like to use the bone. What happens if I do sandwich? I am getting the same result with bone graft. If I do sandwich, if the patients develop osteoarthritis, again I need to take out the cement, put the bone and do a regular TKR, otherwise I have to do a mega prosthesis. So that's why I am not a sandwich person, so either I use bone graft or cement. And the next question, what was the question? Stabilization. So usually when I use the bone graft, till now I have not used plates for bone graft. I put it in such a way that it is packed. I use iliac crust and then jam it so that it is quite stable. So in most of the cases I have got away without using plates in bone grafting, and usually I check for the stability and only if it's stable. So still I have not used, but in case if it's not stable I may use it. In cement, in most of the cases I use bone plating. Because if it's a large cavity and there is a window and if you put cement, cement is never going to get incorporated into the bone. So there is always the loosening between the cement and the bone graft. And if you're not using, the cement become loose, and if it's a small cement, it can roll out. So for that reason, we use cement. And for other reason of using cement, plate in cement is because here we are not expecting a normal bone to form and get the full strength. So we need additional stability. So I use plate in large defects where I am using cement. So usually in graft, till now I have not used plate.
Actually, treatment of any bone tumor is one is oncology part, that is to control the local disease, and another
Function.
is the filling up of the cavity of the reconstruction. So can we think of, instead of bone cement, some other bone substitutes which will be absorbed later on?
Sir, what is the problem with the bone substitute is they're never going to give a mechanical strength. And I am achieving mechanical strength with a limited amount of bone which I have. Means you can see that patient was an autograft. I could manage with ilia crust in the fibula. And like how, means we have all bone bank in Bangalore, so we can get the bone bank and use it. So I don't have any experience with the bone substitute. And as I told you, we don't have to fill the whole cavity. Just you need the strength. So you don't need that much amount of all this substance to fill it. Okay, so we'll move on to next case. 23-year-old female. There is a giant cell tumor involving the superior ramine and acetabulum. So my question to Jyoti, what do you want to do?
For confirmed diagnosis.
There is no issue with diagnosis, only management.
So in that case, we can try denosumab.
Okay, only denosumab. Okay, no surgery. Means you are telling definitely? Then surgery. Okay, okay. Chandru, what do you want to do? Okay, no surgery. No, probably no surgery. Okay, Kaushik? Non-surgical. So why non-surgical? What is the issue? What is there?
Young lady who's in her 20s.
Okay.
Surgery will entail removal of partial acetabulum.
See, removing pubis is not the issue
Yes.
here. It's involvement of joint is the issue here. The bone quality is also not good. So I don't want to give her a bad quality of life.
Okay. Anybody for radiation? We know that radiation works in GCT. Anybody for radiation? No? Okay, so we usually don't use the radiation because the first of all, she's a young lady. If you want to give radiation, her ovaries, everything will get affected. And second, there is chance of secondary cancer with radiation, which is even 5%, but those cancers have a very poor prognosis, so we don't give radiation. Usually GCT, in past 10 years, I have seen only one case we are given GCT, radiation in GCT. So radiation, the role of radiation is gradually coming down in the use of GCT. Okay, so the worry here is the compromise of the bone. So Dr. Kaushik and Dr. Chandru doesn't want to operate because if you take out the acetabulum, it becomes unstable and she won't be able to walk. So what we did in this case is, I wanted to operate this case, but if I want to operate and do a curettage, the patient is going to bleed. And I can't use tourniquet here. So either the option is do angioembolization and reduce the vascularity, or give 1 or 2 doses of denosumab, reduce the vascularity, make the tumor little hard and do a curettage. So we gave denosumab 2 doses, same, and we operated. So what I did is, so you can see here, X-ray is the superior ramine where there was a tumor, and done a curettage of the inner wall of the acetabulum, and with the same incision, I have taken the bone graft there and supported the acetabulum. The inner outer cortex of the acetabulum was fine, means towards the hip joint, and put just a screw to stabilize it. Okay, so this is the function of the patient. So this is a function of the patient. Close to 2.5 years. She is
ಅಲ್ಲೇ ನಿಂತ್ಕೊಂಡು ಅದು ಇದು ಮಾಡಿ ಕೆಳಗಡೆ ಕೂತ್ಕೊಂಡಿದ್ದೇವೆ. ಕೆಳಗಡೆ ಕೂತ್ಕೊಂಡು.
So, excellent hip range of movement. It's been more than, I think, 3.5 years. She had a normal delivery and she conceived and she has a baby now. So, the one thing which denosumab was not given, it's for her husband or it's for me? Okay, so the one thing I wanted, I didn't give denosumab was because she was young girl, she wanted to conceive, so denosumab usually is contraindicated in pregnancy. So so that's the reason why we gave, so she's doing absolutely fine. Okay, so we go to next case, 16-year-old GCT of the patella, recurrent giant cell tumor, GCT. So that's a X-ray and that's a MRI. You can see there is a huge lesion involved in the patella. So how many wants to do patelectomy and how many wants to do curettage? If curettage, how you reconstruct? Fast. How many for patelectomy? You want to remove the patella? Okay. How many wants to do curettage? Okay. So rest want to refer. I think there's a good number of people who wants to refer. So I need to start practicing in Kolkata. You have good reference. So, sir, I want to know from your side, like after doing patelectomy, what is the morbidity associated? Is that okay? Is it easy to? We know that it's easy to do a patelectomy, but you have seen the patient after patelectomy. So how do you do? Whether there is a morbidity, any limitation? What is your take on that?
I think Professor Pal will be a better person to answer that, because even during our training days, I think we've done patelectomy on very selective cases. And I think over the last 20 years, I can't recollect, I think only in one case I have had to do a patelectomy. But the key what I had learned during my training in KEM was that you have to reconstruct the quadriceps mechanism properly. Otherwise, you would always end up with some functional extensor lag. But that's not something which is difficult for the patients to accept. But I think previously for patella fractures, patelectomy is still mentioned in the textbook. So your experience probably would be.
He is absolutely correct. That removing the patella will bring the quadriceps more towards the center of rotation. So the compressive force along the knee joint will be greatly increased, and it will eventually result in osteoarthrosis shear. So something is to be done. Here in this case particularly, I want to excise the patella, but some kind of prosthesis or the newer technique is that CAM procedure with a regenerative bone, that is the scaffold, can also be implanted. That is the future. But at present some prosthesis can be used. So that the quadriceps mechanism works away from the central.
Okay. Thank you so much, sir. So in this case, unfortunately, this lady's mother had some head and neck cancer. So they didn't wanted surgery immediately. So I started patient on denosumab. We gave 2 cycles of injection denosumab, and I wanted to do a curettage and save the patella because she is just 16-year-old. And removing patella, we can do it anytime. Even if it recurs later, it's not a morbid surgery to remove the patella. So that's how the approach was done. And you can see after 2 cycles, and the gap was 2 to 3 months, the tumor has become so hard. It's like almost fibrous tissue, which was like a jelly-like material. So literally it took 1.5 to 2 hours to reach that level. It's very difficult for me to make out which is the cartilage, which is the fibrous tissue, which is the normal bone, whether I'm going to perforate the cartilage or not. It really, I was quite patient, took a lot of time. So we could reach that stage after 1.5 hours. Then we have a bone bank. So we use the allograft patella of the patient. So whenever we do amputation, I send my bone to the bone bank. So that's how I could get the patella. So patella was placed in the pouch and we sutured with the threading. So that is, I call it as patella in patella. So that's the stability, intraop stability. So you can see it's quite stable, which around 30 to 40 degrees. was done, and that is the post-op X-ray looks like within the patella, and that is the function of the patient post 6 months. She is just 6 months post-surgery. Sorry, yes, longer follow-up is required, but she doesn't have any extension lag and she is doing absolutely fine. So we will share the longer follow-up when I come next time to Kolkata. Kaushik, let me know when to stop. I can stop. Last case? Okay. So Campanacci grade 3 distal radius lesion. That's the X-ray and MRI for you. That's the X-ray and MRI for you. Quick question, Chandru, what do you want to do? You want to do a curettage? Okay. Kaushik? Resection. Sir, आप क्या करना चाहते हैं? Curettage. Sir, आप?
Yeah, I'd still do offer a curettage first, but I would probably give denosumab this.
Okay. Okay.
It's broken through on the volar side.
Yes,
so
yes.
volar cortex is
Yes.
very, very thin. So chances of tumor spillage is there. I know Kaushik is biased. We are at loggerheads on this. I prefer to retain the joint. And he's trained to do the
arthrodesis.
Yeah.
Okay. See, as such for postgraduates, two things you should know. The giant cell tumor in distal radius are per se aggressive compared to any other GCTs in the body. So the local recurrence rate is a little high in distal radius compared to other part of the body. Second thing what I wanted to mention, I think I forgot, so I'll tell you as soon as I remember. So what we did in this case was curettage was done and bone graft. And second, what I wanted to say is always do biopsy from dorsal aspect and do the surgery from dorsal aspect, because we as orthopedic surgeons are always approached distal radius through the volar aspect for plating. So we love doing it from here, but never do it because there is so much vital structures. If it's get contaminated, the artery, the vein, the tendons, every get affected, and it's difficult to get clearance when we are doing the surgery. So this area, there is nothing, 1 or 2 tendons, even if it's recurrence, we can manage it easily. So always approach from dorsal aspect. So one more case, large case. Sir, you want to do curettage here or excision? I think it's, I've already showed. Okay, sorry.
The recurrence, it is better to do an excision.
Okay.
But I would still, I tend to reconstruct with the fibula.
Okay. Okay. So this case, because you can see that such a large tumor, we know that after doing curettage we won't get adequate bone to save the joint. So we did wide local excision, and what we do is the ulnar translocation and fusing the wrist joint. So we shift the ulna from that area and fuse the wrist joint. That will give a stable joint for the mobility. So that's the function of the patient post surgery. Okay, so this is the criteria which we use for distal radius. As I told, distal radius are more common for local recurrence. So we use this Chang's criteria. If there is more than 50% of the cortex is gone, or soft tissue in 2 planes, or anywhere the articular cartilage is damaged, we do excision because the recurrent rate is quite high. After doing excision, there are 2 options. One, you can take fibula and do arthroplasty and try to save the wrist movement. The other option is shift the ulna to that area and fuse it, getting arthrodesis. So each procedure has its own advantages. I'm not going to talk or debate on it, but I prefer doing arthrodesis and giving a stable joint to have a better function. So these are the options available. The prosthesis doesn't work well in distal radius, so we don't use prosthesis. So either you use fibula and do arthroplasty, or we shift the ulna to that place and do arthrodesis. So let's end it here, Kaushik.
Arthrodesis means ulnar to
Sir, this is a gap. We cut the ulna of same length, move to this area, and plate to radius, ulna, and second metacarpal.
That is my question. Actually, the wrist movement, 50% of the movements are taking place between the intercarpal joints, not in the radiocarpal. So if we can keep that part of the joints free, then 50% of the movement of the wrist can be achieved.
But how to get the hold, sir? How to fix it?
So the arthrodesis of the ulna, that is, it is not centralized, it is not radialization but centralization of the ulna, and then fusing it with the lunate.
With that, you don't get rotations. So here, we get pronation and supination. If you shift the ulna and fuse it to carpal, you don't get
What
rotation.
sir is proposing is that you don't fuse right up to the metacarpal.
Okay.
You just fuse up to the lunate, proximal row of the carpus.
Okay, with one screw to the lunate.
Yeah, one screw in the lunate and one screw in the scaphoid.
Okay.
Because some amount of the wrist flexion which occurs actually occurs at the mid-carpal joint rather than that.
So intercarpal and the carpometacarpal, 50% of the movement.
And can be explored, but
Yes.
we are pretty happy with the results, and most of our patients, I think, I don't know, Dr. Manish Agarwal's patient, there is a statue of Dabbawala in Marine Drive. Dabbawala, I think that is done by a patient who has gone ulnar translocation. So they can do all the fine works, I think, but
Yeah,
this is the
it
field which
is-
we can explore. Actually.
Yeah, actually I have done both. I have done both the translocation as well as the fibular reconstruction. And of course, with the fibular reconstruction, it does not look like a very good cosmetic, and there is little bit of subluxation of the carpus. You get a restriction of pronation, but they get a reasonable range of move. As opposed to the translocation and arthrodesis, they definitely have no flexion extension, but they have got full pronation supination. So obviously it is a balance between what the person wants. So I tend to offer both to the patients and ask them which is the function which they would want, and then take a call on that.
Actually, I don't have any practical experience of my own, but I was thinking like.
Oh, yes, sir. You are correct.
And when the arthrodesis is done, that is for the postgraduates. So the arthrodesis must be done at the degree of dorsiflexion, because the hand function, that is mainly because of number one, the grip strength and also the pinch. Both these functions, that is constitute about 90% of the hand functions. So when it is arthrodesed, wrist is arthrodesed in position of 15-degree dorsiflexion, then the grip strength and the pinch strength is increased. So when you are considering for the wrist arthrodesis, so it must not be in the neutral or in the flexion position. That is important.
Very important. Very important. Fixing dorsiflexion and ulnar deviation. That's the where you get the best grip. So the take-home message today, the residents here, if you are able to identify bone tumor on X-ray and get a diagnosis, and you understand that we have to get an MRI and we have to do a biopsy, that is the aim of this CME is fulfilled. So you understand that much. So giant cell tumor, biopsy is must. You need to get a local imaging. Extended curettage, birth is must. No doing surgery without birth. Adjuvants doesn't have much role. Fill cement versus graft. Yes, cement has theoretical advantage, but it's not much significance. Denizumab, you should know where to use and how to use. It's not. There is no fixed protocol how to use it. Recurrent, same principle as primary. How we are going to manage. Role of adjuvants post surgery. Giving denizumab after surgery, giving zoledronic acid after surgery, or putting the patient on radiation after surgery doesn't have any value, and usually we avoid radiation in these benign conditions. Thank you so much.
Thank you, sir, for this wonderful session. We will be starting our last session for today, the competitive session for residents. Single case presentation by residents. Each of you will be getting a time of 5 minutes with 3 minutes for questioning. Our judges are Dr. Jayanpal and Dr. Anirban Chatterjee. We'll be starting pretty soon. The first presenter, Dr. Parkinson Art.
Sports seat? Where is sports seat?
Good evening, everyone. I am Dr. Parkavian. I am going to present a rare case report of giant cell tubule of distal fibula and preservation of ankle mortise in its management. As we all know, giant cell tumor is intermittently locally aggressive tumor. It occurs in metaphyseal and facial region of the long bones. It most commonly occurs in the distal femur, proximal tibia, or distal radius, or even less commonly distal tibia, proximal humerus, proximal femur, proximal fibula. These are can occur. But GCT in the distal fibula is extremely rare, and it is reported to be less than 1%. So distal fibula is an important component of the ankle mortise. So any pathological lesion or fracture or deformity in the lower end of fibula can lead to unstable ankle and affect the ankle joint function. So lower end of fibula pathological lesion needs to be addressed carefully, not only the primary pathology but also the restoration of the ankle joint. So we report a rare case of grade 2 distal fibula GCT and its management in a young patient. So moving on to our case, 34 years old male came to OPD with a swelling in the right ankle outer aspect for last 2 months and pain for last 1 month and difficulty in walking for past 1 month. No history of trauma, no other comorbidities. And on clinical examination, we found eccentrically located a smooth globular swelling in the outer lateral aspect of the ankle. No scar sinus discharge was there and bony hard inconsistency. Skin over the swelling is free, not adherent, and range of movement is restricted in last 10 degree of dorsiflexion. No distal neurovascular deficit present. So moving on to radiography, and the scarogram shows expansive osteolytic lesion in the epiphyseal metaphyseal of the distal fibula extending into the arterial margins of control bone. So we have procedure with CT scan also to look for any cortical break is there. There was no cortical break in the coronary section or sagittal section, and MRI also shows there is no soft tissue spread. The expansive lytic lesion which no soft tissue normal, and tibia also looks normal. So as biopsy is the gold standard for diagnosis of bone tumors, we proceeded with the J needle biopsy, and biopsy confirmed the GCT. So as we all know, Campanese is grading, which is used for the prognosticating of aggressiveness. So grade 1 is well-defined margins within mature bone cutters, no expansion, and 2 is well-defined margin, no mature bone, moderate expansion, but there will be no cortical break. And grade 3 will be irregular fuzzy margin in distribution rim. Gross expansion will be into the soft tissue will be there after the heart trigger break. So with well-defined margins and without any matured bone rims and no cortical break with moderate expansion, our case will fall under the Campanese grade 2. So how to plan? And we have done chest X-ray also to look for there was no benign metastasis. So how to plan this case? So we plan for intralesional excision by eccentric curettages and adjuvant chemical cauterization with phenol and tricortical reconstruction, fibular reconstruction with tricortical iliac crest bone graft with supportive plate fixation. So under combined anesthesia, when patient in position lateral position after sterile draping, pneumatic tourniquet was applied and over direct posterolateral ocean over the distal fibula. The fibula proximal and distal tumor was osteotomized and tubular tissues were exposed and eccentric curettages started. And we have done the eccentric curettage with a high speed burr. We have removed all the septations. We have used the adjuvant chemical cauterization with phenol. And tricortical iliac bone graft was harvested from there. And the tricortical bone graft was positioned in the excised bone graft. And after pre-contouring the distal fibula anatomical plate, and we have fixed it, and wound was closed in layers. So intraoperative fluoroscopic image after fixation shows there is good fixation of the preserving the ankle mortise with the good clear space. So postoperative protocol for sterile dressing, then the ankle immobilized with Villeneuve slab, specimen sensitive as HPE. So patient was kept in follow-up and advised for non-weight bearing till further advised by doctor till bone graft get incorporated. So this is immediate postoperative X-ray. It shows good fixation. And actually the surgery was done 2 days ago in this Friday. We don't have any follow-up. This patient with this, but we have this literature support where they have shown that after reconstruction with the tricortical fibular graft, after 18 months of follow-up, there was no signs of recurrence and good incorporation of the iliac crest graft are observed, and the stability of the function of the ankle joint also preserved with good range of movement. So coming to our case, in this case we described the management of distal fibula GCT without circularizing the ankle mortise. It's a very rare set of GCT occurs in the treatment. The treatment is often ill-defined and there is no clear guidelines available for us. The salvage of the ankle joint is whenever planned. Maintained of the integrity of the lateral malleus lower further is essential for the stability of ankle mortise. So without reconstruction there will be ankle valgus instability and subsequent arthritis. And Campana described 6 types of fibular resection and advance of intact fibular resection. In our
Time's
case,
out.
we plan for in-block resection of the extended curettage. So conclusion, as distal fibula, GCT is a very rare case where orthopedics poses very challenge to manage. So however, in our case, we used one method of reconstructive surgery with the tricortical iliac bone graft with the distal fibula anatomical plate fixation after complete excision with the extended curettage. These are the reference. So take home would be, so rarity of this case gives so much importance in the discussing the appropriate treatment strategy, and whenever possible preserving the ankle mortise is much advisable, especially in the young patients. And use of adjuvant chemical cauterization external proper curettage prevent the recurrence of GCT. Ankle reconstruction provides stable and vascular time. Thank you.
So the paper is open for discussion. Any question? Any question from the floor? If it is not there, then how you reconstruct the lateral collateral ligament?
No, sir. In our case, the distal tip of the fibula was stable, sir. The ankle joint was already stable. The ligament was not avulsed or something. It was we filled the gap with the tricortical reference.
So second question is, as you have taken the preoperative biopsy.
Yes, sir.
So how the biopsy track was excluded? How the biopsy track was excised?
Oh, we have the procedure with the J needle biopsy, Jamshedi needle biopsy was done, sir.
And then?
We have approached in the same way.
Okay, thank you.
Yes.
The next speaker.
So our next presenter, Dr. Atanu Ganguly.
Yes, sir. Just random shuffling, sir. Just random shuffling, sir. Sir, his name is Atul Ganguly. Yes, sir.
Good afternoon, everybody. I am Dr. Atanu Ganguly, second year resident of Department of Orthopedics, RGCR Medical College and Hospital. Today I am going to present a case report. So, a 46 years female presented with pain around the left hip joint with difficulty in walking since last 6 months. However, there was no history of any trauma in the patient. And we opted for a sciogram of the left hip, which showed an expansile lytic lesion with bony septate involving the metaphyseal region of the left part of the left femur proximal part. Then we, for better assessment of the lesion, we opted for MRI, and the MRI lesion showed a well delineated lytic lesion involving the proximal part of the femur, which was extending to the neck, GT, and the LT. However, there was no expansion of the lesion to the surrounding soft tissue. This is the coronal view. This is the coronal view of the. This is the axial view of the same lesion. And here also we can see that the lesion is just confined to the bone without any soft tissue extension. Then our next plan was for a cone needle biopsy, and the cone needle biopsy showed cavernous spaces, blood-filled spaces without any endothelial lining, and numerous benign giant cells and spindle cells. And the biopsy was confirmed to be a case of aneurysmal bone cyst. Next, our plan of management was we calculated the Mirror score, and it was around 12. And we opted for extended curettage followed by skeletal stabilization with internal fixation. In the intraoperative steps, a large lateral cortical window was created, and extended curettage was done. While performing so, a pathological fracture occurred in the subtrochanteric region, and the fixation was done with a long PA film. Here we can see the immediate post-op sclerogram of the patient. And here is the 1-year follow-up of the patient showing complete recovery. These are some of the clinical pictures of the patient showing complete range of motion of the hip joint. So my take-home message would be extended curettage, that is removal of the disease per se, is the main modality of the treatment for aneurysmal bone cyst. Thank you.
So, question? In the discussion part, question?
You mentioned the middle, sorry.
Paper is open for discussion.
Middle score of 12. So what are the criteria you use for middle score?
Sir, we calculated the location of the tumor. It is part trochanteric, so score of 3. Next, we opted for the size of the tumor, which is around more than 2/3 of the size of the cortex of the diameter of the bone, so it's also 3. Then we opted for the site lower limb, so it is 3, and it's lytic lesion, so 3, total 12.
You're wrong with the middle score. Your criteria are not, it's not the exact middle score what you told. It depends upon the symptom, pain, severity of the pain, location of the lesion, whether it's, what is the character of lesion, whether it's a lytic, osteolytic, or it's a combination, and it is what is the amount of cortex involved. Okay, so based on you are going to calculate the middle score, and also the middle score what you have calculated is wrong.
Any question? So why you have chosen, as it is ABC, then why you have chosen this method? Is there any alternative method?
Yes, sir. Actually, we want to remove the disease per se. So extended curettage was the option to remove the disease completely. And after that, following removal of the disease, recovery will occur on its own if we can provide proper stabilization, skeletal stabilization.
Is there any other recommendation now?
Yeah, intraditional injections can be used. Intraditional or bone graft can also be used in place.
Okay, so thank you. Let us next speaker.
Thank you, Atanu. Can the next presenter, Dr. Dipankar Ghosh, please come on stage?
Good afternoon, my respective sirs, my seniors, and my colleagues. I am Dr. Dipankar Ghosh, first year resident, Department of Orthopedics, Archigor Medical College and Hospital, Kolkata. Today I am going to present a case report. We had a patient, a 5-year-old male child, who was complaining of fast increasing swelling of right leg, that is a proximal tibial area, on March 2021. On examination, there was a local rising of temperature, there was tenderness on touch, and along with venous prominence over the swollen area. Then we had opted for a preoperative or skygram, which shows an expansal eccentric lesion with multiple septations. For better assessment, we opted for an MRI, which shows multiple fluid levels, as we can see in the screen. Then we have opted for a CT carotid biopsy, which was done actually outside and brought by the patient, which showed aneurysmal bone cyst. As we can see on the slide also, there are multiple hemorrhagic sinusoids along with different multiple giant cells present, which is compatible with aneurysmal bone cyst histopathological slide. To confirm the diagnosis, we had sent for a review biopsy and immunohistochemistry, which also confirms that it was a giant cell rich lesion, favors aneurysmal bone cyst. Now, what are the management options for aneurysmal bone cyst? We had option of curettage and bone grafting, then preoperative denosumab injection, then curettage with bone grafting, then combined transarterial embolization and percutaneous sclerotherapy. For this patient, as the tumor size was very big and it was, we opted for percutaneous sclerotherapy. Before that, we had opted for a transarterial embolization. Percutaneous sclerotherapy was done by polytocanal 30 mg per 1 cubic centimeter of volume, and we have followed up the patient at 6-week interval for 5 times, and clinical radiological assessment on 6 weeks interval for first 6 months, and thereafter we followed him up 3 monthly basis. This is his first follow-up skygram after 6 months. This is his next follow-up skygram after 9 months, then after 12 months, and after 18 months. This is post-operative rehabilitation video showing the patient's status, post-operative status. That is after 1 year of follow-up. So the take-home message is transarterial embolization along with percutaneous sclerotherapy is a simple, safe, cost-effective, minimal invasive treatment for ABC with excellent outcome. It is very much important, particularly for deep lesions, challenging access for surgery, and wherever it is very close to potentially damaging vital structures. Thank you, sir.
The panel is now open for discussion.
His physis is damaged, so now
you consider the cyst has healed? Is there
Actually sclerosed.
It is sclerosed, yes. But are you aware of any criteria by which you can quantify whether the cyst has healed or not?
No, sir, I don't.
Five injections were given, no?
Yes.
At what intervals did you give the injections?
Sir, 6 weeks interval.
Every 6 weeks.
Every 6 weeks interval.
At your last follow-up, is there any limb length discrepancy?
No, sir, we haven't noted any limb length discrepancy.
question?
Thank you.
Thank you, Dr. Dipankar. The next presenter, Dr. Kaustubh Chakraborty, would you please come on stage?
Cell tumor of distal ulna treated by wide excision and ulnar support reconstruction. So it is a primary bone neoplasm, generally benign but locally aggressive, osteolytic tumor arising from epiphysis, commonly in young adult, potential for recurrence and pulmonary mets. In our case, a 22 years old female presented with right-sided distal end of ulnar swelling, which is gradually increasing in size. Overlying skin is stretched and shiny, but no engorged veins is there. On gentle palpation, tenderness present with bony consistency, egg cell crackling absent. There was intermittent pain which became persistent and increasing severity. There was also limitation of supination and pronation, mild restriction of palmar flexion, and ulnar deviation was there. No distal neurovascular deficit. So here we can clearly see the stretched and shiny skin overlying the swelling. So this is the restricted supination and pronation movement. So in plain radiographs, we can clearly see epiphyseal metaphyseal expansile lesion, eccentrically situated confined to bone, geographical distribution not extending to articular cartilage, and no cortical break is there, absence of margin of bone sclerosis or punctate calcification, and absence of internuclear bone formation. Then we can go for CT scan. It confirms the integrity of cortex and outlying tumor extent. No subcortical destruction is there. Then we go for MRI. T2-weighted MRI, we can see the expansile lesion of the distal ulna appears white. Then this is the axial cut. Then this is the coronal section of T2-weighted MRI, which we can see interlesional cystic and solid mass. We can go for other investigation there. Hemoglobin was 14.3. Chest X-ray calcium phosphate is normal. Serum alkaline phosphate is 73. T3, T4, TSH is normal. Then we can go for FNHC, which will say giant cell, spindle cell lesion, possibly GCT. So what are the plan of management in this case? Curettage and bone grafting is there. Extended curettage, resection, wide excision, and ulnar support reconstruction, and resection and reconstruction of wrist with fibular head. We can go for resection and ulnar support reconstruction. Then what are the basis of management plan? Those are the articles and journals on which we plan our management. So what are the operative steps? Under brachial block, medial longitudinal incision, we expose the distal ulna, then bony swelling identified and wide local excision done, FCU tendon identified and has been split. By making a drill hole on the distal ulna, we have passed the splitted end and again tied back the tendon to its original position. Then those are the intraoperative pictures. Tumor mass is there. We can clearly see the ipsu tendon after excision. These are the after reconstruction ipsu tendon. These are the pictures, and this is the tumor mass after excision. And this is a demonstration of reconstructive steps. Here we can see the distal end of ulna and ipsu tendon is clearly identified. Then it's splitted down. Then after creating a hole in the distal ulna, the splitted end of the ipsu tendon pass and is tightened. Then the original end is tightened to its original insertion site. This is immediate postoperative X-ray, where we can see the Rombeck suction trend. Then we send for histopathological report after excision. It came as multinucleated osteoclast-like giant cell and spindle to round mononuclear cells. Those are the histopathological slide, giant cell and spindle cell. So postoperative rehabilitation, after 48 hours Rombeck suction trend is removed. Postoperative period was uneventful. Then range of motion exercise started from 2 weeks onwards and follow up 2 weeks, 6 weeks and 12 weeks. TRAP is sent as a tumor marker as it is specific for GCT. Preoperative phase it came as 41. In 5th post-op day it came as 5. This is 3 months follow-up X-ray. This is pain-free near normal supination and pronation present after 3 months. We also did Mayo modified wrist performance score at 3 months, which came as 80. Here we can see the features: pain satisfaction, range of motion, and grip strength. Take home message: locally aggressive tumor, radiological evaluation and blood investigation necessary before planning definitive management. Wide local excision after proper evaluation can give satisfactory result. Or post-operative rehabilitation and follow-up is necessary. Thank you.
For the discussion.
In which area giant cell tumor you want to excise and not to do curettage? What are the sites?
So distal ulna.
The expandable bones where you can just excise it and it's not going to affect the function much.
Yes, yes. Sir, I can say the only one side. Distal ulna.
In proximal fibula, when we excise, we don't do any reconstruction. And these are the sites where we commonly see giant cell tumors.
So how you confirm your diagnosis?
Sir, by preoperatively by FNAC and after postoperatively by histopathology examination. I can.
Histopathology you shown, is it preoperative or postoperative?
No, sir, it is postoperative. After excise the tumor, we confirm that it is a GCT or not. Preoperatively by FNAC, we done, sir.
So FNAC how you do?
Sir, the FNAC with how? Sir,
How you can do FNAC in bone tumor?
Sir is asking if FNAC is valid in bone tumor.
Sir, with experience, I think FNAC is valid because there is also chances of contamination of the tumor tissue periphery, but with proper protection and with proper demarcation line, if we go for FNAC, then we can do FNAC in pre-op period.
Just need to send this message. There is no role of FNAC when it comes to bone tumors. So always do a true cut biopsy. But with FNAC, what happens? You are going to aspirate few cells. To diagnose bone tumor, you need to have a matrix. You need to see whether the cells are invading the normal bone. There are so many other things which we need to do. So at present, we are not doing FNAC for bone and soft tissue tumors. Okay, so and with needle biopsy, I don't know whether you missed the morning talk by Dr. Chandru. So with needle biopsy, the contamination will be very minimal.
Yes,
Needle true cut biopsy, so there won't be much contamination, and that is the standard of procedure in all the cases.
Okay, sir.
Okay, so the next speaker.
Thank you, Dr. Kostov. Our next presenter, Dr. Argo Acharya.
Shall I start? Good evening, sir. I'm going to present a case of light lesion in the calcaneum of a young lady. A 22 years old female came with a complaint of pain and a swelling at the posterolateral aspect of the right ankle, which is present since 9 months. The pain is insidious in onset and progressive in nature, which is aggravated during the walking, and it is relieved on taking some rest. No recent and past significant medical and surgical history. The inspection. On inspection, we find out this is occurred over the posterolateral aspect of the ankle. The mass size, lesion size is 5 into 3.5 centimeter, shape spherical, and the surface is completely smooth, and the skin over the lesion is completely normal. There is a scar present. You can see in the picture. This is due to the biopsy, and no visible pulsation seen over the skin. On palpation finding, we find out the tenderness present, surface completely irregular, edges are completely smooth, consistency firm, and it is non-mobile and non-reducible and non-compressible, and it is non-pulsatile lesion and not fixed or adhered to the skin. The movement of this ankle joint is completely within the normal limit. Then we go for investigation. First we do the X-ray, and the X-ray shows an expansile lytic lesion over the posterior aspect of the posterolateral aspect of the calcaneum. Then I do the CT scan. CT scan also shows that there is an expansile and eccentric lesion over the calcaneum. Then I do the MRI. MRI also shows the fairly marginated expansile lytic lesion which involving the calcaneum posteriorly and its tubercle. The routine blood examination for this patient is completely within the normal limit. Then we do the staging, that is the Campanacci staging, and that is the Campanacci classification grade 2. So the differential diagnosis of this case is intraosseous lipoma, bony cyst or giant cell tumor and infection of the calcaneum. The result of the biopsy, what we take, the needle biopsy, before do anything, result is giant cell tumor. So we do the management, that is the international curettage. The open biopsy, what we talked about earlier, that is done on the 4th December 2020. That is biopsy which is suggestive the giant cell tumor. Then we do the extended curettage of the bone with a high-speed bar and chemical cauterization with the H2O2 and absolute alcohol. And then we fill the cavity with the bone cement. Peroneal tenodosis also done on 2nd January 2021. This is the intraoperative picture. We enter the calcaneum through the L-shaped incision over the lateral aspect of the calcaneum. During the operation, we find out that tumor is adherent to the peroneum longus tendon. So that's why we do the peroneal tenodosis. This is the intraop picture. We expose the joint up to the talocalcaneal joint, and then we just keep the flap away with the help of a K-wire. And then we fill the cavity after the high-speed bar and extended curettage. Then we fill the cavity with the bone cement. This is the post-op picture. This is the histopathological examination finding. The biopsy shows there is a multinucleated giant cell, and also there is a presence of mononuclear stromal cell. That's also indicate that it is a giant cell tumor. The postoperative rehabilitation program, we do the below knee POP application, the non-weight bearing walking with the support for 6 weeks, then toe touch weight bearing with the walker support, and then we start the full weight bearing walking. This is the 2 months follow-up of this case, and then the 1 year follow-up of this case. Patient now able to walk properly and with slight limping. This is the case summary. It's a giant cell tumor which is most common in the female, and also it is occur in the calcaneum, which incident rate is very rare, just 1%. And the treatment of the GCT of the calcaneum bones remains a challenge because there is no clinical and radiographic and histological aspect that allows one to accurately predict the trend of a single lesion to recur or to metastasize.
30 seconds left.
The diagnosis should be done, and this is my take-home message from this case. The early diagnosis is the key of the prognosis. Diagnosis should be done by clinically histopathological examination and also the radiologically. The extended curettage and adjuvant therapy, what we done, it should be done meticulously, and the proper follow-up at the regular interval to look for any recurrence. Thank you.
Paper is open for discussion.
Just the two KYs put for what reason?
For the, we open the joint up to the talocalcaneal, so the skin flap is come during the operation. So that's why I just hold it with the KY. Flap. Otherwise it can be contaminated.
So extended curettage, after that, say, is there any other option, ignoring them, why you have selected for this putting bone cement?
Because you can see, sir, this is a large lesion. So when you remove the extended curettage done, there's a lots of bones are removed. So give the stability, we use the bone cement. And also start the early rehabilitation, because bone cement already said that is give the strength from the next day.
But you have avoided weight bearing.
Yeah, non-weight bearing we just precautiously taken, and then we start early rehabilitation.
The patient is adult.
22 years old. Yeah.
So adult patient, enough of bone graft can be obtainable, autogenous bone graft, even though you do not have any bone facility.
Yes, sir, but we prefer the bone cement first.
Any more question?
Thank you, Dr. Orgo, for your presentation. Our next presenter, Dr. Abhishek Chatterjee, the last presentation for the evening.
Good evening, sir. I am Dr. Abhishek Chatterjee, second year PGT of Medica. So I will be presenting a case of osteolytic lesion in the distal femur. So a 55-year-old male, known case of CKD on medication, not on dialysis, presented to us with complaint of pain and swelling over the medial aspect of the left knee for the last 4 months. There was no history of trauma. Initially, he consulted a local doctor and conservative management was given and then was referred to us for further management. On local examination, there was a swelling on the medial aspect of the left knee joint, approximately of about 4 by 3 centimeter, and there was mild tenderness while doing active and passive range of motion of the knee. There was no neurovascular deficit. The swelling was present on the anteromedial aspect of the left thigh. it was non-fluctuant and the skin was absolutely normal and the swelling was also hard in consistency. On inspection, the knee was in slightly flexed position. There was no sinus or scar, temperature was normal, and the ROM was restricted and painful, and coarse crepitus could be felt while doing the ROM of the joint. So from the initial pre-op X-ray, the differential diagnosis can be made such as tumor, path fracture, or metastasis due to the more than 50 years of age. On X-ray features, we can see a lytic destructive expansile lesion involving the left distal femur. It was eccentric with a narrow zone of transition. It was heterogeneous in nature with a cortical bridge on the medial aspect, and there was also periosteal thickening in the medial aspect with a sclerotic rim. From the X-ray, we can come to the differential diagnosis of non-ossifying fibroma. It can be an infection, it can be a chondroblastoma, a fibrous dysplasia, or a GCT. Further imaging were done. CT scan and MRI can be done. The advantage of CT scan is that it can give a 3D image of the joint, and we can also measure the distance from the articular surface. MRI can give us the idea of the extension of the swelling, the constituency, the intra-articular extension and soft tissue involvement with adjacent marrow infiltration. In MRI, we can see iso-intense lesion in the T1 images and the hyper-intense lesion on the T2 images. And we can see the involvement of the soft tissue of the vastus medialis in the medial side, and there was a cortical breach in the medial and the inferior side. The treatment options to us were to first do a corneal biopsy to establish the tissue diagnosis, then followed by a intralesional curettage with bone grafting, and or we can also do a wide resection with reconstruction with bone graft. And the choice of bone graft in this case will be iliac crest graft. So incisional biopsy was first done, and then we opted for the second stage of extended bone curettage with autologous iliac crest bone grafting and prophylactic plate fixation 3 weeks later after the HP report. So the initial biopsy report, true cut needle biopsy report, it revealed a benign fibrohistiocytic tumor. These are the histopathology slides. Foam cells, spindle cells, and micronucleated giant cells were seen. So we went for the stage 2, we went for the extended curettage. A cortical window was created, soft yellow necrotic tissue found. The tissue was taken out and sent for biopsy, and it was filled with autologous iliac crest bone graft and also with the synthetic G-bone and the Genex bone putty graft. And it was later on fixed with a proximal tibia plate contoured for the distal femur. This is the immediate post-op imaging of the patient. We can see the bone graft in situ with the plate holding the site. The histopathology report of the final specimen, it also favored a diagnosis of benign fibrous histiocytoma. These were the histopathology slides with histiocytes. We can see there, the brown colored, the foamy cell component and the spindle cell of the slides. This was the X-ray of the 3 weeks follow-up. We can see the bone graft being starting to be incorporated. There was no further fracture, and the plate was in situ. This was a 3 months follow-up with an MSTS score of 19 out of 30. And this was a 1 year follow-up with well incorporated bone graft and bony alignment with plate well maintained. And this was a 1 year follow-up of the patient. Patient was able to crouch with slight deformity in the left knee joint. So we can come to a summary that the benign fibrous histiocytoma is a very rare tumor of mesenchymal origin. It was first described in 1958 by Darlin. It comprises of about only 1% of the benign bone tumors. It is more frequent in patients older than 20 years, and it is normally asymptomatic. It has a very benign behavior, and the metastasis is very rare. So early diagnosis is the key to treating the disease. Narrowing down the diagnosis is proper and relevant imaging must be done as soon as possible. Extended curettage and adjuvant therapy is the cornerstone of the disease care, and proper radiopathologic correlation is very important for proper diagnosis of a tumor. Thank you, sir.
So in a patient with CKD, you have missed the 2 important differential diagnoses which you want to keep in mind. What are those DDs?
One will be multiple myeloma.
Myeloma. What is that to do with CK? Okay. CK. Okay, got it. Done. Okay, fine. Next. So what happens in CKD patients?
So the
What are
renal,
the secondary changes which happens in CKD patients?
the calcium and the phosphorus metabolism is altered. There is
So what happens?
calcium gets deposited, and we cannot excrete the calcium. The patient cannot excrete the calcium. It gets deposited in the bone.
So secondary to that,
Yes. So secondary to this altered metabolism, what happens?
What is the condition called?
Hyperparathyroidism can be seen.
Yes. So with hyperparathyroidism, what bone lesions can happen?
Brown tumor.
Yeah, so that should be your diagnosis when you say light lesional CKD. And second, what is one more condition which can happen in CKD patient causing bone change? Chronic CKD patient. Amyloidosis.
Oh,
Amyloidosis. So these should be one of your differential diagnoses. 100%. I don't think infection is a differential diagnosis in this case. Neither in X-ray, nor in even chondroblastoma in a 55-year-old doesn't fit. Non-ossic fibroma, cortical lesion doesn't fit. Fibrous dysplasia doesn't fit. Only little close is GCT. Otherwise, none of your differential diagnosis is going to fit. So just for sake of putting differential diagnosis, you should not put. It should be really close to diagnosis. Then we call it as differential diagnosis. Right?
any more question?
Thank you, Dr. Abhishek.
Thank you.
Okay.
Thank you each and everybody, all the delegates, our faculties from Chennai, Bangalore, and our senior teachers from West Bengal Orthopedic Association. Sincere thanks from Medica Cancer Hospital for participating and making this program, this CME on bone tumor, a successful one. For all the participants, my heartfelt thanks and congratulations. You have performed very well, but as because this is a competitive session, we have to make someone first. That doesn't mean that others have performed poorly. But this is a competitive session, it's a mandatory thing to make someone first. So congratulations and big round of applause for all the participants for coming forward. So sir will just declare, I request Professor Pal sir to declare the results.
As Kaushik already mentioned, almost all the participants presented very nicely, and they are very close to each other. But we have to select one of them, and accordingly, marginally, we have selected Dipankar Ghosh. Okay, so
please come forward.
So, So actually, because so many PGTs are there, so as a teacher, not as an oncologist, so what I suggest that you start to like in a bone tumor, any musculoskeletal tumor, you approach phagic manner. That is, in the first phase, you see clinical pictures of the patient. Okay, so clinical picture, and along with that, the normal, that is the routine blood test, and also the X-ray. This is the first phase approach. And obtaining the information from there, you go to the second phase. And that is nothing but the pre-biopsy phase. So the special investigations, what are indicated, you do in that phase. that may be very extreme, or just CT, MRI, or any other investigation. What is it in the biochemical studies also? Many a time it is required. So special investigation you do, that is the second phase or pre-biopsy phase of approach. And third phase is nothing but the biopsy, because biopsy is the most important issue. So biopsy and treatment, that is the constituting in the third phase. You biopsy, you do the biopsy, and then the treatment, whatever is required. Okay? And in the malignant conditions, the phase 4 investigations or phase 4 study is nothing but the diligent search for the metastasis, in particularly in the malignant conditions. So as you start like that. So phasic manner, you assess the bone tumor and they approach them in that way. So that is advice as a teacher, not as the oncologist. They are there, so they may differ. Allow them to differ, and you will be also, some of you will be also oncologist, and then you will create your own opinion. But now you go like that. Thank you.
I would request all the residents present to please come here and collect your certificate.
नाम लिखे नहीं थे वो, नाम लिखा है।